Good morning, everybody. I think everybody is refreshed by now. People are traveling all far and away to come to Pokhara. First of all, I would like to thank my international delegates and all my national delegates and faculties to be here in this wonderful city of Pokhara. We are here yet again with one of the beautifully organized scientific event where we are here to learn, share, and teach each other about whatever we have done in last 1 year time. And hopefully you enjoy, at the same time learn new things while you are here. Without further delay, I think I would like to start this program. If any issues regarding your stay here, please come to us, we'll try to help you. Thank you.
Thank you, sir. Next, I would like to invite our respected Vice President and Scientific Chair, Professor Anil Shrestha, to highlight our scientific program. Please, sir.
Very good morning, distinguished guests, respected national and international faculties. It's both honor and privilege to have you all here and declare this scientific session open, which we have crafted to include association lectures from different associations across the Asia, plenaries, JLB orations, residence session, award sessions, debates, and some instructional courses that we are starting from this Urocon. I hope this academic meeting will be fruitful and you will enjoy next 2 days with sharing of ideas, experiences, and you'll go back with the beautiful memories of academic feast. I agree that you are not being able to see the beautiful range of mountains in Pokhara, so I hope tomorrow the weather will be clear and you can enjoy the Pokhara city more. By this, I declare the scientific session open, and I request all of you to get engaged with scientific session. I hope you will participate actively, share your ideas, and make this meeting successful. Thank you.
Thank you, sir. Next, let us begin our scientific program with the blessing of Saraswati Mata, the goddess of wisdom and knowledge.
श्वेत पद्मासना
Now we are beginning our scientific session. The first session of our conference is the NOWS International Association lecture session. So it's our cooperation and collaboration among various professional urological societies that expand our urological knowledge and foster our clinical excellence. So to start this session and to conduct this session, I would like to invite our chairpersons. So I would like to invite our president of NOWS, Professor Parasmani Shrestha, sir, to take the chair. Next, I would like to invite our vice president and scientific chair, Professor Anil Shrestha, to take the chair. I would like to request Dr. Suman Sapagai, our general secretary, to chair the session. So I'd like to request our chairs to conduct the session. Sir, please.
Good morning to you, everybody. I think we should start with our video sessions. First one is SUA lecture by Dr. Lee Liu Xiong. He will be giving a talk on UTUCC, is there an optional treatment approach in 2026? He is the president of SUA, and he is head and senior consultant from Sengkang General Hospital, Singapore.
Urocon 2026 organizing chairman, Professor Anil Shrestha, fellow urologists and friends, a very good morning from Singapore. I apologize for not being there in person due to an administrative commitment. I congratulate the organizing committee for a very successful Urocon 2026. This morning, I speak on the topic of upper tract urothelial cancer and how best to treat and manage it. These are my disclosures. There are several issues related to the management of upper tract urothelial cancer. The first being a lack of level 1 evidence as compared to the management of bladder cancer. There is also a challenge in the definitive diagnosis and staging of some patients. The role of systemic therapy is also limited, especially in the neoadjuvant setting. We also discuss some surgical considerations in this presentation. Obtaining tissue diagnosis for UTUC is a good practice. As urologists, we are very familiar with the retrograde access route. This allows us to survey the lower urinary tract. It is also an intuitive access route for us. With the improving technology of flexible ureteroscopy, we can certainly get better reliability in access and in optics and also in tissue yield. And of course, having tissue allows us to ascertain tumor grade and testing for molecular variants where applicable. In parts of Asia where TB is endemic, tissue diagnosis is quite useful to distinguish between a benign and malignant disease. There are challenges related to the retrograde access route. Access is certainly not guaranteed where there is obstruction. Where there is significant hematuria, optics may be affected, thereby reducing the accuracy of diagnosis and also tissue yields. Biopsy yield may be limited given that our biopsy forceps through a flexible ureteroscope is still limited in size, and there is retrospective evidence to show that a high risk of intravesical recurrence may occur after biopsy of an upper tract and placement of a ureteric stent. The percutaneous access route may also be used for tissue diagnosis and can be done in the same setting as in the intent to treat using a percutaneous treatment option. However, this comes with a risk of tumor seeding. You may reduce the risk of antegrade tumor seeding by using a fine needle aspiration cytology technique, but that is associated with a higher non-diagnostic yield rate. It is also not a good or intuitive access route for ureteric lesions. Carcinoma in situ of the upper tract remains challenging for diagnosis. usually still requires a ureteroscopic retrograde access route, good biopsies, and of course, positive urine cytologies. Looking at available evidence, the non-diagnostic biopsy rate using a retrograde access route can range from single-digit percentage points to up to 37%. Of course, we understand that with improvement in flexible URS technology and biopsy equipment, these non-diagnostic rates are likely to reduce. At the same time, when we look at concordance of grade between ureteroscopic biopsies and nephroureterectomy specimens as reference, the concordance rate is quite high. We do appreciate that staging of UTUC is largely image dependent and not so much biopsy reliant. This recent case that we manage highlights the difficulty in obtaining histology. As you can see, this patient has a left-sided pelvic ureteric junction stone. There is difficulty in retrograde access. The tumor has occupied the entire calyx and the parenchyma has thinned out, making percutaneous access or biopsy very challenging. Imaging remains the mainstay for staging in UTUC. Contrast-enhanced CT has the highest sensitivity and specificity. However, they are confounded by the presence of inflammation or obstruction. We know that genital urinary TB is a great mimicker. In those with renal impairment, then we may have to consider MRI urography, which unfortunately is more costly and has less sensitivity than contrast-enhanced CT. FDG PET may be useful for systemic staging, but not so useful for local staging. The EAU and AUA has proposed different risk stratification strategies for patients with UTUC. The EAU risk stratification is more intuitive. It dichotomizes the patient into two groups using clinical criteria of cytology, ureteroscopic biopsy outcomes, CT findings, and histological subtypes. In patients who have a large tumor, multifocal disease, or hydronephrosis, these are relative contributors to high-risk disease. The AUA is slightly more sophisticated and requires more input parameters. We do appreciate that not all variables or datasets of biopsy, cytology, and radiography are available for every patient, and therefore risk stratification in these cases will require clinical expertise and input. Nephron-sparing approaches for UTUC are prerequisite for those who have renal impairment, and one method of nephron-sparing treatment is endoluminal ablation, best suited for patients with unifocal lesions, small lesion size 2 centimeters or less, low-grade disease, and preferably tumors in the renal pelvis or calyx rather than the ureter. Depending on your practice, you may have access to different laser sources. In general, holmium lasers have higher or more efficient ablation rates, while thulium lasers are associated with less bleeding. Gelmito is a reverse thermal gel that has mitomycin C impregnated, and in this Olympus trial, which is a phase 2 single-arm trial, patients were given Gelmito with induction dosing or once a week, followed by maintenance up to 12 months in duration. The gel exists or remains in the upper tract between 4 to 6 hours after installation and can be performed in the clinic using or under local anesthesia. And outcomes from the Olympus trial shows that the 12-month clinical response rate is up to 82%. Patients who received maintenance had higher rates of disease-free survival compared to those who did not complete maintenance. And in general, we can say following ablation and Gelmito, about 50% of them achieve clinical remission with induction alone, while with maintenance at 12 months, about 80 to 90% of them have no disease. Long-term phase 3 data is not known. One advantage of Gelmito has been downstaging of some patients who have unresectable disease at the start. However, Jelmyto is associated with a high rate of ureteric stenosis, up to 44%. The cost of treatment is also very expensive. For example, the cost of induction is $150,000. Another surgical strategy for nephron-sparing surgery is segmental ureteric resection. And this is, of course, feasible only for ureteric lesions, and the ease of reconstruction depends on the length of ureteric defect. So ideal for unifocal disease, but as compared to endoluminal ablation, segmental resection is not generally limited by size of lesion nor locally advanced disease. The various reconstruction options are, of course, related to the length of ureteric defect that occurs after resection. What is the role of lymph node dissection during nephroureterectomy? We do know that the mandatory role of a lymph node dissection is less established in UTUC as compared to bladder cystectomy, and based on retrospective data, lymph node positive rates in UTUC can be up to 30%. We are certain that lymph node metastasis in UTUC is prognostic, and those who have complete lymph node dissection will report a higher cancer-specific survival as compared to patients with an incomplete lymph node dissection. The Japanese have proposed that the template of lymph node dissection in UTUC should be as follows. For a renal pelvis cancer, it should be the ipsilateral hilum and along the ipsilateral great vessel down to the level of the inferior mesenteric artery, while a cancer of the upper ureter will include a similar template down to the aortic bifurcation, while that of a distal ureteric tumor should follow the lymph node dissection template for bladder cystectomy. We have described a totally laparoscopic approach for nephroureterectomy if you do not have access to a robot. And the first step includes using an incision of the ureteric orifice, followed by creation of a sliding knot that allows you to put a noose around the ureteric orifice. This sliding knot is introduced into the cystoscope, and using a ureteric catheter, you can tighten the noose around the ureteric orifice, thereby occluding it. The patient is then flipped over to do a conventional laparoscopic nephroureterectomy. And without changing position, you can go down to the distal ureter and the vesical ureteric junction, as you can see here. And this method allows you to ensure that you can visualize the ureteric orifice during nephroureterectomy without leaving any remnant ureter. As you can see, after dissection, you would see the ureteric orifice and the loop of suture that demarcates the ipsilateral UO. There is data to show that after nephroureterectomy or around nephroureterectomy, a single installation of intravesical chemotherapy reduces the risk of intravesical recurrence. Some considerations will include whether you have easy access to intravesical chemotherapy, a post-op administration. There, of course, is a slight concern about post-operative peritoneal leakage, especially of mitomycin C if the bladder cuff is not closed properly. The overall survival, however, is still dependent on the stage and grade of the UTUC. The role of neoadjuvant therapy before nephroureterectomy is not well established in UTUC. Most data for now has been retrospective, showing a tendency towards overall survival benefits. The data for adjuvant therapy in UTUC is more well established, especially with data from the POKHARA trial, where there is a platinum-based chemotherapy after nephroureterectomy. This has been shown to benefit mainly patients who have advanced disease, T3 and T4 disease, and efficacy is better with a cisplatin-based regime than a carboplatin-based regime. And therefore, this is the limitation of the POKHARA trial, that after losing one kidney, not every patient is eligible for cisplatin-based adjuvant chemotherapy. In a setting where someone is ineligible for platinum-based chemotherapy or has disease that is PD-L1 positive, one may consider the use of adjuvant nivolumab from the CheckMate study. The limitation of this study is that only 20% of patients in this adjuvant study comprise upper tract urothelial cancer patients. Also, there is no overall survival benefit. This data is mainly for disease-free survival. The data for neoadjuvant immuno plus chemotherapy in UTUC is evolving with the use of the durvalumab. In a patient who has UTUC and young, i.e. less than 50 years old, do consider the possibility of a germline mutation in the form of Lynch syndrome. They may certainly present later, and they may have also other tumors in other organ types. The classical MMR protein loss on IHC can be diagnostic, but not routinely reported by pathologists. The diagnosis of Lynch syndrome does not have an impact to therapeutic decision-making, but affects the clinician's decision to counsel the affected patient for cascade testing in his or her next of kin. This is my take on how we can manage a patient with UTUC and concurrent lower tract disease. The first scenario is someone who has locally advanced UTUC and muscle-invasive lower tract disease. We can consider neoadjuvant treatment before local surgery. Where it is not feasible, then it is upfront surgery followed by adjuvant chemotherapy or nivolumab, based on the CheckMate data. In someone with locally advanced UTUC and a non-muscle invasive bladder cancer, do consider treating the lower tract with conventional en bloc resection and followed by nephroureterectomy, being very careful with the bladder cuff such that it will be closed and it can heal properly, and consider post-op adjuvant chemotherapy depending on the T stage of the UTUC. In someone with low-risk upper tract urothelial cancer but a muscle-invasive bladder cancer, consider endoluminal therapy for the upper tract, neoadjuvant for the bladder, and then radical treatment for the lower tract. In someone with low-risk lower tract and low-risk upper tract, then you can go totally endoluminal treatment with a consideration for intravesical chemotherapy in the bladder and intraluminal mitomycin C for the upper urinary tract. So in summary, in 2026, what is likely the best possible treatment for UTUC will be, number one, prompt and precise diagnosis with a combination of clinical evaluation, imaging, and tissue biopsy, using the best flexible ureteroscopic retrograde access route for tissue biopsy and also for endoluminal ablation where relevant. Consider the use of radical treatment and lymph node dissection where the patient has locally advanced or high-risk disease. in patients who have low risk or small lesions, consider nephron sparing with endoluminal ablation. The role of systemic therapy is becoming more established, especially in the adjuvant setting. In the neoadjuvant setting, we await further data from IO chemo trials. So, ladies and gentlemen and friends, thank you very much for your attention. We invite you to Eurofair in Singapore in July 2026. And if you're in town, I would really like to meet up with you. Take care and have a great morning ahead.
Thank you, Professor Lee Xiong. We move on to next presentation for the morning. It will be a UA lecture by our very good friend Anthony. Anthony is Professor of Surgery in Chinese University at Hong Kong, and he's also a founding chairman of Asian Urological Surgery Training and Educational Group. It's very well known as a OSTEC group. Over to you, Anthony.
Good morning. Thank you for the kind introduction, and thank you for the invitation to me to come to this beautiful POKHARA to share with you about the UAE lecture. So today my topic will be on the current development of robotic surgery. But before we go into the topic, let me just update you about the annual event, our UAA meeting. So for the UAA meeting this year, we will be on the 3rd to 6th of September this year. We'll be in Philippines. And as usual, we will have a very fruitful program, including both regional and also international speakers to deliver the most up-to-date knowledge about the development in urology. And besides the official program, we also had before the program, we also had the usual Asian urological residency course, which will including some of the young trainee or residency in our whole Asia to join together to learn something new from both speakers from regional and also from the AUA, and also they will have some mingling. Hopefully, their networking will help to build the future urology in Asia. And this time, we also had a new program called the Young Leadership Forum, which will be a collaboration with the EAU. And for this program, it will be something in between the residency course and the full program. That will be for those young fellows, and they are looking for their opportunity or looking for their way for development. So this Young Leadership Program will help them to shape their pathway in future. And also beside the program for the doctors, we will also have a program for the nurses. And this will be conjoined with the Asian Urological Nursing Association and the Urological Nursing Association of the Philippines. Therefore, we hope we can see all of you in the meeting and also with some of the young residency and also the nurses in this UA meeting this year in September. So after this, I will also go back to my lecture, and this is my disclosure. So when we talk about the recent development in robotic surgery, what will be something that we expected? So I will try to summarize them into different three ways. Will be the local system that we have, and also what are the local application of robotic surgery in urology, and also what are the new local ideas in the use of robot in our clinical management. So first, let's look at the local system. And I think the big brother, the intuitive system, is keep continuing evolving just like the Iron Man. And therefore, from the original design, and then they will have the SI, XI model, and now they also have the SP model available in some of the market. And besides that, they also have the new Gen 5 robotic system coming up. And for this new Gen 5 system, I think one of the main important things will be the so-called force feedback. It's not exactly a tactile feedback, but at least it will give you some sense of what are the force you need to do for the procedure or for each of the steps. Therefore, it gives you some sense of force feedback, and hopefully this will give you some sense of tactile feedback during your procedures. And besides the Da Vinci system, also there will be other new systems, in particular even in those superhero, they also divided into 4. Therefore, for the Hugo system, it's one of the new systems that are available. And instead of having the 4 arms put together in one system, they separate them into different modular systems so that it will be more mobile in the operating theater. You can move them around different theater, and also you can try to position the port in different different procedure due to the different body build of the patient or different procedure you want to do for the patient. And besides this, we also have the virtual system, which is developed from the UK system. It's also a modular system, and the robotic arm is more like the laparoscopic instrument, and the control of the arm is a bit different from the other system. And this is also being used in some of the centers. And besides seeing those development of the new robot in the US and also in Europe, in fact, we see that there's a booming of system in the Asian. We have the Korean system, the Revo Eye system available, and in Japan they also had this Hinotori system, which is also like the all-in-one system with 4 arms available for the procedures. And in China, there are also multiple robotic systems have been coming out, like the Edges, the Medbot, and also Kandu, and they can have both a single arm system and also a standard all-in-one system with also single port system available in the China market. And nearby in India, they also has a SSI mentor system, also a modular system can be mobile in different areas. And even in our local Hong Kong, we also have our own robotic system developed in this area. Therefore, I can see that compared to the past 10 or 20 years ago, robots are only coming out from the European or US market. But now we have many new systems available in our region that can help the further development of robotic surgery in our region. So what we can learn from this kind of robotic system, I think we can learn 2 things. One is the convergency and also the divergency. I think after many new robots have been developed, I think the one thing that have been actually get converged is the interface. And I think now, although we have different systems, but the interface of the control system are more or less similar. The arm are more or less using the finger to control the movement of the instrument, and also the pedals are more or less standard. And I think this is just like we are driving a car. No matter you are a petroleum car, electric car, local car, or from a European country car, they're all having the same interface. Therefore, it will be facilitating the surgeon to change into different systems, and you don't need to spend time to refresh your skill in different robotic systems. And this is one thing good for us. And also, I can see the divergency now. We have the all-in-one system that have a multi-port system, single-port system, but we also have those modular systems. But in fact, is this that all either you can go to all-in-one system or the modular system? In fact, we have also some new system that you can combine 2 things together. You have 4 arms from the all-in-one system, and then you can add on extra arm from the modular system too, so that you have 5 arms under your control. I think this will be something new that we can expand further with one surgeon can controlling 3 arms and both controlling the robot, the retraction, dissection, or even the suction by himself. How about the use of robotic system and some new application? All around the past 20 or 30 years, we talk about robotic system, we talk about the use of robotic system to replacing laparoscopic surgery. How about in the endoscopic space? In fact, robotic RRS is one of the areas that have a robotic system already developed. And the first robotic RRS system is developed in the US in the South California, and at that time it's more than almost 20 years ago. At that time was quite a clumsy system which led to using the specific designed RRS endoscope. But over the years, many new systems have been developed, including the Turkey system, the French system, ED system, and also even in China, in Korea, they also have a robotic system developed. And we are also using one of the robotic systems, the ED system, in our center to do an RCT to compare the use of robotic system with the use of men's health RRS. You can see that the surgeon is much more simple, using just a PlayStation-like control platform to controlling the system, and also she can easily either sit down or even stand away from the radiation field to do the procedures. And the scope was quite easy to use, and you can find the stone, and then you can trigger the laser system to fragment the stone. And from the data, we can see that the use of this robotic system can help to improving the ergonomics of the surgeon, and you can, and in particular for the hand and the finger, the thumb, you don't need to hold the robotic, urothroscopy during the whole procedure. That will help to improving your, decrease the tiredness and also improving the ergonomics for the patient. But we are still looking for the data to support whether the use of this robotic system can really help to improving the surgical outcome of the patient. How about in the transuretral surgical field? And aquablation system is one of the so-called robotic system. In fact, you can plan your resection margin by the use of the pre-op ultrasound imaging, and then the robot will using the water jet to create remove the positive tissue during the procedure. But still, it's more just using the robot to control the water jet and not really what we're expecting from a robotic system. In better surgery, in the past, we're using TURBT to remove the tumor, but my good colleague, Dr. Jeremy Thiel, had promoting the use of this on-board resection of the whole tumor fragment in order to decreasing the fragmentation of the tumor and hopefully decreasing the settling of the tumor and improving the recurrency rate. How about we can develop a robot that can perform the procedure inside the bladder? This is a robot system that we have developed in Hong Kong. It's using a 3mm robotic arm. It's the Agilis robotic system. And the good thing is that it can perform the whole robotic TURBT within the usual endoscopic system. We are just using the usual Olympus endoscope, and we can put in this 3mm robotic arm into the bladder, and you can recheck the tissue that we want to remove and do the whole procedure endoscopically. The good thing with the resection, we can easily define the lower part of the tumor, and we can easily dissect the whole tumor from the base and without any complication. Another similar system is the virtuoso system developed by the US, and this can, instead of using a flexible arm, is using two very thin, around 1 mm size robotic arm also with a forceps, and also using the laser system for the resection of tumor. And basically, the principle will be the same. After you inside the edge of the tumor, then you can using the resection to reject the tumor, the surface, and then using the laser to dissect the lesion. So therefore, and with the past experience in the development of a laparoscopic robot, and I'm looking forward to using more and more this kind of robotic system in endoscopic area, which our urologists we are more also working a lot in the endoscopic for stone or for tumor surgery. How about another overall idea in the use of robotic system? In fact, are we really satisfied with what we have currently, our robotic system, which need to be connected with the wire connected to the console, and also the robot actually is just performing the procedure you want to do. It's more a master and servant system, not really automate in the performance. So we're really looking forward will be something that really wireless, and in fact the using of wireless or telesurgery is in fact one of the initial idea of developing robotic system, because in the past when robot was first developed in US, there is actually is a more military design, and hopefully we don't need to send the surgeon to the war field to do the surgery for the patient, for the army, and also even in the future in the spaceship we can using the robot to perform the surgery for the spaceman. And in fact, telesurgery is not something new, and in the more than 25 years ago, the transatlantic surgery performing the robotic laparoscopic cholecystectomy from French to US, from New York is also feasible, have been demonstrated. But so far, we have never demonstrated whether this telesurgery can be helpful, really benefiting a patient, really it can provide the same outcome as robotic surgery performed locally. Until recently, there's an RCT performed by the China group, and using a robotic system to perform telesurgery to 4 different sites from Beijing within China to see whether compare the result of the robotic telesurgery performed procedure compared with locally performed robotic surgery, what the common outcome. And besides having the good robotic system, certainly you need to have a good network support. Therefore, the 5G system in China have really supporting this telesurgery trial performed in the mainland. It is a RCT comparing the use of the robotic system for the robotic prostatectomy and also partial nephrectomy. And the trial, eventually there's from 30 patients in each arm, and from that result it has demonstrated the operating time for either the locally performed robotic surgery and the telesurgery was quite comparable. The blood loss and also one ischemic time for the kidney surgery part is quite comparable. And for the EPICS 26, which is the assessment of the clinical outcome of patients after prostatectomy, the two arms was also showing comparable results. Therefore, by this study, you can see that the use of robotic system in telesurgery can really performing the same outcome at those surgery performed locally by the surgeon. And but certainly, it really not easily replicable, because you really need to have a very good support about the network system so that the signal delay and signal transfer will be quite smooth during the whole procedure in order to maintain the safety of the procedure for the patient. How about automation? In fact, we really want the robot can perform the procedure by themselves. When we talk about automation, in fact, nowadays, most of our robotic system actually is only at the level 0. That means it's totally controlled by the surgeon rather than performing the procedure by the robot itself. Starting from level 1, if you can, some of the procedure can be decided by the robot can assist the surgeon in some of the procedures, to level 3 where the procedure can be semi-automated by the surgeon, by the robot, and then the surgeon just confirming the procedure, and up to level 5 will be totally automated by the patient or by the robot. And in fact, the Monarch system from the J&J has, instead that it had already has some automated actions, such as the size detection of the stone, laser setting, and also control of the respiration during the procedure. And we are looking forward for the result of this automated robotic system in our clinical usage. And our center is also working closely with our engineer team to try to perform some automated procedure for the stone disease. And this is our automation. You can see that the robot can detect the stone, and then once the stone was not in the target field, it can automatically control the laser fiber back to the stone area to perform the procedure. And just a few days ago, we have performed the first in-human trial for this automated robotic procedure. You can see the surgeon is not holding the control arm, and all the thing is controlled by the robot to move the laser fiber to target on the stone. And hopefully this will be something we look forward in the future. So in conclusion, I think in the past 5 to 10 years, we have seen the rapid advancement of technology, and which have helped to improve promote the growth of the robotic surgery in our field. And besides the traditional robotic platform for laparoscopic surgery, we also see the new robot emerging in the endoscopic field. And hopefully it will be something we will booming again in the future. And also with the further development in technology, network, artificial intelligence, we are looking forward for the era of the telemedicine, automated surgery in the coming future, which can help to improving our patient care and also the surgical outcome in the near future. And thank you again for your invitation, and look forward to see all of you in the UA meeting this year. Thank you.
Thank you, Professor Anthony, for your excellent deliberation. So as we do not have a question answer during our association lectures, so there must be so many questions in everybody's mind, so we can do that during our networking period. So without doing much delay, I would like to welcome Professor Dr. Uttam Methi. He is going to present a USI lecture from the Urological Society of India. He will be talking on locally advanced prostate cancer, intensified approaches and surgery.
Good morning, everybody. First of all, I would like to sincerely thank the NAUSH, and special thanks Dr. Paras, Dr. Suman, and of course Dr. Anil, and the whole team for inviting me for this nice program in POKHARA. And all of you are invited for the next Urocon to be held in Lucknow in 2027, well in ahead. Okay, so I don't know whether my title is okay or not, whether we have understood the title or not. The thing is, locally advanced prostate cancer, intensified approaches with surgery. As you all know, that whenever you treat a patient of prostate cancer, usually you have a localized disease or a metastatic disease. For a local disease, you have a local therapy. For a metastatic disease, you have a systemic therapy. But there are a group of patients who are in between, that is the locally advanced. That means they have localized disease as well as micrometastatic disease. And that's why you need to take care of both. So only local therapy is not going to control. That means you need to add something, and that is the topic for my discussion today. What sort of intensification you are going to do? Now, as you all know, the locally advanced prostate cancer is actually, there is a lot of controversy rather than consensus. Where are the controversy? Controversy starts with definition itself. There is no uniformity in the definition if you go to the past literature. So if you go across the literatures in the past, they have used several stuff. But now we usually follow EAU, and it is a little bit uniform now. What are the treatment goals? Treatment goals, just like localized prostate cancer, the treatment goal is curative, but problem with this treatment is recurrence, morbidity, and mortality. So that's why you need to have a multimodal treatment. In a multimodal treatment, there will be one primary treatment and the secondary treatment. The primary treatment either will be radiotherapy based, or you start with radiotherapy and followed by other treatment, and or it can be a surgery based, and then surgery with neoadjuvant or adjuvant therapy. Now another problem or controversy has been added by the addition of PSMA PET CT, because your definition, see what I'm talking about, this is about 15 to 20% of the patients they present with locally advanced prostate cancer. And if you see the EAU guideline, it says it grouped together the T3, T4 and node positive disease, irrespective or regardless of the ISUP grade and PSA. That is very unfair, because you have to re-stratify these patients. Few patients with a high grade disease, few patients with a high PSA level, they will not behave similarly as the patients with low grade and low PSA level, and the node positive and node negative patients, they behave differently. So my intention is to tell that even if they are grouped all together, they need to be reclassified or re-stratified. So how do I reclassify for your day-to-day practice? First of all, a patient has come with node positive disease on imaging. This on imaging, if it is a node positive disease, then it is definitely a high risk. If it is a node negative disease, still some features in the primer, some features in this biopsy that will tell us, or the PSA that will tell us the high risk. That means those are the patients who needs intensification. Second thing is, if you have taken surgery as the primary therapy, and after surgery you have the pathology, then again re-stratify again those patients. So pathologically, they may have a node positive disease, or they may have a high risk features, 2 out of 3, that is that pathological T3, T4, pathological GG4, 5, or PSA more than 4, they should be graded to differently. That's what I was just telling. There is a controversy about the definitions. So regardless of all the definitions, I think we should follow this EAU guideline, and these patients are divided into 2 groups, either CT3-4 disease or a node positive disease. Now if you see, the T3 or T stage is done by your digital rectal finger, a digital rectal examination. But is that accurate? Definitely not. We usually go for MRI. The MRI only stays about the digital rectal findings. But if you add the PSMA, what will happen? Now it has been found that the GG4 plus 4, it will be downregulated in around 60% of patients. Clinical T3 can be downregulated by T2 by 29% of patients. And even in PSMA PET, they say the negative nodes, 25% of the patients can have pathologically positive nodes. So these are the controversies. That's why when you are treating a patient of locally advanced disease, these things you have to keep it in your mind. Now, what options are available? Either it may be ERBT or RP or intensification. So what we are going to gain, I'll come later on. So what is the treatment recommendations? Treatment recommendation as per the guideline is, as per RCT, the radiotherapy with 3 years of ADT, and that may include 2 years of abiraterone, depending on the destratification which I was talking. But surgery is also mentioned, but it is not guideline recommendations. Now, what we know about the RT? Now, radiotherapy can be given as a primary therapy, or it may be given as a secondary therapy. Now, what are the benefits if I give as a primary therapy? And it has been found that the MFS benefit will be there if we add, in addition to ARBT with ADT plus ARPI, the MFS benefit will be from 69% versus 82%. Now, how ARP has been added based on few trials. What are the trials? That is a Stampede trial. Based on that, so Q for ERBT, radiotherapy plus abiraterone. Now those trials are also going on, Engerard and Atlas trial. They are telling rather than abiraterone, you go for enzalutamide and apalutamide, and the results are awaited. So what I am telling, radiotherapy alone cannot give a good oncological outcome. You have to add something, that is ADT or ADT plus ARPI, and which ARPI you are going to give depending on the others. So what are the older trials says? Older trials says the SPCG7 and URTC, these trials says that if you give only ADT, this ERBT, along with short-term ADT, the results are not good. So that's why the treatment is, you have to go for long-term ADT. Now, what about the ART in the new adjuvant setup? In the adjuvant setup, it can be given as ART or SRT. Now, these controversies goes on, but the three landmark trials, that's the Radicals RT, REVS, and JETAG AU47, AFU17, as well as this meta-analysis, they says that SRT is as good as ART, so but without the side effects of ART. So that's why you should better go for ART. Now the question is, we are the surgeon. Why don't you like the RT? Is it less effective? It is toxic? There is chances of developing a second cancer and hard to perform surgery after RT. These are the reasons. Not only that, anyway you need ADT with its side effects. So that's why you should go for a surgery. So next question is the surgery better than radiotherapy? If you see if you go for a surgery also, at the end of 10 years, giving secondary therapy is about 65% of the patients. I mean, 2/3 of the patients will require another therapy. And at the end of 10 years, 1/3 of the patients will already have developed metastasis. So therefore, you have to see whether surgery is better or radiotherapy is better. In that case, how to choose between the radiotherapy and RP. The only trial which can give us this answer is SPG15, which is going on. That is the Scandinavian trial. Now see how surgery is difficult in these sort of patients. Can I have this slide? Okay. So the surgery in a locally advanced prostate cancer is definitely difficult. And you know, normally, I have seen in the PIP form, if it is a localized disease, the surgery is easier. In the locally advanced cases, you don't have the plane. And not only that, you cannot think of nurse-sparing surgery. You can see in a locally advanced disease, the planes are so ill-defined. And especially if you give hormone therapy as an adjuvant therapy, then it will be like this. And you have to go always for extrafacial, and we call it a wide RARP. Wide RARP means you have to remove the prostate along with all surrounding tissue. That includes the perirectal fat also. Otherwise, it is going to be a margin positivity. Because the risk or what is of concern for the surgeon is having a margin positivity or a residual disease. So for that, you need to have a wide excision, and that part is really difficult, whether it is a posterior dissection or a lateral dissection or whatever dissection you go for it, unless and until you are very experienced, you might injure other stuff. And then I think we can stop this. Okay. So that's what I was telling. So it is also not rosy. If you go for, if you are a surgeon, you want to go for a radical surgery, it is not okay. Now, what are the outcome measures you look for after radical prostatectomy? That is a perioperative outcome. I will go one by one. What was the perioperative outcome? So definitely if you compare the OT time, blood loss, hospital stay and complications, there will be more compared to if I go for a radical prostatectomy in a patients with localized disease. What was the pathological outcome? Definitely positive surgical margin, it will be to the tune of 50% of the patients will have positive surgical margin. And not only the stage migration, it has also been found that clinically it was locally advanced. 1/3 of the patient may have that specimen confined disease and they may not require any other additional therapy. What additional therapy you are worried about is ADT with the side effects. So if you can at least avoid ADT for those 30% of the patients, that will be beneficial to the patient. So that's why surgery has got a role. Now what about the oncological outcome? We are worried about 3 major oncological outcome. One is biochemical recurrence-free survival, metastasis-free survival, and overall survival. And it has been found most of the time, if you do only surgery, they will not give much of a benefit. So you need some additional therapy. And functional outcome, definitely continence and sexual dysfunction will be poorer compared to if you go for a radical prostatectomy in a localized disease. Now let us see. In RARP for a locally advanced disease, the lymph node dissection is part and parcel. Without that, you cannot go for surgery in a patient of locally advanced prostate cancer. And what should be the extent? It should always be extended lymph node dissection. That means you have to remove the external iliac, obturator, internal iliac, and the common iliac nodes up to the crossing of the ureter. And as you go for a lymph node dissection, it has its own complications. Now let us see what are the outcome of the surgery if you do surgery alone. If you go for a surgery alone, the outcome is not as good as or maybe equivalent to radiotherapy. Now what about the BCR? You say that if a localized prostate cancer go for a surgery, 1/3 of the patient will develop BCR at the end of 5 years. If you go for locally advanced, 50% of the patients will develop BCR. That means you need some, what I am telling by all this data, what I am trying to tell that only surgery for a locally advanced disease is not going to improve. You need to intensify with the therapy. I'll just go quickly because time is running short. So ultimately, the summary of those series what I have presented is that overall survival is about 75% at the end of 10 years, and CSS is about 60% at the end of 15 years. So that's why we need to go, or you need to add something with this surgery, that is the neoadjuvant or in the adjuvant setting. What is the goal of neoadjuvant therapy? Is you can downstage the disease, and it can decrease the surgical margin. And not only that, you can have an opportunity to delay the systemic therapy. That is the main advantage for giving a neoadjuvant therapy. Now, if you are planning for a neoadjuvant therapy, what are the options available? It can be a hormonal therapy. Hormonal therapy may be only ADT, ADT plus ARPI, or ADT plus ARPI plus ARPI. Now go one by one. If you give only ADT, it has been found, so what are the benefits? That's what I was telling. What are the outcome measures? The pathological outcome will be better. That means you will be very happy that your margin is negative, your tumor has shrunken, and that is good enough for the immediate counseling of the patient. But at the end of 10 years, most probably it is not going to give any survival benefit. That's why you need to add something along with ADT. That means it can be an ARPI, and what sort of ARPI you are going to add? As per the Stampede trial, it will be either abiraterone or Atlas and Angela trial, that is for radiotherapy. You go for apalutamide as well as enzalutamide. What about the chemohormonal therapy? Chemohormonal therapy, does it give any benefit? There are so many studies available for chemohormonal therapy. For the PUNCH trial, it had given ADT plus docetaxel before surgery, and they had found, yes, there is pathological outcome better, but the survival outcome is not good. And then, I think I'll just go quickly. So, what is the summary of benefit following neoadjuvant AD therapy? Pathologically, it has improved, but no survival advantage. So, the two trials I would like to maintain what is going on. That is the second one is the Proteus trial. That is the phase 3 trial which is going on. What they are going to do is ADT plus apalutamide versus ADT plus placebo, 6 month pre and post RP, radical prostatectomy, and we are waiting for the results. That is the design for the Proteus trial, and most probably it is going to tell us whether the addition of ADT plus apalutamide is going to give a better outcome in terms of oncological outcome or not. What are the main studies for the neoadjuvant chemotherapy? I think I don't have the time to tell all these trials. What is the chemohormonal therapy? Only trial which gives us some idea about this chemohormonal therapy outcome is the CALGB trial, and it shows what is the benefit if you give 6 cycles of docetaxel per ADT before radiotherapy, before surgery. It gives a survival advantage only 4%. So the toxicity is more. That's why nobody is going for any sort of chemotherapy before surgery. And this is the graphical representation of the CALGB trial. And then the question is, why should we go for neoadjuvant therapy for all patients? Can we re-stratify these patients based on their molecular features or genomic features? That is what is going on by the GANS trial. What is the GANS trial? GANS trial says, okay, you have the biopsy, you go re-stratify based on your genomic profile, and the patients who has got those marker, you go for LHRH analog plus apalutamide plus docetaxel. On the other hand, if the patient has got P10 deletions or RB deletions or P53 mutation, you go with docetaxel. If you have a DDA alteration, you go for a PARP inhibitor. If you have MMR alteration, you go for PD-L1 inhibitor. That is how the GANS trial is going on. That means you highly select your patients where and what sort of neoadjuvant therapy you are going to go. And in addition, people are trying to go for radioligand therapy, which is usually used for CRPC patients, but it can be used for before surgery as a neoadjuvant therapy. And the recent trial which is going on, that is the Nautilus trial, that is the neoadjuvant theranostic lutetium therapy. You are giving before surgery the lutetium PSMA and see what is the outcome, whether it has got a benefit in terms of survival as well as the surgical outcome. And another trial is going on is the PD-L1 inhibitor. As you all know, the prostate cancers are immunologically inert, but some prostate cancers are immunologically very active, and if you add them, if you identify them and go for enoblituzumab for 6 weeks before surgery, most probably it is going to give us better result. So what is the summary of neoadjuvant therapy? Is most probably it is going to give us say better cytoreduction, better microscopic node detection, as well as it is going to give a better outcome in the terms of biochemical recurrence-free survival, MFS and OS. What about the after prostatectomy? That is the most controversial stuff. The most of the time we go for, just take 1 minute. We go for SRT rather than ART, and which I have already told this. So what is the future direction? Future direction is precision-based approach. That means you don't give the same therapy to everybody. So So what is the so this is the conclusion slide. So a patient with locally advanced prostate cancer, you go for ERBT plus ADT for 3 years, and you add 2 years of abiraterone if there are features of high risk. And if you have gone for a surgery, then if node positive, you go for adjuvant ADT. If you are node positive plus there is high risk features, you go for ART also. In other patients, you go for observation. If the patient develops recurrence, you go for SRT or systemic therapy. So conclude that locally advanced prostate cancer has a lethal potential, and the high level data supporting the surgery is lacking, but still surgery can be taken as a primary therapy, but you need to intensify your therapy with a systemic therapy that is in the neoadjuvant and adjuvant setting. I think time is up. So I think the message what I'm to give for the locally advanced prostate cancer, you can have multimodal therapy, either radiotherapy based or surgery based. If you are going for a surgery based, you have to intensify your therapy by neoadjuvant therapy. There are 5 categories of drugs are available which you can use for in a neoadjuvant setting. And thank you very much.
Thank you, Dr. Thank you so much. So we will be calling upon our next lecture from Malaysian Urological Association, Dr. Noor Asani Muhammad Yusuf. He'll be giving a talk on robot-assisted laparoscopic RPLND for advanced testicular tumors of 5 years Malaysian experience. Dr. Noor is Senior Consultant Urologist and Head of Urology Hospital, Kuala Lumpur, Malaysia, and he is President of MUA of the current tenure. Please, Dr. Noor.
Thank you, Dr. Faraj. Bismillahirrahmanirrahim. Very good morning to everybody. First of all, I would like to thank the NAUS for inviting us again to come to this wonderful city, POKHARA. I've traveled a lot yesterday to look for the beauty of the city and learn about the history of the POKHARA. Thank you very much. I would like to talk, my topic is about robotic-assisted laparoscopic RPLND in testicular tumor. This is a 5 years experience that we had in Malaysia. I hope that our experience will help and motivate people around the region to do a similar thing. So I have nothing disclaimer. I just have a dream that I can do something better for our patient, so that they can go back to their own normality as soon as possible. So as we know, that testicular cancer management is depend on the cancer stage. We know about this. And unfortunately, some of the cancer that come to us at the late stage, not the early cancer. So that's the problem that we are facing at the moment. And all of us know about this staging, that we tend to use the EAU staging. So most of our patients in Malaysia now actually come at the stage 2 and 3, which requires certain more than just orchidectomy. So that's the situation that we are facing in Malaysia now. And this tumor unfortunately happen in very young men, that will have impact to their quality of life and their livelihood. So this is the thing that I'll try to minimize the impact to their livelihood as far as possible. And the survival, actually we know that those patients with even that advanced disease involving the lymph node, the survival rate is still is good. Unfortunately, the management is more challenging and technically difficult. This is an example of one of my patients. This is basically the artist in Malaysia. He was diagnosed at early cancer with the earlier presentation. Orchidectomy alone is good enough actually to cure him from the cancer. So, but unfortunately, some of the patients actually presented late. One men, because this involves our genital organ, and men tend to wait longer before they even visited the doctors. But unfortunately, sometimes this particular patient is seen by the 3 doctors in the general practitioner and treated as orchitis. And unfortunately, he subsequently presented with back pain and found to have basically metastatic disease and was given chemotherapy. So in this particular patient, we end up that had to do more than just orchidectomy. In Malaysia, we don't practice a primary retroperitoneal lymph node dissection. Most likely, most of the 100% of patients actually we done it after post-chemotherapy. And we know that chemotherapy actually have an impact to those patients with testicular tumor, even they survive long. And the impact of this chemotherapy can last more, even after 30 years. So this is one, if we can able to do retroperitoneal lymph node dissection, we can avoid all these complication, long-term complication. So this is the indication of retroperitoneal lymph node dissection for the non-seminators in the primary setting, what we are not practicing it, but some actually for residual tumor. For non-semimatous, for tumor more than residual tumor more than 1 centimeter, for the seminoma more than 3 centimeter with the avid PET scan. So now, because the excellence of the survivor, we need to focus now in terms of the reducing the toxicity. So, is there a role of the lymph node dissection? Yes, definitely. There is a role of retroperitoneal lymph node dissection. It gives a precise assessment of lymph node involvement, guiding personalized treatment strategy. It's not otherwise the patient may end up going for the second line chemotherapy with all the complications. And also he has some demonstrated therapeutic value, improve oncological outcome, and improve also survival rate. So in the previously before 2020 in Malaysia, actually most of us doing the open surgery with very long scar, high morbidity, and most of the time the patient actually refuse to go for surgery, and the oncologist also will not actually refer to us earlier. We end up doing the desperate retroperitoneal lymph node dissection with a lot of complication. But now since 2000 actually we start moving and try to do something minimal, and the support from the patient actually the oncologist is very good. Now they start referring the cases earlier to us. So this is how we started into 2020. We did a dry simulation, tried to do it, and this is my first patient, actually 19 years old boy, managed to convince the patient to go this procedure. And I'll be totally honest to him that I said, I'm good in robotic surgery for prostatectomy, but I've never done this procedure before. And because there's no other alternative for them, and then they decided to agree to go for surgery. So this is the position, but at this time we are using the SI model, and the SI model, the robot has to come from the head side, from the head, cranially, and this is the port we put, and one with front assistant. This is how I do the supine robotic retroperitoneal lymph node dissection. You see the tumor at the top there? That's the ureter, the right ureter. We need to sling the peritoneum so that we can have able to see the retroperitoneal area better. Then we go directly dissection on the right common iliac artery. The similar way that we do for open surgery. We will take all the packet between the right ureter and the IVC at the paracaval area, sorry. I just speed up the video. That's where the mass is. That's basically the left renal vein. And we need to clip all the lymphatic tissue to avoid lymphocyte collection after the surgery. That's basically the left renal vein. On top of that, there is a fourth part of the duodenum. You see that one? That basically the right renal artery. So that basically the upper limit of the dissection. Then I go to the end. Then we need to also remove the right gonadal vein. And that's the final outcome of the surgery. So this is what happened to the patient after surgery, with a small wound, and the patient can go back into this time. So this is my first patient I mentioned to you. After 5 years, there's no recurrent or tumor, and he's very happy now, putting on weight. So this is another patient that I have done. It's a huge mass there on the right side, and this patient with the mother. All this picture was taken with the consent from education purposes. So this is a tumor that we have removed. So this is a huge tumor that we have done on the right side. You can see the mass there, very close to the right kidney and the left renal artery. Sorry. So this is the port position. I think now we are using the SI model, the straight line of port position. The good thing about this model, actually, we can switch the camera port from one to the other. This is only one assistant port. This is how the port, the robot, when he dock. But unfortunately, for this particular patient, that I have to take out the right kidney because the tumor actually infiltrated to the ureter. This is him after the surgery. So that's the situation. So in the tumor, something like this, very small, to do open surgery, I think it's not good. But because this can be handled by the minimally invasive surgery, and the outcome is good, so maybe now it's time for us to change. This is another guy that we have done recently. Huge mass on the left side. You can see the kidney, the left kidney, and that's a tumor. Also very close to the left renal artery and vein. But fortunately for this particular patient, we are able to remove the tumor completely without sacrificing the left kidney. This is the video that I have. So that's a mass there. You can see the mass, huge mass there. But in this particular patient, I decided to go to the lateral approach. Just speed up the video a little bit so this part actually is similar way that we do for the nephrectomy, robotic or laparoscopically, mobilizing the descending colon. And now this is the dissection part of the tumor. You can see that's the ureter. This is a source muscle. I tend to put the vessel loop around the ureter so that I won't accidentally cut the ureter. And then we do more further dissection medially and posteriorly. And the tricky part actually more at the top part. At the top part of the very close to the left renal vein and left renal artery. This is the part a little bit more tricky because there will be a lot of addition. Because we are dealing with the huge blood vessel there, any mishap actually can be disastrous. Just to speed up, okay, that where the right renal artery is, and that basically the gonadal vein going to go to the left renal vein. So that the vein, the gonadal vein. They have to take with the clip. And eventually we managed to take out the tumor completely. Okay, this is my result actually since 2020, for 4 years. We only able to do 10 cases. But now in 2025, actually we have managed to do 26 cases. Or the incomplete one actually at the first beginning, and then the blood loss is only 180 cc. They stay in the hospital only for 2 days. And majority actually at the mature teratoma, and 17 patients are still stable. Only 2 patients actually developed recurrent require second line chemotherapy. So this is the problem with if you don't do anything, the teratoma syndrome, growing teratoma syndrome, is eventually will destroy the adjacent organ. And it's been introduced in 2006, in 2020. Actually, it's been proven to be safe and effective and reproducible. These are the pictures that I've taken with Dr. James Porter in Chennai. I got the opportunity to see him. And when I told him I'm doing the robotic RPND, I learned from his video, watching his video, 5 hours video repeatedly, and can really memorizing what he's saying in the video. And it's an alternative to open surgery. I think it's a good alternative to open surgery. It's feasible, safe, and reproducible. It's allow patients to recover as quickly as possible. But what I learned is the best thing we can do to open the patient if we do not need to do anything. So that's why at the stage of learning be a surgeon, first we learn how to do, then after that we learn when to do, and the last thing that we learn actually when we do not need to do anything to the patient. Another good thing is if we can do something cheaper, easier, simplest, by diagnosing the tumor as early as possible, and subsequently try to do something that allow them to recover as quickly as possible and go back to the normality as soon as possible. I think that because these are young people, they are at the productive age. Another thing I like to do is basically in Malaysia now. We have the highest number of robot actually installation in the South Asia. This is something that I'm very glad. And then another thing that I'll do is basically go around the country and proctoring people to do robotic surgery so that they can basically do simulating. I think this is what we do. And after that we teach people to do it as good as us. With that, I thank you very much for your patience, attention, and willingness to listen to my talk. And thanks again for your invitation. Thank you.
Thank you, Professor Sani, for your excellent talk. Now I would like to welcome Professor Dr. Srinath Chandrasekhara, our society lecturer from the Sri Lanka, the Slough lecture. He'll be talking on the 12 to 20 mm dilemma in stone disease, evidence versus reality in South Asian practice.
Thank you, sirs. Firstly, warm greetings from the Sri Lanka Association of Urological Surgeons, and thank you, Naus, for inviting us to be present, not only the specialists, but several of the trainees who are here. So, Professor Paras, Suman, Professor Kshetra, it's great to be here and to be associated with this meeting. So I'm going to take you to the mundane, where I'm going to talk for a few minutes about one of the commonest problems we have, which is stone disease, of which in the upper tract you would agree that 1 to 2 centimeter stones are the most commonest size that we encounter in treating patients in most instances. So the dilemma of treating the stone is because there seems to be some degree of divergence between guidelines which are based mostly on Western experiences and the realities many of us in South Asia, in Asia and Asia in general face in treating these patients. We do have a very high disease burden, and I am to believe that even the stone characteristics such as stone density is somewhat different in our parts of the world where the stones are more dense. So, whilst acknowledging the technology and the evidence, I think the optimal treatment in terms of efficacy needs a relook. So we are familiar with this. All Western guidelines talk about ESWL, RIRS for stones less than 20 centimeters, no debate about it. PCNL for higher stone burdens and for unfavorable factors. AUA has similar recommendations, and practically all treatment modalities are appropriate for this stone size. Now, some of you who belong to my era, where we started urology 20, 25 years ago, would remember that this stone size was ideal for ESWL no matter what, and we used to just crack on with ESWL. That has changed. Now we are looking at density, we are looking at anatomy, we are looking at so many things, including cost efficiency, and ESWL is now taking a lesser role because of all these factors. And as I mentioned, I'm sure you share my experience that many of our stones are very dense, and even when they are small, do not respond to ESWL therapy, which makes it necessary for us to do repeated procedures or subsequent interventions. Now, although PCNL was popularized subsequent to ESWL, ureteroscopy, which has come into the limelight even later than PCNL, has now taken the limelight, and quite rightly so. It is less invasive, does not require incisions, can be done under day case, and with the newer technologies of smaller scopes, better sheaths, suction, energy devices such as thulium, holmium, this modality of treatment has become ideal when you look at a research or an audit setting. But we do have limitations, and this is where the South Asian scenario comes in. Well, our personal experience, our own experience in Sri Lanka has been that most people who require flexible ureteroscopy for relatively larger stones in particular benefit from an access sheath, and the ureters in our population is not always accommodative of scopes and sheaths, so we need to pre-stent them. So that is one procedure. And of course, with larger stones, invariably we end up leaving a stent behind. So there's a pre-stent, there's procedure, and a post-operative stent makes it 3 sessions. Time is a problem, although efficient in terms of getting the job done. This is not a time-efficient procedure, and we have vast waiting lists. Unfortunately, as yet, flexible ureteroscopy remains a more expensive treatment option for our patients in this region, and I'm sure our experience of cost as well as time efficiency is no different from all of you who experience similar limitations in this terrain. Unfortunately, flexible ureteroscopy is not yet freely available in the free healthcare system that we operate in Sri Lanka, and I'm sure it is again the same in South Asia, where many, if not most of the private institutions have flexible ureteroscopy, but not all will have free access or unlimited access to this modern technology in all levels of healthcare. So this makes it a bit more restrictive for us to use flexible ureteroscopy as the most preferred utility for this size of stones, especially as the stone size becomes closer to 2 centimeters and the stones become more dense, where more time and effort is necessary for clearance. Ureteric injury following ureteroscopy is something that is well documented. I'm not going to talk about it, but I'm sure with modern technology, this incidence is becoming lesser and lesser. So stone clearance, again, this is a fairly old study from Gusti, but I don't think the situation is very different. If you look at one setting, the stone clearance goes down as the size of the stone goes up, and this is one of the key considerations for time constraints and for economic constraint when there is a system where we need to consider all these factors in deciding on a modality. So let's come to mini PCNL. Again, these are facts you know, so I am just going to reiterate them. We will not have to argue that this is the highest single session stone-free rate of all the modalities. It is density independent, which is important for us, and fortunately, again, due to Asian innovation, we have variety of scopes. We have ultra mini, we have mini, we have super mini, and we have just a standard mini PCNL. And that makes it a far more versatile procedure to treat these average size stones very efficiently. And with the advent of and the popularization of supine PCNL, we have now begun to start doing PCNL under spinal anesthesia, which makes it even more efficient in terms of getting the job done. Again, no argument that the operative time, when done properly, is much, much less than a flexible ureteroscopy, and stone clearance, a very high rate of stone clearance, can be achieved using one session. We have also begun to done surgery, and our experience with mini PCNL for small, or the average size stones, as I would call it, for 1 to 2 centimeters is less than 24 hours. So patients are able to go home and return to normalcy, and the use of stents, again, is in a very, very limited setting. Hardly anybody has a nephrostomy. If at all, the drainage would be by means of a stent or a ureteric catheter. So this is very efficient, it is cost effective, it is time effective, but the rare higher grade complications, again, that have been recorded with PCNL have also begun to see a decline with the advent of smaller sizes. You know the statistic that the tract size is proportionate to the hemorrhagic complications, and when the tract size drops below 22 French, the hemorrhagic complications drastically drop. And this is everyone's experience, your experience, my experience. So mini PCNL, again, with a tract size less than 22, again provides an advantage of minimizing higher grade, rare but higher grade complications in this modality of treatment. So my proposition here is that more practical approach for the higher size or the upper limit of stones that sometimes need further consideration beyond guidelines would be mini PCNL for many of the reasons, especially in resource constrained or resource restrained environments. So just to sum up, we know that comparative outcomes for shockwave lithotripsy, even when chosen well, even when the case selection is good, is much less than other modalities. RIRS, again, there's no debate that this is the new kid on the block, but the most attractive kid or the most attractive modality, but we have limitations of time, cost, and sometimes in certain places, availability. So again, a case for mini PCNL, when we need to consider all these things, it is certainly an attractive, efficient modality of treatment. So these findings are well documented. I'm just citing one study, a relatively more recent study, where mini PCNL is found to be a better treatment modality for higher single-step stone-free rate, short operative time, fewer post-op complications. So this is where we are. So now, just to wind up, let's look at some of our local realities. As I said, cost, availability, and therefore, this mini PCNL remains a very strong contender for treating average size stones, which is the most frequent size that we encounter in most centers across South Asia. So, yes, we have all modalities, but when the stone is hard and when we need to look at all these things, we may need to consider percutaneous extraction. So I'm just trying to coin this term rather than PCNL. Should we be actually be calling it percutaneous extraction of stone? And that's what we documented in some of our hospital records, that we have actually gone through the loin and gone through a mini tract, but extracted the stone for purposes of efficiency. Thank you very much, ladies and gentlemen. It's lovely to be here, and I do hope that the weather will clear up for us to have a good view of the beautiful mountains. And I also take this opportunity, whilst thanking the organizers once again, to warmly welcome you to Sri Lanka for our South meeting, which is a fantastic meetup. We had colleagues from everywhere, including a significant contingent from Nepal joining us last November in Kandy. And this year it will be in our capital city of Colombo, which is a much sought after tourist attraction. And I do hope to see many of you in Colombo later this year. Thank you very much.
Very kind invitation to be in this beautiful city of Pokhara. So I've been asked to talk about some decision making in the management of locally advanced renal cancer. And POWS, which is the main body of urologists in Pakistan, has over 750 members. It's a vibrant body, and our next annual conference will be in the city of Peshawar in the month of November. I have no conflict of interest related to this presentation. And I'll start off by giving a brief description of what we mean by a locally advanced renal cancer. Unfortunately, we have greater clarity compared to what Dr. Mehta described about the locally advanced prostate cancer. So we have a T3A cancer, which is irrespective of size, involving the renal sinus fat. We have IVC thrombi with RCC, which could be at various levels and described as B and C, T3, or locally invasive disease, which is going into the contiguous organs, and there is a direct invasion, which is T4, or node-positive disease. Essentially, for this clinically T3, T4, or node-positive disease, we have to make the diagnosis well, and we know that the cornerstone of diagnosis is the imaging in renal cell cancer. So standard imaging with contrast-enhanced CT scan is necessary. For complex IV thrombi, IVC thrombi, we need to do the thrombus mapping by either MRI scan or good quality CT scan. However, sometimes it's important to do selective imaging to exclude metastatic disease, which is unfortunately relatively more common with such locally advanced cancers. So when we are dealing with locally advanced RCC, the whole idea is to develop a strategy to make sure that we take out most of the disease, almost all of the disease. And surgery remains the mainstay even in these era of systemic therapy. The surgical modalities, which is either radical nephrectomy in almost all cases, very selectively we can do arm block resection for T3A cancer if it is oncologically feasible. And obviously, the mainstay of treatment for IVC thrombus is surgical vascular procedures. In order to do staging, because the role of lymph node dissection in renal cell cancer is not as certain as in some of the other cancers, is to do staging lymphadenectomy so that we know that we are dealing with a lymph node positive disease, which definitely is a complex condition and which require multimodality treatment. Now, the key in essence in this setting is to do a multidisciplinary team involvement. So it's extremely important that urological oncologist, medical radiation oncologist, radiologist, pathologist are all involved. And also importantly, we do shared decision making, looking at the personal goals of the patient to understand what he actually or she actually thinks in terms of treatment of her condition. So aggressive curative treatment is definitely associated with morbidity. We know that maintaining quality of life may be one consideration for certain patients. So you have to really model your treatment based upon patient's consideration. The important characteristics that need to consider when making shared decision making is to understand the tumor characteristics. Not all 7 centimeter or 10 centimeter renal cell carcinomas would behave similarly. The pathology dictates the aggressiveness, and understanding pathology is now very frequently done with the tissue biopsies before any intervention is planned. There are various prognostic risk scoring, and for locally advanced disease, the Leibovitz score probably provides you with some statistical analysis before you make the decision. Obviously, the age of the patient, the comorbid status, and the overall performance status makes important consideration when you're deciding about the treatment. We all know that the Leibovitz score involves not only looking at the histology, staging, but also various grading factors are incorporated in that score. And if you look at the score, you see that if your score is low, there is a 5-year survival, the metastasis-free survival in nearly 97% patients. However, it drops significantly if you have a high score between 6 and 11 to under 1/3 of patients. What is the role of systemic therapy in this setting? Now, we need to understand that systemic therapy has made significant advances over the last 30 years, moving from the biological response modifier to immunological agents that we have, and in between we have tyrosine kinase inhibitors. However, you need to understand that it can either be given in a adjuvant setting, which is more frequent for locally advanced disease, sometimes in neoadjuvant cases in which the primary surgical team consider surgical option as not a first option in this situation, and in inoperable cases. Now, we know historically that radiation therapy at best has some palliative role in the management of renal cell cancer, as we have been taught that it is a radio-resistant cancer. However, the stereotactic ablation body radiotherapy has come up not only as a purely palliative measure, but also in the management of the primary cancer. So the local control, if you look at the IROC trial reported in Lancet Oncology a few years back, shows that there is a 97 to 100% one-year cancer control with SABR only. And 5-year local failure rates could be just under 5%. So this is a very significant cancer control using SABR or SBRT alone. For more complex cases, larger tumors, centrally located tumors, particularly in a single kidney, again, SABR or SBRT has significant role. If you look at the advantage of nephron sparing in terms of the preservation of the kidney function, we see that the loss of GFR really varies between 8 and 15% mils per minute following SABR, and also it is safe for solitary kidneys. Probably one of the most complex condition that as surgeon in urological oncology that we face is high-grade, high-stage IVC thrombi related to the renal cell carcinoma. And this is perhaps one of the more complex surgical procedure. It's associated with significant morbidity, and now we have a well-defined role of stereotactic body radiotherapy, not only in downstaging the IVC thrombus if it is considered inoperable, or also primarily treating the IVC thrombi using stereotactic body radiotherapy. So, in essence, the management of IVC tumor thrombus in locally advanced renal cell carcinoma, we have a surgical option as the mainstay, whereas the SBRT is coming up as a significant definitive therapy as well as supportive therapy. So in complex thrombi, SBRT provides symptomatic relief and local control of the thrombus. It can be given pre-operatively to downstage the disease, and as well as to decrease the possible chances of the metastatic shedding which can happen during the surgical maneuver. Now, the other thing that we face in the setting of locally advanced and also sometimes localized renal cell carcinoma is the oligoprogression. And we know that systemic therapy, particularly in our particular setting, is not only extremely expensive and difficult to continue for a longer period of time, but it can also result in significant failure rate. So if you have oligometastatic disease, which means that you have 1 to 3 metastatic sites, again, SABR is one of the options in this setting. It also, at least theoretically, provides immunomodulation, which essentially means that when you apply the stereotactic body radiotherapy to these tumors, it results in tumor necrosis, which result in antigen release, and this stimulates the anti-tumor immune response. And at this point, when you administer the immunological, oncological agents, their impact and effect is much more better than if you do it in de novo settings. So what are the current guidelines and recommendation for SBRT? And if you look at the NCCN guidelines, SBRT is now a category 2B recommendation for inoperable stage 1 disease with IVC thrombi. For category 3 for inoperable 2 and 3 disease, this is the NCCN recommendation. The dose fractionation is described. So surgical approaches for IVC thrombi, you all know that the level 1 and level 2 thrombi are relatively easy and purely urological disease, which most urological oncologists can easily manage because it does not require significant liver mobilization and major reconstructive vascular procedures. However, it's important that we perform good quality imaging in order to ascertain whether there is a intimal involvement or the wall involvement by the tumor thrombus, in which case resection of the wall is required with reconstructive surgeries, reconstructive vascular surgeries. It is the IVC thrombus with level 3 and level 4, which is really a multidisciplinary approach, and the life is made significantly easier if you have a good quality liver surgeon and vascular surgeon available, and they will be able to provide significant support in order to live. Once you mobilize the liver, the life becomes quite easy, and the Pringles maneuver would definitely help you in significantly decreasing the blood loss. And for level 4, obviously you need cardiopulmonary bypass, which is a much more complex procedure. So in essence, if we look at the treatment modalities for locally advanced renal cell carcinoma, I would still say that surgery is the mainstay of treatment in majority of cases, although the role of lymphadenectomy is not certain, but staging can be performed using lymphadenectomy. The role of adjuvant treatment with the IO is again, the immunomonitor trial was negative, so we don't have any definitive answers in terms of use of adjuvant treatment after surgical management of locally advanced kidney cancers. As for the neoadjuvant trial, the PROSPER trial with the use of nivolumab started pre-surgery and continued after surgery is an ongoing thing, although the current recommendations are not in favor. For unresectable or M1 renal cell carcinoma, the first line treatment is definitely systemic treatment with a combination of IO or TKI or IO plus IO. Cytoreductive nephrectomy is now mostly deferred after the 2 landmark trials, and it is only performed post systemic therapy if there is very significant response. Again, SBRT has a significant role as a palliative management. Thank you very much for your attention.
Thank you, Professor Hamad, for your lecture. Now we would like to move on to the next BAUS lecture by Dr. Prabhat Chandra Biswas. He will be giving talk on transforming urological practice in Bangladesh, overcoming barriers in minimally invasive and robotic surgery. He is Associate Professor of Department of Urology, Dhaka Medical College, Dhaka, Bangladesh, and General Secretary of BAUS. He would be giving us the recorded session as he is not able to travel. But at the same time, I would like to welcome all the friends from Bangladesh so making to POKHARA, even in a difficult situation. Thank you.
person, members, and colleagues. Today I am going to present the structural evaluation of minimally invasive urology, the systemic barriers faced in Bangladesh, and how global evidence strongly supports simulation-driven, proficiency-based reform. Recent global perspective emphasized that the evaluation of minimally invasive urologic surgery is not merely technological, but fundamentally educational and structural. This is my alma mater, Dhaka Medical College and Hospital, established in 1946, about 80 years ago. Before that, it was used as a secretariat of East Bengal and Assam. It is pioneer and center of excellence in Bangladesh. It has a glorious historical role, especially in the mother language movement in 1952 and independence of Bangladesh 1971. And this is the timeline. The minimally invasive surgery begins 1901 when George Killing introduced lipoperitomy. The modern urological laparoscopy evolved in the 1991. The claim the first laparoscopic nephrectomy done. And 1993, Winfield has completed laparoscopic partial nephrectomy. Then laparoscopic radical prostatectomy done by Sursler in 1997. The first robotic assisted radical prostatectomy done at 2000. These milestones marked a paradigm shift in urology. However, rapid global expansion without structural training lead to significant early complication stages. Now, where are we? The majority of urological surgeries, particularly the cancer surgeries, still we are doing in open, and like radical nephrectomy, radical cystectomy, radical prostatectomy, and some others, few operations also, which depends on the still the open procedures. And urology now is available in Bangladesh, like PCNL, URS, TURP. But RIRS is very limited, who have not yet established. And the robotic systems, only two on the process of installation. Now the major problems. Three systemic challenges are evident. One is the training gap. The residents have limited structured exposure to minimal invasive surgeries. Number two, financial constraints. High output of pocket expenditure restricts access. Number three, the infrastructure instability. Poor equipment maintenance and procurement inconsistencies. Studies shows that in Thailand, which demonstrates that national economic and insurance structures significantly influence minimal invasive surgery training exposures. This is not a surgeon's problem. It is a systems problem. The why minimal invasive surgery is important for us. It's obvious that the less postoperative pain, shorter hospital stay, faster return to work, less blood loss, better cosmetic outcome, lower long-term morbidity. In a high-volume surgical country like Bangladesh, the shorter hospitalizations translates into major health systems efficiency gains. The global scenario. The evidence shows in low middle-income countries, surgeons experience longer operative time, higher conversion rate, and more equipment malfunction. This is a systems problem, not also a surgeon's problem. Now the core issue. The training structure is really very weak. So why is traditional surgical failed in minimal invasive surgeries era? The Helsedian model became the inadequate primarily due to growing concerns regarding patient safety and ethical considerations, and a shift towards competency-based rather than time-based training. Laparoscopic psychomotor skill differs fundamentally from open surgery, requiring unique training to overcome challenges like two division, limited tactile feedback, and the fulcrum effect, where instrument tips move in the opposite directions of the surgeon's hand. What the different articles shows, the historical data demonstrated 90% of the bile duct injuries occurred within a surgeon's first 30 cases. the rapid minimal invasive surgery expansion without structured training increased complication rates. This crisis forced the global surgical community to rethink training models. Unstructured learning equals patient's harm. What the article, The Understanding Course of Care in the Operating Rooms, states the 1 minute of operating theatre time costs approximately in European currency 18 to 31. That means about 2,000 to 3,000 taka in terms of, in case of Bangladesh. The training inside the operating theatre is economically inefficient, ethically questionable, the patient's risk intensive. Therefore, the training must move outside the operating room. Now, the issues of simulation-based training evidence. From multiple RCTs summarized, among the all other trainings materials, the POKS trainer training significantly improves technical skills versus no training. The outcome improvements is faster task completion, fewer intraoperative errors, pattern not integrated. The other evidence confirms the fourfold reduction in the complications risks after laparoscopic simulation training, reduced operating time, lower postoperative complication rates also. So simulation is not optional, it is essential. The different literature shows the which simulator is best. According to findings, the box trainer is the most effective and inexpensive. The virtual reality simulators offered advanced analytics but rare. They are very expensive. No clear superiority for basic skill acquisitions. This is critical for low middle income countries' feasibility. Now, the proficiency-based progression. The study showed the proficiency-based progression is a training method where surgeons must prove they can perform a skill at a predefined expert level before moving to the next stage. Instead of progressing based on time or number of cases, trainee practice specific tasks repeatedly, receive objective feedback, and advance only after reaching a clear benchmark. The skills are measured using defined performance criteria, making the process structured and standardized. Research shows that this approach reduces errors, shortens the learning curve, and improves performance compared to traditional CU1 and 2-1 training. In a simple term, the proficiency-based progression ensures the surgeons are truly competent before operating independently. So evidence shows the professional-based progression superior to traditional training. And the table shows the staged procedure. In this table, the 12 stage of robot-assisted radical prostatectomy with 5 levels of difficulty based on the modified modular training scheme developed in the University of Leipzig. Now, the core conclusions. The minimal invasive surgery training cannot rely on exposure alone, and simulation-based training is evidence-supported. Proficiency-based progression reduces complications, no doubtly. Standardized certification definitely improves patient safety. And finally, surgical societies must lead reform. Now the implication for us, which are must for us, introduce mandatory simulation slabs, implement benchmark-based progression, certify before independent minimal invasive surgery, create national minimal invasive surgery curriculum, and avoid uncontrolled early learning curve harm. Surely, the evidence strongly supports system reform. So what we appeal, the regional collaboration, and we propose for regional collaboration. What we can offer? Surely high case volume, research collaboration, cost-effective clinical studies, training, exposure in complex open cases. And in terms of it and in exchange of it, we can gain from regional collaboration, regional robotic and HOLEP training, fellowship exchange, visiting proctors, joint workshops, online case discussions, etc. Now, with that few words, I like to conclude. Before that, welcome you all to 20th BOSCON 2026, which will be here on Dhaka in 21st and 22nd June 2026. With that few words, I conclude here. Thank you very much.
Thank you, Dr. Biswas. With this, we conclude this association lecture session. I would like to thank representatives of different societies and associations. We are honored to collaborate, and we hope to have more collaboration in future. And we move on to next session. Before that, we call all the speakers of this session to hand over the memento. Sujit, please.
Okay, sir. Thank you, sir. So before we conclude this session, I kindly request our chairpersons to present the token of gratitude and memory to our esteemed dignitaries from our fellow urological societies. So I would like to invite Professor Anthony Ng. I would like to request our President, Paras sir, to present the token of gratitude to Anthony sir. Next, I would like to request Professor Uttam Mehte sir. I would like to request, I'd like to request our President to present the Next, I would like to request Professor Noor Asani sir to come forward. I would like to invite Professor Srinath Chandrasekhara sir. Next, I would like to request Professor Hamad Athar sir to come forward. So I'd like to sincerely thank our respected chairpersons and our esteemed faculties for wonderfully conducting this session. And we'll take a short break and move forward to our next session of JLB oration. Thank you very much.
Everyone, after the nice After the very nice morning International Association lecture, we are starting the JLB oration now. So JLB oration is one of the most important and prestigious component of every NOWS Urocon, and it is a session where we look forward to a moment of learning, inspiration, and reflection guided by our experts. So to formally begin with, I would like to request Professor Paras Manishrestha, President of NOWS, to have seat on the dais. I would also like to request Professor Anil Shrestha to come to the dais. And I would like to request our General Secretary, Dr. Suman Chapagai, to the dais. So our orator is a personality who truly needs no introduction in Nepal's urology arena. So he is none other than Professor Rabindra B. Sabni sir. So I would like to request Dr. Suman Chapagai, General Secretary of NOWS. I would like to request Professor Paras Manishrestha to escort our Professor J.L. Baidya sir to the dais. Sorry.
Baidya.
Thank you, sir. Now I would like to request Dr. Suman Chapagai to introduce our orator, Professor Rabindra B. Sabni, sir. Suman, sir, please.
Thank you very much, Dr. Baikuntha. So, welcome once again. Good morning, respected dignitaries and dais, and all the international faculties, distinguished delegates, and ladies and gentlemen. So we are going to start the GLB oration lecture. To give the lecture, we have invited our mentor, Professor Rabindra B. Sabni sir, who needs no introduction in this crowd, I think. But still, I would like to say a few words about him. So, sir's full name is Dr. Rabindra Balachandra Sabnis. He did his MBBS, MS, MCH, and FRCS. Presently, he is chairman of the Department of Urology, Muljibai Patel Urological Hospital, Nadiad, Gujarat. So, he's currently different positions in various organizations around the world. To name a few, it's World Endourology Society, the member education committee for the World Endourology Society is regional director for Southwest Asia. In SIU, he holds the position of committee head of stone and endourology. In the Urological Association of Asia, he is deputy director of research. He is past president of USI and council member, board of education chairman, USI. And in Western USA is president, secretary, and council member, and is executive council member of the UAA, and is member of fellowship committee and award committee in World Endourology Society. He is chairman and HREC for Sri Krishna Medical College, Karamsad. So to talk about the academic achievements, he has 38 years of teaching experience, post MCH, is a national board teacher, examiner, paper setter, and inspector for accreditation. He has written 4 books and 23 book chapters in various books. He had 160 publications in various peer-reviewed articles. He had 350 presentations, which includes orations, guest lectures, convener of symposia, several best paper awards in podium, poster, or video category. So his honorary, when we talk about the association with academics of Nepal, he has an immense importance, and he is honorary member of our association, the Nepal Association of Urological Surgeons. He is past visiting professor of B.P. Koirala Institute of Health Sciences, Tharan, who helped to develop the urology department there. He was examiner for MCH in various universities of the country, and he's conducted live operative workshops
and he has attended several NAUS meetings at various places. I remember the first Urocon in POKHARA, he was our faculty. So some important awards, the highest award of Western USI, the gold medal 2017, Best Paper Award for the calendar year 2013 by BJUI, is invited to publish 4 modules on various topics by BJUI Knowledge, Indological Social Service Project Award by World Indology Society, Best Expert Review Award by SIU 2018, Best Teacher Award by National Board of Examination, New Delhi, India in 2019, a Secretary Commendation, Global Leadership Award by AUA in the year 2019, highest award by USI, the President's Gold Medal was awarded to him on 2019. He also had award of Teacher Traveling Fellowship Award by USI in 2020. His honorary FRCS was given by Royal College of Glasgow in 2021. His Distinguished Career Award by Society International Urology in 2022. The Ralph Clement Mentor Award in the World Urology Society in 2022. Urology Gold Medal by USI in 2023. And Distinguished Career Award, the Genitourinary Pathology Society in 2025. And the Know Your Guru Award and Citation by Western USI during Western UCCon in 2025, and Indian Society of Organ Transplantation, the RVS Yadav Oration and Award in 2025, and he delivered UA lecture in the Philippines, Urology Association annual meeting in Manila. So let us welcome Dr. Ravindra B. Sabnis for the oration lecture.
So thank you, Suman sir. Now I would like to welcome Professor Ravindra B. Sabnis sir for his oration.
Well, thank you very much for that kind introduction. Well, coming to Urocon is a routine affair. When I come to Nepal and various meetings and various other activities, it's like homecoming for me because I am the member of the NAUS Association. And therefore, today it is my great pleasure to deliver this most prestigious oration of this association, popularly called as JLB Oration for Urocon 2026 here in POKHARA. Well, it is customary for me to introduce the person by whose name the oration is being delivered. And it's my great pleasure just to give the introduction. He was born in 1945 at POKHARA itself. So this is the city where he was born. He finished his MBBS in 1971 in Amritsar, India. Then he went to England because that was the practice at that time. For the higher studies, most of the people from India, from Nepal, from surrounding countries to go to England for the higher studies. He finished his double FRCS in 1977. And like many other people, he came back to the home country. So he came back to Nepal and continued as a visiting professor, but continued, in spite of coming back to Nepal, he continued as a visiting professor to Royal College of Surgeons in England. After coming back, initially he worked as a surgeon, which most of the senior people in that era did. But because their interest in the urology and because their exposure in UK, they always worked for development of urology, and Professor J.L. Vaidya also did the same thing. His interest in urology made him practice urology. He got attached to many hospitals as a urologist, but main interest was teaching and training urology. And then he got involved in the FCPS program. He has trained many urologists who are now accomplished urologists, and that's a great thing. He has received several Lifetime Achievement Awards by Nepal Surgical Society in 2012, by the Urology Department, Bir Hospital in 2019, Sri Vaidya Army Hospital in 2020, and he was a founding president of NAUS. So that was the very important thing, that what founding president he was and what association we has formed, now has flourished so much and has grown to this extent. He was an ex-senator of the Purbanchal University, and Nepal Medical Association named the office space on his name. So that was a great respect given to him by Nepal Medical Association. And therefore, it is my great privilege, honor, and I feel proud to deliver this JLB oration today. And the topic I have selected is the lessons learned in PCNL from experience to evidence. Well, as you know, that in our country and in this region, the stone disease is a very common disease. If you see the evolution of the treatment of PCNL, it decades back to almost 1980s. And therefore, if you see the beginning of the PCNL, maybe 4 decades back, it arrived in India in 1985. Initial years, there were only few centers which were doing PCNLs. That time, the CT scan was almost rarity. Even ultrasonography was not so common. But the minimum tract size when the PCNL was introduced was 30 to 34, maybe a little higher. And obviously, there was no camera system at that time. So this was a scenario at that time when the PCNL was arrived in India, and then people started doing it. During that period, what was the contraindication of PCNL? I mean, this was the common exam questions at that time. That solitary kidney, no PCNL. Staghorn stones, no PCNL. Undilated system, contraindication. Mild rotated kidney, ectopic kidney, or the horseshoe kidney, not to do PCNL. Pediatric age group, no PCNL. So there were lots of contraindications for PCNL when it arrived in the decades of 80s and 90s. However, now if you see that all these contraindications which were there at that time have become a classic indications for PCNL. So this journey of 3 decades from 1980s and 90s today in 2025, this is the journey of 25, 30 years, contraindications to indication. And when you do that, there are several lessons which I've learned. The journey is not simple. There are lots of problems, lots of complications, lots of lessons to learn. And therefore, some of the lessons you learn by yourself in your own experience, and some of the lessons you learn by what is published and what is the evidence from different centers. And that is you modify your own surgical technique. So today I'm going to tell you about what are the lessons learned in PCNL in last 3 decades. Well, the most important thing which is hesitant and why there is still hesitation of doing PCNL is the getting the access, the puncture of the kidney. Now this is the most critical thing, and most complications, if you see, they are related to inappropriate puncture. And therefore the important lesson that we have learned is that spend time on the puncture. If your puncture is not proper, you are going to land up with problem. This is the puncture where you have to spend time. This is an undilated calyces, very small calyces. And if your puncture is not through the calyx, is going to have a problem. Similarly, when we make this sort of a puncture, the needle has gone into the lower calyx. That was not the appropriate puncture. Just because you get water, just because your access is there, you are in the PC system, does not mean that it is appropriate. You have to go in an appropriate place. Then only you can approach all the calyces. And therefore, this is not a proper place. This is not a correct thing. This should have been from here. Similarly, if you see, don't accept suboptimal puncture. Even if you do ultrasound, now if you see this sort of a puncture, even though it appears okay, it's not proper. It is going by the side through the infant development. Therefore, it is not acceptable. Although the wire will go properly into the system, and it is not acceptable. So these are all lessons which we have learned. Now, similarly, sometimes you get a puncture and you get blood. Now, when you clear up or when you push fluid from the ureteric catheter, it clears up. Again, there is a little bit of blood. And you are tempted whether it is appropriate or not, and whether to go ahead or not. Now, there are a lot of problems in that. What happens is that whenever there is a blood in the puncture, you have to understand that sometimes the puncture is not through the calyx. It is absolutely mandatory, and this is a very hard way we have learned, that if you don't go appropriately through the periphery of the calyx, you are going to land up with problem. Although urine may be clear, everything is fine, but moment you dilate this tract from this place, you are going to land up with problem, and there will be a lot of hematuria, bleeding, hematoma, lots of things will be there. Similarly, if your approach is directly from the infundibulum, there are a lot of vessels which are significant size vessels which run parallel to infundibulum. Now, if you make a puncture, small tract, no problem. But moment you start dilating, these are the vessels which will get torn, and you are going to land up with the problem. And therefore, the lessons what we have learned over a period of years while making puncture is that ultrasound definitely helps. Not that ultrasound is the only way of doing it, fluoroscopy also can be done, but ultrasound gives you a fair idea where exactly the pelvic cholesterol system is, where is the targeted calyx, and then you can target it appropriately and make a little bit adjustment on the fluoroscopy. Spend time. Straight, shortest peripheral puncture is the most important thing. If you spend time, no problem. Sometimes people are in a hurry, but there is no point in hurrying in making access. Spend time, doesn't matter, 1 attempt, 2 attempt, 3 attempt, doesn't matter. Just needle puncture, no problem. But most important is to get the accurate puncture. If you are not happy, if you are doubtful, consider that it is not correct and make a fresh puncture. Direct pelvic puncture, infundibular puncture, although may appear appropriate, but eventually it is going to give problem. It was also highlighted in the previous lecture, the tract size is very important. Now, if you see the publications, what is the evidence of tract size? In first 2 decades, almost all PCNLs, the tract size was 30-34 French size. And there was an ultrasonic energy to break the stones. And if you see, these are the very early publications in 80s and 90s. And what you see in this, when there are big size, the tract size, there were lots of complications, and the most important thing was the hemorrhagic complications. If you see all these landmark papers in the earlier era, you see the blood transfusion rate, 14%, 45%, almost every alternate patient received blood transfusion. Now, this is not at all acceptable, and that was a very important thing. Now, we also had similar problem. Now you see that this was a young adult, bilateral stone, very simple, straightforward, small stones, good functioning kidney, young adult, healthy adult, small stones. Bilateral PCNL was done. It was conventional PCNL. Next day, frank hematuria from the right side. Conservative treatment failed. Hemoglobin dropped by 5%, took up for angiography, could not cannulate, and therefore transferred to our hospital. When patient came in, he was in hypotension. He was on ionotropic support, received 9 transfusions already. There were signs of multi-organ failure. We took up for angiography. We could cannulate it, angioembolize it, and the bleeding stopped, recovered well, and discharged. Another patient, a very young adult, 1.8 centimeter pelvic stone, good functioning kidney. Underwent left PCNL, nephrostomy was removed on 2nd day, developed hematuria on 3rd day, also had leakage from blood from the PCNL wound, clot evacuation was done, he was okay for 1 day, again had severe hematuria, he was transferred to our hospital. We did CT IVP, which shows that the whole kidney was full of clots, there was a leakage from the tract, and there were clots in the pelvic cholesterol system and the ureter. Selective embolization was done, hematuria stopped, recovered well, and discharged. Now, what these 2 patients tell us, and this is not our experience, this is almost everywhere. I'm sure every one of you who are doing PCNL for years together must have experienced this. And therefore, this CROW study, which was a multi-country and multi-center study with more than 5,000 patients, prospective study, concluded that sheath size was predictive of bleeding complications. Very important. And therefore, after that, in about 1990-95, it was realized that this sheath size is a problem. And then all advances since then were revolved around the reducing the sheath size. And the mini perk was invented, and it was arrived in the year 2000. So now it is almost 25 years that mini perk was invented. Now once the mini perk came in, it was a remarkable difference. The bleeding complications really got decreased. And then subsequently, it was almost the race to reduce the tract size. And then lots of different modalities of mini PCNL came. From conventional, it became mini PCNL. Then it was minimally invasive PCNL. Then ultra mini PCNL. Then super mini PCNL, mini micro PCNL, micro PCNL. Hundreds of alternatives came in just because to reduce the tract size to a significant extent. Over a period of years, the lessons which we have learned is that going too small has its own morbidity. It is not that from 20, we have reduced the tract size from 30, 35 to a microperk which is just 4.85 French, just a 16 gauge needle. But it has its own complications. So just by reducing the tract size does not mean that you have achieved everything. There are complications which will keep on coming. Minimally invasive PCNL at present almost solves all the concerns which are present in the conventional PCNL. Ultra mini PCNL, MIPXS, microperk have very limited role in a very limited cases. And therefore, as of today, the biggest lesson we have learned is not going down in the tract size so much, but it is appropriate to have a mini perk size that is about 15 to 20 French size is fair enough, which will have a very nice results. Similarly, in an ectopic kidney, PCNL, there are lots of lessons we have learned. Ectopic kidney previously was contraindication. Then it was thought that, okay, bowels are surrounding it, so it has to be laparoscopic control. But we have seen that if you have the ultrasound, because ectopic kidney, the benefit, pelvic ectopic kidney, is almost under the skin. If you press with the ultrasound as shown in here, that the bowel contents move down, under the skin there is a direct kidney, and therefore if you have ultrasound, if you visualize properly, and we have a big series of patients in which pelvic ectopic kidney we have done without any laparoscopic control, purely ultrasound guided puncture and subsequently fluoroscopic thing without much complications. So that's a very important thing which we have learned. Now, other thing in ectopic kidney, what happens is that RIRS is a preferred modality, but sometimes the system is so awkward, the calyces are oriented in such a way that the flexion of the thing does not go, and therefore in those situations we have also done the microperk wherein you just puncture it. The benefit of microperk is what, especially in the ectopic kidney, that you don't have to dilate. Technically, even if there is it goes through something, it's just a needle puncture. Once you puncture the needle with this, you have to put a telescope and start breaking the stone with the laser, and the job is over. You just have to take out the needle puncture. That's it. It has not much morbidity. And therefore, in a situation like this, where RIRS is not going, dilatation is a little hesitation, microperk comes to the rescue, and you see that we could puncture this kidney properly with just a microperk needle technique, and once your thing is over, your job is over, there is hardly any morbidity, just a puncture mark, that's it, and the whole stone is completely cleared. Over a period of years, we have learned a lot of lessons with the infective stone. We keep getting so many infective patients with infective stones, matrix stones. Now these are the stones where you just can't do any lithoclast, you can't do anything. With the slough-like material which is present, you can't keep on just removing this slough-like material with the forceps. It is too time-consuming. And therefore, in a situation like this, over a period of time, we have realized that suction is very, very important. And therefore, these newer advances which have come in, the shock pulse, the triology or ultrasonic, it's extremely useful in the infective stone like this. Very important as shown here is that these are the radiolucent stone. They are not seen on the fluoroscopy, and therefore every time to ensure you have to put a contrast, make sure that there are no filling defects. If there are filling defects, make additional puncture, but make sure that all the stones are completely cleared. And therefore, in the matrix stone, the important lesson we have learned is that complete clearance is absolutely mandatory. We have repented many times that you thought that, okay, this is just a 1 centimeter small stone, nothing matter. Within 6 months, they will come back with the complete stagon again. And therefore, complete clearance is absolutely necessary. You have to do CT scan. Now is the era of CT scan. To make sure that stone clearance is complete, you have to do the CT scan. Energy source with powerful suction is extremely useful. Better to keep nephrostomy or double jet and give a wash, because there are some slough which remain there that can be washed out with the nephrostomy. Post-operative irrigation is extremely useful, and low-dose antibiotic for a very long time is the key thing which we have learned over a period of years. Many times when you do the PCNL, either during the dilatation or during the puncture or during the nephroscopy, you end up in having perforation. Perforation can be in the infundibulum, perforation can be in the calyx, or perforation can be in the pelvic wall. So what is important here, as you see here, that if you have perforation, there is whole stone gets migrated. This is the medial wall perforation. Stone gets migrated, and there is always temptation. Oh, stone is seen. Now let me go outside, pick up the stone with the forceps or break the stone there. We have had this temptation and we have repented. Because the moment you start putting the forceps and putting the nephroscope and trying the stone will migrate somewhere, your perforation will become bigger, your perforation will extend into the PUJ, and once you have perforation that extends into PUJ and he gets a secondary PUJ obstruction, whatever you do, that kidney is gone. Because that is a dreaded complication, PUJ obstruction, PUJ stenosis, and therefore, it is good idea that leave the perforation just like that. Even if there are stones migrated, just leave it alone. Nothing will happen. Explain to the patient that the stones have gone outside. Anytime you do X-ray or CT scan, the stones will be there, but not to worry about it. And that is what is the important lessons that we have learned. Another lessons which we have learned in a very hard way is that to remove everything in one puncture. Now you see here, that there is a small fragment which is in the lower calyx, and you are trying to go from the middle calyx to the lower calyx, and there is an extreme angulation. Now, if you have that sort of an angulation, sometimes in a temptation to remove from that thing, you tend to angulate more, and then what happens is that there is a torque, there is a severe torque on the thing, and you end up, moment you withdraw the nephroscope, you have massive amount of blood which starts coming because there is a torque on the infundibulum and that tears, and there is a huge bleeding which comes in. And therefore, it is not appropriate to give excessive torque. This is what happens, that whole pressure on this system gets torn and there is a bleeding. So if there is too much angulation required, stop it. Make a separate puncture. Either you push the stone into the main tract or dilate. That is no problem, no morbidity. But excessive torque inadvertently will tear the system, and therefore it will have a lot of problem. Post-operatively, quite often you tend to get the bleeding complications. Gross hematuria, perinephric hematoma, you should act very, very fast. By attempting conservative measure, we have repented. In fact, there was morbidity and there was occasional mortality. All measures to prevent clot retention should be there. Immediately start irrigation into the periurethral catheter. Color Doppler we have found is not much useful. If there is any doubt, if there is a clot retention, consider that this is the indication for at least angiography. Because the moment there is a clot retention, that means there is a significant hematuria. Even if it is negative angiography, it doesn't matter. At least you have made it very clear. This is what we have learned, and this is what now we practice. Whenever post-BCN there is a clot retention, straight away angiography and embolization is necessary. Friends, coming to the end, PCNL is an art. Evidence have to be understood, and it was rightly pointed on the previous lecture that evidences are from different parts of the country you have to learn. Not that everything is to be learned only from the evidence. There is more learning from your own experience and other people's experience. Guidelines will only guide you, but mastery can be achieved only by your own experience. It is said that it was always told to us by you make a mistake and you learn from your own mistake. Then you are a good surgeon, you are a wise man. But this is a smart era. You don't have to learn from your own mistake. You have to learn from somebody else's mistake. And therefore, this lecture is mainly devoted for that. That we have learned in a hard way, in a difficult way. We have made lots of mistakes. But it is for all of you to learn from our own mistakes and make sure that ultimately patients are benefited and your PCNL is without any complications. Thank you very much.
Thank you, Ravindra sir. And now I would like to invite Professor J.L. Vaidya sir for a short remark.
Thank you. Very good morning to national and international delegates, my friends, and of course, thank you to Dr. Sabnis as the sponsor of the prestigious oration at Urocon, it is my great pleasure to offer a few closing remarks. Today, we have the privilege of listening to an outstanding and thought-provoking lecture by Dr. Sabnis. His depth of knowledge, clarity of presentation, and practical insight has truly enriched this academic gathering. On behalf of the organizing committee and the sponsor of this oration, I express our heartfelt gratitude to Dr. Sabnis for sharing his experience and for traveling to the POKHARA with us, to be with us. Dr. Sabnis has been a mentor, inspirational, and facilitator for our PG students for long, which our NOWS General Secretary has elaborated in detail. We deeply appreciate his contribution to the success of this conference. Let us carry forward the knowledge and inspiration from today's session into our daily practice. Thank you very much.
Thank you, sir. Now I would like to request all the dignitaries on the dais to felicitate Professor Rabindra B. Sabnis, sir. So I would like to request Professor Jagdishlal Vaidya sir to hand over the oration medal to Professor Rabindra B. Sabnis, sir. Now, I would like to request Professor Paras Manisester, President of NOWS, to hand over the plaque to the. Okay. Now I would like to request General Secretary Dr. Suman Chapagani to hand over the bouquet and khada. I would like to request Professor Anil Shrestha to hand over for a topi to Professor Rabindra B. Sabnis, sir. Thank you. Thank you all the dignitaries and Professor Rabindra B. Sabnis, sir. Now without break, we will continue the next session and all the three halls will be run parallelly.
Have a quick tea and come to the halls.
Quick tea now. So we will
in Beer Hospital, and he is a consultant, senior consultant in BNB Hospital, Nepal. He has got a societal leadership like a deputy chairman, scientific committee, Urological Association of Asia, UAA. He is an executive member of PEARLS and OSET, and international member of EAU Endourology. Professor Anil Shrestha.
Thank you, Chairperson. Before we begin this session is dedicated to Asian endourology. So since it's a very new branch of Urological Association of Asia, I take this privilege to introduce OSET for a few minutes. So OSET is basically Asian Urological Society of Endoluminal Surgery and Technology, and we have a few of OSET members present in this hall, including Deepak, Chinake, and Anthony. We have a structured executive committee, board members of OSET, which was officially accepted as Endo-Urological section of Urological Association of Asia in Bali meeting. Basically, the OSIT was formed way back in 2018 by Professor Song-Young Cho from South Korea. He started a simple, very small meeting called ETS meeting, Endoluminal and Technology Symposium in Asia. It started with a meeting, and then we gathered together to form Asian Endo-Urology section. We conduct various meetings annually. We conduct our own OSIT yearly meeting called ETS. Recently, we had ETS meeting in Kobe, Japan. We collaborate with various endo society from Europe, Endo-Urological Society, and we do regular meeting. The main aim of OSIT is to promote endo-urology from Asia and do various collaborative work, research, training program with Endo-Urology Society and EAU Endo. And we are, the upcoming events are ETS 26 Phuket, and we are having our own dedicated session in UAE, Manila in September. And also we are collaborating, we are having collaborative sessions in ICE 26 in Valencia and World Congress of Endo-Urology and Technology, Buenos Aires. So we are trying to shape the Asian endo-urology with OSIT. Thank you. So now we move on to next presentation. With the permission of chairs, in next few minutes, I'll be talking how to master the surgery of RIRS. Actually, mastering any surgery, not only RS, be it open surgery, laparoscopy, robotic, it's a very challenging job to do. Doing a surgery is one thing, doing surgery well is another thing, but mastering a surgery is a very challenging. I think it's the most difficult thing to do. It's harder than to learn surgery. So I'm consultant for a couple of companies, but I don't have anything to disclose for this particular presentation. So mastery in any kind of surgery consists of continuous learning. You have to learn, you have to have a basic fundamental knowledge and ideas. You should learn technique, how to do surgery. Learning technique can be done from the masters, from the mentors, and you should learn and you should acquire some judgmental skill as well. To have that judgmental skill, you need experience. Only learning, studying is not enough. So all the mixture of all these three will give mastery in any kind of surgery. So you have to have good judgmental skill by having your own experience to master any surgery. Talking about mastery in RIRS, it doesn't only give higher stone-free rate and decrease the complication, but to be a master, you have to do surgery like it is a reproducible procedure. If you do surgery, complex surgery well, but if you can't teach your fellows, then you are not considered as master. So here is the key point. To become a master, you have to make complex surgery easy and to make it reproducible by your fellows. Reproducible, not only surgical technique, your outcomes should be also reproducible. So keeping things simple, keeping complex things simple is the essential part of mastering any surgery. You have to have an interest in particular surgery because urology is a vast subject. I mean, there are various branches in endo-urology. So if you choose a specific subject, then only you can be a master in that particular field. The challenge of mastering RIRS is there because it's a rapidly changing field. It's a heavily technology-dependent area of the surgery. Newer technologies are coming day by day. Scopes are changing every 3 to 6 months. If you see scopes, I think there are more than 80, 90 varieties of disposable, digital, flexible scopes. Lasers are coming every year, if not every year, every 2 years. The accessories are changing very fast. So these are the challenges to learn and to master RIRS. The key step of becoming a master is to choose a master. If you choose a proper master, mentor, then I think it is the very key and initial step of becoming a master. Find a master to learn well and to do well. He will teach you what to do, when to do, and how to do, but it's very basic. Mentorship also teaches you what not to do. I think this question is more important than what to do, You should learn what not to do and when to stop. The very famous quotes from Royal College of Surgeons, it's the best surgeon know when not to operate. So, mentor can teach you what not to do during surgery. In the video, short clip, you can see that the access sheath is not passing. If you force the access sheath in this ureter, then you can land into disaster. So you should know when to stop. So going specifically into RIRS, I think any surgery should be systematic. This is the operative field that we do RIRS. This is the layout of my operation theater, how we set up our C-arms, our laser, our endo tower. I don't think it has to be exactly like that, but you have to have your own setup. It should be uniform so that all your theater staff, your fellows, your residents are accustomed with the setup and there is no confusion to avoid problem during surgery. So this is the exact view of my theater. All my screens, C-arm, endo tower, lasers are on the perimeter of my vision so that you don't have to turn around, the ergonomics become easier. The setup of a trolley is pretty simple, you avoid all the unnecessary items from your table to avoid clumsiness, to keep your operating nurse and of your residents comfortable. There are only very necessary, very few things that are kept on the operating table. All the surgeries are based on preoperative planning. I don't need to emphasize the importance of sterile urine because most of the mortalities, there are mortalities reported in literature and most of the mortalities reported are due to unsterile urine and infectious urine that were not treated preoperatively. These days, evidence are coming up with the importance of stone volume rather than maximal stone dimension in terms of preoperative planning in RIRS. Just to show why stone volume is important, if you see the picture A, it's also 4 centimeter stone in the maximal diameter. Picture C is also 4 centimeter. But when you calculate the volume is almost 16 times higher than picture C. Then that means you will make 16 times more fragments. Your operative time can be 16 times longer even if you are doing same 4 centimeter size stone. So stone volume calculation is very, very important. Nowadays we routinely do volume calculations in our center to plan the surgery preoperatively and anticipate operative time and complications. Because endourology is all about surgical duration. Prolong the surgery, higher the complications. So even with the introduction of suction in flexible ureteroscopy, if the volume is high, then you have to spend longer time suctioning all those fragments. Access is very important step in starting flexible ureteroscopy. I always start with cystoscopy because we all are very familiar with cystoscopy. We are comfortable, the vision is good, and I cannulate the ipsilateral ureter, and you have to be systematic. You don't have to follow the same step, but some prefer doing semi-rigid ureteroscopy before RIRS. I do cystoscopy. If you are doing semi-rigid, it's well and good, but you have to be systematic. After insertion of the guide wire, you can assess the ureteric orifice for subsequent passage or subsequent introduction of your access sheath if you are planning one. RIRS is considered as one of the very minimal invasive surgery for stone and upper tract TCC. It's a fine surgery. There are very fine movements we do. So small things matter when we do RIRS. That means if you do small things correctly, then there is a higher chance that you will achieve a better result. If you fail in those small steps, then you will land into problems. So learning small things, small maneuvers, small movements, small laser settings, or small things matters when you have to learn RIRS perfectly. I don't have to emphasize that you should not force in endourology, be it a cystoscopy when you are doing cystoscopy in a tight urethra or high bladder neck, semi-rigid ureteroscopy, even PCNL and RIRS. Force is the enemy in endourology. Most of the things in endourology can be done with the wrist or finger movements. You don't have to push much. So we usually do ureteric access with the use of fluoroscopy. Quick burst of fluoroscopy is advisable. We have published our work that the requirement of fluoroscopy doses or radiation dose is very minimal in ureteroscopy. Before we start, even CT shows a solitary stone. I always make sure that I inspect all the calyces because there can be surprises. There are cases when we leave behind small stones, and when we follow, we think that we have done a very good job, but when we follow up with ultrasound or CT, then we find very small stones and patients are not happy and you are disappointed too. So before you start, quick check of calyces is very important. You have to learn very fine movements like micro-rotation, which was popularized by Professor Traxler. It helps you to navigate difficult lower calyces, even difficult upper or middle calyces, calyceal diverticular stones, you know. And you have to understand your scopes about end-tip deflection. So these few minor things will make your difficult cases easy and help to achieve higher stone-free rate. Talking about flexible scopes, we have various aspects of flexible scope that we can discuss, but I just want to show you this small clip that there are scopes with various working channels. And sometimes we need scopes with different working channels. The picture in the left shows that I was not being able to reach the stone. This is the post-PCNL residual stone. The scope with 9 o'clock working channel was not very helpful, whereas when I changed the scope with 3 o'clock working channel on the right, you can see I was easily approaching the stone and I could finish the case very easily and achieve the stone-free rate. Regarding laser, I don't want to talk much, but regarding laser fiber, always use smallest laser fiber that you have in your theater because it not only occupies less space in working channel, but it also ablates the stone efficiently. If you use same 1 joule with 365 micron fiber and 150 micron laser fiber, then the efficiency can be 6 times higher. You know, the efficiency, laser efficiency goes high, and the dust produced by thinner fiber is much finer. There is a misconception of laser frequency. We always think that if we increase the laser frequency, then we achieve the finer dust. It's not true. Laser frequency is all about speed. And if you want to use higher frequency, you have to be comfortable, you have to have good skill. If not, always stay in low frequency. In kidney, keep the frequency below 20. In ureter, I always use 5 to 7 hertz of frequency. Tips for good dusting is not only laser setting, it's a fiber size, the distance of fiber size and stone, and the maneuver you do over the stone. These all matters when we talk about the stone dusting. So at the end, always check for the clearance. You know, even if you do good dusting in upper pole, check the lower pole because there is always chance that you leave behind the stone fragments or dust in the lower pole. I always check all the calyces before and after the surgery and do no harm. While coming out, always check the ureter because especially when you use non-stented ureter, when you use axis, always check the ureter whether you have done damage or not. So this is the key point to avoid complications. Coming to the end, always respect anatomy. You know, ureter is not the straight tube. If you look properly the ureter from the UBJ to PUJ. There are lots of bends, there are lots of curves, there are lots of constrictions. That's why respect the anatomy, use smallest accessories, use smallest scopes, and respect the anatomy. Data keeping, networking, research is all very important part of mastering any surgery. We are trying to collaborate with various international groups for research. Again, without our fellows, without our students, it's not possible to become a master or to become a teacher, you know. So mentoring, teaching others is a very essential part of being a mentor. So I would recommend, there is a principle called watch one case, do one case, and teach one case. So if you don't teach, you are not a teacher, then mastery is incomplete. So to conclude, to become a master, you have to repeat simple steps again and again. So first and foremost, most important message is repeat, 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 and learn from each repetition, you know, and do an incremental refinement every time you repeat. Then only you can become a master. You have to be hunger for knowledge. You have to have a beginner's mind. You have to be eager to learn every time you repeat. And mastery is not a very simple job. It takes time. It's a long process. So be patient and be consistent to become a master. Thank you.
We cannot ask question right now. At the end of the session, we're going to ask question to Professor Anil Shrestha.
Next, we call upon Anthony Ng. He's going to present on the role of AUSTEG in surgical training in Asia. He's Professor of Surgery in Chinese University of Hong Kong, CUHK. He's the founding chairman of Asian Urological Surgical Training and Educational Group.
So thank you again for giving me the chance to introduce about the OSTEC group and how we are helping to the training of the urologists in Asia. And again, this is my disclosure. I think we have noted that in our region in Asia, we are the most rapidly growing population over the world, and in particular in the South Asia and also Southeast Asia, we are expecting almost doubling our population in the 20 or 30 years' time. However, on the other hand, while we have the huge population in here, we're also facing a problem that not every patient of us will have an equal chance of having access to surgery, not just because of the space or distance, but also sometimes because of the economy, everything, that our patients are lack of the access for good surgery and also being cured by the surgeon. Therefore, while we're facing this challenge of how to improving the care in Asia, therefore our group OSTEC is the Asian Urological Surgical Training and Education Group. We try to hopefully we can contribute a bit on this area. And our mission is to try to advancing the standard of the urological surgery in Asia through providing a training platform for experience sharing and skills exchange. And also hope we can cultivating the next generation of leaders in Asia. And our aim is trying to using the Asian resources, Asian trainer, mentor to try to help the build up of the next generation of Asian urologists. And our group including many urologists from the whole Asia, from both from Singapore, Hong Kong, and Taiwan, and even from Pakistan and Iraq, everyone is including in this group. So currently I'm the chairman of the group, and also we have Dr. Yusuf Tani, the vice chairman, Dr. On, the vice chairman from Malaysia, and also a large batch of trainer and lecturer to help in the training. Our main work is including we providing training course, but just now we learned that we need to observe or learn from the quick mentor to learn the surgery. But sometimes we still need to have some hand-on section, hand-on courses to in order to prepare ourselves before we go into the patient to do the surgery. Therefore, training courses, in particular with the physical hands-on part, is the most important part of our work. Although in the COVID time we had lack of the chance of having physical workshop, but we're still trying to using the webinar and also some hackathon model in order to provide this training during the COVID time. And also for good training, besides before we using a patient for our practice or learning, we still using a model will be very important. Therefore, our group also trying to develop different kind of the model for the training purpose. And also we will try to summarize some of our experience in order to share with other group to see how to promoting training in different situations. Concerning about the training courses, our main, compared to other society or other meeting, our training courses mainly just focusing on surgical parts. Therefore, we will not talk about the disease, pathology, the pathophysiology, or other things. We just talk about the surgery. So we start from the equipment, how to make the best use of the equipment, understanding, say, the laser setting, understand how to manipulate the scope, and to how to perform the procedures. And then we will spend almost half of our time we will put working on some of the dry lab or wet lab in order to practice how to perform the procedure like uteroscopy or laparoscopic surgery in a wet model or dry model. And also, we sometimes, for some particular situation, like some of the stone disease, we are using some problem-based learning to try to train our trainees to how to face the different situations, different scenarios, to how to improving the clinical management of our patient. And most important, we try to providing a free of charge or minimal charge for the courses so that all the trainees in Asia can join the courses without the financial burden. These are some of our courses like the low and check course. We start from basic things like how to perform a cystoscopy to using a resectoscope to perform a TRP, TRPT, or even now we go for on-board resection or relocation procedures. We also have some laparoscopic courses, also both basic courses and also the advanced courses. Basic courses will be touching on how to perform a basic surgery like dissecting the kidney, doing a laparoscopic lipectomy, or doing some uteric anastomosis. And for advanced courses, we will talk using the cadaver to do some of the pelvic surgery or some of the emergency management, say how to manage a patient when there's bleeding or some organ injury during the laparoscopic procedure, so that you can have, the trainee can learn how to manage some of these complications during their surgery. Besides ourselves, and we also closely work with different society, including the WCE, the AUA, and also some of the local regional society to perform the collaborative workshop. For example, we have every year we have the collaborative workshop with the UAA talking about different topics. Some are lecture or some are on the hand-on section. And also we have working with the Arabic Association of Urology on some of the workshop on laparoscopic surgery. And also just now we have the Japanese society also work together. Last year, we have just celebrated our 10th anniversary, and in the past 10 years, we have run over 75 courses, and with about 5,000 trainees being trained in our courses. And these are some of the work that we have been done. And besides the training courses, as I mentioned, training model development is also very important for us because sometimes we can't always just do the procedure in our patient. Therefore, we need to have some model to try to practice, and also we need to validate how effective is the model for the training. And therefore, these are some of the models that we have been developed. Like this is a bladder model using a pig bladder, and then we can, using some lock, and then create some small bladder tumor within the bladder. Then we can do TRPT or on-board resection for the bladder tumor. And also, these are some of the turkey kidney that we have used to try to mimic the free loop of the prostate. We can try to perform a relocation procedure or TR procedure with this model. And this we will summarize our experience. Hopefully, this model can be also been used by other groups in their training. And besides publishing this kind of model experience, we also try to summarizing some of our experience in training, how to perform training stone courses or how to perform laparoscopic surgery, so that our experience can also be learned from the other group. I know that this section is talking about the endoscopic procedure, so I'm particularly focusing a bit on how OSTEC is helping in the stone management training. And from we have some basic courses. I like those very simple things from ureteroscopy to PCNL, how to perform the procedure, how to use or different gadgets or accessories during the procedure, and how to perform a good puncture for the PCNL. And then we also have some problem-based learning, because sometimes for a patient, although they have the stone look the same, but different patient, different body build, different medical condition will affect the planning of surgery. Therefore, we have some small group discussion every time during the stone courses, and then each group will face a particular clinical situation, like someone with sepsis or someone on anticoagulant, how to perform the procedure for the patient. And then we will share our experience. Hopefully, this can help the trainee to understand different scenarios, different clinical situations. And this has also been summarized and presented in one of the journals. And we're also using some model to help the training. This is the work from Dr. Siraj, and also how to using some of the jelly to perform a PCNL model for ultrasound training, and also a model for the use for the PCNL training. And we also, with the advance in the technology, now we also including some of the training in the use of French, in our training group to help the updating the program for our trainee. And we also work together to put up a book on the practical management of urinary stone, and it can be downloaded from the internet. And for this book, including different speaker and expertise from the Asian to put together how to manage the stone from diagnosis to the treatment. And I mentioned there's also some more advanced courses like the ECIRS courses, which will be summarizing how to perform the URS and PCNL together. And in order to have a good training, we also work with a Korean group, the LDEFA, to develop this ECRS model. So you can perform the flexible URS, and together with the puncture together, we can do the help the trainee to understand how to perform this procedure. And we also have built up a ECRS regional registry, so that when all of you have experience doing ECRS, we can join together and put our data together, so that we can have more noise or more voice from the Asians to show to the world that how we perform the procedure and what our experience in doing surgery in our region. And some of the data have been already presented in the WCT in 2024. And certainly, without the support from our sponsor like Olympus, Cox, or Boston, that we cannot run all these workshops. And so this is our content, and in case you are interested in joining in our OSTEC group, joining some of the program or some of the training, and also would like to become part of our faculty in helping to support the training in Asia, please feel free to contact us. And once again, thank you for the opportunity for me to share with you the mission of the OSTEC group, and look forward to seeing many of you in our group workshop in future. Thank you.
Thank you very much. Thank you so much. Invite the next one, Dr. Deepak Raguri. I have great pleasure in introducing him. He is one of the respected urologists in India, and he has a huge experience of endourology procedures. He conducts several training programs very regularly, and they have really become very, very popular. He's attached to INU. He's a very close friend. And over to you, Deepak. Please go ahead.
Thank you, sir. Thank you for that kind introduction. Honored for those words coming from you. So I thank Naus and Dr. Anil in particular from OSET for giving me this opportunity to speak on my journey. This is the first time I'm doing that, to speaking on my journey actually. After listening to lectures like from Professor Baidya and like Professor Sabnis, now it's a very small journey of mine. I'll share you on training in flexible uteroscopy. Can I get my slides on? Okay, fine. Thank you. So I'm here to share my experience or my journey in training in flexible uteroscopy, and we've given it a name called the FLUTE. It's an acronym for Flexible Uteroscopy Training and Evaluation Program. So now, like Anil was just speaking about mastery in RIRS, and it has to truly come from a mentor. And although I was not actually trained by Professor Traxler, but he has always been a mentor virtually for many of us around the world. Started back in 2011, 2012 with flexible uteroscopy, but the actual fascination and awe came in when we watched Professor Traxler operating in our hospital back in 2014, when we invited him for a masterclass in RIRS. That was the time when RIRS was making all the noise, new scopes coming in, the fascination for operating stones in minimally invasive, as minimally as you can, which was trying to challenge, mini PCNLs in its own way. I got an opportunity to observe him very closely, starting from how he would set up his OR, like Anil was also again describing. It's very important to get your basics right in procedures like this. Understanding the instruments in a much, much closer way. It's just not picking up any ureteroscope and operating it, but to understand the anatomy and physiology of the scopes as well. How to handle it, how to get the movement straight. And it was so fascinating to see Professor Traxler speak about all these things in a very methodical manner. That kind of sets your mind straight and think over it again and again, and how to understand, how do I do this procedure? And the details of all these things is about, that is where the excellence is created. And the next big step came for me through my opportunity in WC back in 2014. There are two persons who are involved in this. One, my boss himself, Dr. Mallikarjun. He couldn't take up that invitation for being a guest speaker for a session in RIRS, and the other person is the one who's chairing here, Professor Subnis. So my boss said, call him first, whether he'll allow you to speak in my place. I was just a very young urologist. Then I called sir. He said, okay, fine, come on. I'll give you a topic and you should speak on this. It's about RIRS for lower calyx stones. That was a tough talk to take on being a young urologist then, but I took it up. It made all the difference for me in the way I was trying to prepare for the talk. And speaking in front of audience which had Grasso, Professor Anders Gross, all the big names in endourology were sitting, and sir was actually heading that session. But after the talk, when all the seniors said that you did a good job, it changed everything for me. The self-confidence grew as a young urologist there. And what matters once you come back from such conferences is you should base yourself on a mentor who can guide you through these procedures, and you should have an equipped OR where you can try and experiment and start doing procedures in different ways using them. And the caseload and volume has no substitute. You should have it. You should be lucky enough to have a setup which can give you a lot of cases to operate on. And the academic exposure becomes much more important for you to fine-tune on these skills. And the opportunity to showcase your skills when it matters. And that constant hunger to learn and improve, like Anil was saying, repeat, repeat, and repeat. The more you do it on day-to-day basis, you will master the skill. And then came another big stage where at our institute, we conducted a session on stone at Ainu, which was a big event then back in 2018-19, where we were more than 1,000 delegates, and I got an opportunity to do a live demonstration again, along with a lot of international faculty, and that kind of sealed it for me. I just moved to the next point saying that this is the time I should try and fine-tune my skills. On the social media came in next this idea to try and post a few things saying on the finer aspects of how do you do the grips, how do you do the movements, which something fascinated me always. So I tried doing something for myself, started clicking a few pictures and then posting. That gave an opportunity for a lot of urologists around the world who got in touch saying that we should do something in ergonomics in RIRS and we should collaborate to do a study on this. And that's where the same pictures I used on my tweet were used even in the study and kind of really helped in giving an opportunity for training the next generation. What do the youngsters are looking at as far as endourological procedures on? They want to use high-power lasers, the latest digital scopes, latest technology in the market, attempt the complex stones, and the feeling that, yes, I can do with all these gadgets. But what is it that they actually are struggling with? The kind of case selection, ergonomics in doing any of the surgeries that you wish to, understand the accessories that you use day in and out, the stability of your hand to get finer movements, the scope control, and you should know when to stop, like Anil just mentioned in his talk. The idea was then it's not about a conference, it's not about a series of lectures, and just watching endourology on screens is useless, trust me. You'll watch it, you'll go home and do nothing about it. You need to experience it. You should have an immersive hands-on program a small group of surgeons where we can interact one-on-one, give them the real scopes that we operate, make them operate, correct them on hand-holding methodology, and do a stepwise guidance. And that's where it led to the birth of this program called the Flute, which I've been running it for the last 4 years, trying to improvise it on day-to-day basis. Every year we're moving on, and we are into the 4th year currently. And then came in a lot of accolades from big names and big professors saying that you're doing a good job and this is how you're supposed to take forward, giving it back, whatever you have learned in a small way. The more you teach, the more you learn. That is what I've realized. You constantly try to improve and improve yourself as well. And the experience from all the surgeons who have been visiting us was very, very heartening. It pushed me more towards fine-tuning my own program and then inculcate a few more things into the program so that the surgeons have a hands-on experience and go back home happy about it. And the next two step came in when I was in Sri Lanka for that Silver Jubilee conference where there was a hands-on workshop and I operated live there. And Professor Wong asked me, you're very fluid and very fluent in the way you're describing the procedure step by step. I just said, I keep doing this very often, hence it comes naturally to me. And he asked, what do you do that often? That is when I described about the procedure to him that I'm doing a program called Flute. He was so fascinated that as a chairman of Asian School of Urology, it's my job to support and encourage people like you. And he said, I'll support your program. And he endorsed the program, which was another major step. And to make every day that counts for all the surgeons who come to me are already practicing urologists, we also made sure that there is some form of credit hours that we give in for this one-day program when they attend us through the local medical council. The journey started back in 22, and 22 editions later, I've trained more than 130 urologists till date. And every time I see these surgeons, hold the scope confidently by the time they leave, it gives me the same enthusiasm back, which I felt in 2013s and 14s. This was the latest edition. As recent as last week, I had more than around 6 to 7 urologists, like we always do. And why hands-on training matters is it's about endourology cannot be mastered virtually as such. And the muscle memory cannot be downloaded. You have to do it on your own. You have to feel the difference. You have to make the mistakes and learn it yourself to a certain way. And the confidence cannot be observed, but it must be built over a period of time. And minimally invasive cannot be just minimally immersive. And that's the most important aspect of it. It all started with a fascination, like I said, back in 2012, 2013. And as I moved through my journey, the confidence came in, which to a point where I thought I can start contributing in terms of passing on whatever I've learned to the next generation in terms of contributing in my own small way. Thank you for the opportunity, Anil, to share this. And you're all welcome to join us for the Endo Euro, I know in December later this year. Thank you. Thanks a lot.
Thank you, Dr. Deepak. I would like to invite Dr. Chinnaketa Kitsuban. He'll be talking on the neurological management of stones in renal allograft. He's Associate Professor of Urology, Faculty of Medicines, Rahmatullah Hospital, Mahidol University, Thailand. He's a co-founder of Thailand Endourology Society. So, up to you, Dr. Chitaketa.
Thank you, Suman. First of all, my name is Chinnaketa Kisawan. I'm the Associate Professor from Thailand. I would like to thank organizing committee and Professor Anil to invite me for this event. They talked to me last 2 months about, you want to go here? Absolutely, I say yes, because Nepal is a very beautiful country, and moreover, is a place of birth of Buddha and Buddhism, so I want to, I want to come here. Today, I will talk about the treatment of the stone inside the kidney transplantation. Yesterday, we talked a lot with friends about the increasing number of kidney transplantation in the world. So you will see this problem in the future increasing because the stone, you face a lot in normal people, but in KT, if we do a lot of KT, you will face some problem as well. Video picture was approved by the patient already. And In Thailand, between Thailand and Nepal, we distant 3 hours. And I work in Lama Thipati Hospital. Lama Thipati Hospital is in Bangkok, and we are under umbrella of Mahidol University. It's a quite specific name, Mahidol. Mahidol is a surname. Thailand at present is a constitutional monarchy. I think like the Nepal in the past, but now we have a king in Thailand. Royal family surname of them is a Mahidol. So why my university called Mahidol? We follow from the surname of our king. And we work, I and Anil work as the ORSET. We have the new organization under UAA. We plan to help other country like in border of Thailand, like a Laos country. We plan to, in the future, next year, next 2 years, because there, in some country like Laos, they have only one surgeon in the country can perform PCNL. So I think it's one of the duty of some organization to help for the other country. We plan in next year and next 2 years to help them. Let me talk about the stone inside the allograft. Normally it not feel too much, it's just only 1%. And you can find this problem, you can see the problem after the kidney transplantation 1 or 2 years later, until the 3 years later. Normally inside the kidney, inside the KT stone, you have 2 types of the stone. One is a donor gift. It means that stone originally from donor is a gift from the donor. The second thing is a de novo. It happened later after kidney transplantation. The mechanisms of the stone inside the KT, including 3 things. First thing is the anatomic factor. If a surgeon perform the anastomosis not well, it can cause stasis, it produce the stone later. Or if you found, like this picture, my resident performed the urethral anastomosis and still have some suture grab the double J stent, it means that the suture material can cause the stone later. And the second thing is a metabolic factor. KT patient have hyperfiltration, KT patient have the hyperparathyroidism that cause the stone later. And some drugs that they receive, like immunosuppression, steroid, or calcineurin inhibitor can produce the stone as well. Normally, patients have the stone in KT. They don't have a pain. Not same with the normal people. Normal people have the stone obstruct the ureter, cause a pain, but in KT, not that. Because the nerve for KT no help. It means that why we not found pain is common in this patient. Normally, they present with a hematuria, that kidney dysfunction. UTI a little, and the location of the stone in KT normally found in the distal ureter, about half of the patient. The material inside the stone still be metabolic one. Same in normal people is a calcium base, but you will find the white stone in 20%. What the treatment option? The treatment option look like similar in single kidney. Start with the observation or medical treatment. The second is the ESWL. The third is the URS. The fourth is the PCNL. Open surgery, at present nowadays not recommend to do the open surgery. Start with the observation or medication. We recommend do observation or waiting or give some medication only the stone below 4 millimeter. The rate of success is only 60% if you observe or watchful or give medication in stone in KT. For ESWL, for the KT kidney allograft is put on the behind the the pelvis, human pelvis. So if you decide to perform ESWL, they must to put the position in prone position, not supine position. Success is not high, it's just only 66%. And EAU guideline recommend the ESWL only the size of the stone below 1.5 centimeter. Above this, not recommend. For the URS, success is increasing, right? From 60% is up to near 100%, but you will find some problem a lot because for the orifice in KT is not in normal position. Is a position of neo orifice is at dome or antria. It's difficult to insert the guide wire, difficult to insert the access sheet. So you may have some equipment help you, like a 70 scope lens for URS or cystoscope, or you may need some type of equipment called apparent bridge from Olympus company to help you to insert a guide wire, and flexible scope, flexible cystoscope may help you as well. For the PCNL in KT, I think it's quite, personally I just did the PCNL in KT last month. I think it's quite simple compared with the normal because the kidney close to the skin. It's just only, you don't have the muscle between the kidney and the outside because it put on the extra peritoneal. But they will have some dense scar cover it. When you dilate it, normally I use with the metallic one. Metallic dilation for balloon make hard to break the sheet, break the scar. And you must be aware when you talk. Please don't talk too much because risk of breathing. And antegrade ureteroscopy is one of the good things that you can use by antegrade PCNL, by the PCNL, even standard or mini PCNL. These are one of the antegrade URS. You can see, you can put the guide wire from above down to bladder, even outside to urethra. Is one of the benefit from antegrade one. These are antegrade one as well. And I will recommend you to put the second guide wire lateral to the suction, lateral to the sheet. It's safe for you. If you miss some, if you retract the scope out, it's a miss of the scope outside the track. If you found some donor have the stone, normally it's a contraindication, but in US at present, they are approved to get the kidney with the stone. But you have many options to treat. Done before, done after, or done simultaneously, retrieve the stone during the kidney transplantation. I will show you the case. Actually, I have 3 cases. The first case, 3 years ago, I got the kidney transplantation in rural area. They don't have the ultrasound, so I perform ECs in this patient. It's a quite big staghorn stone inside the kidney allograft. I performed the ECIS in this patient. It's quite big. It is I think it's a full white stone, staghorn stone inside kidney allograft. The recipient got this kidney. We don't know before, but after they got this kidney, we decide to remove the stone, and after that we confirm you that kidney functions still well. They don't have infection after that. It means that if you got some allograft that with kidney stone, you can proceed the surgery. This is the first case. We report this case to kidney transplantation. And the second case, very small stone, 1 centimeter, but the patient have UTI recurrent, so we decide to remove this. We start with retrograde first to see the stone, but I cannot to found, because it's a carrier verticulum stone, we cannot found the hole, so we decide puncture by the PCNL and use the ultrasound guide, use the mini PCNL to suction the character, the verticulum. And for the hole, for the verticulum hole, I used the TFL with low peak power, 1 Joule 2 Hertz. Very small energy to cut the hole and break the hole is a very good. And the final case, 2 months ago, I got this case. Some area in rural part of Thailand sent this case to me. They forgot the double J stent after kidney transplantation. They told me they removed it already, but they told me they removed it already. But after fluoroscope, AP, in our theater, you can see they are still inside the kidney. I start with the retrogate one and cannot to insert the retrogate to grab the double J stent, so decide into puncture as well, into the mid, and use the metallic one first. Metallic first, and then followed by the suction sheet, the clear beta sheet. And you can see, this is a encrust double J stent, even 2 months after kidney transplantation. Some stone found easy after kidney transplantation and be removed by the suction sheet as well. This is a double J stent after we remove. Thank you so much. I love Nepal so much. Thank you.
Next we call upon Dr. Rudradal. He's presenting on comparison between lower pole IP angle measurement by CT, IVU, and intraoperative pyelogram. He's a consultant urologist from National Academy of Medical Sciences, Bir Hospital, and associate member of EAU-ACT.
Thank you, sir. Good afternoon, chairpersons, and all the delegates present. At the outset, I'd like to thank the scientific committee for providing me the opportunity to present here. I'm presenting on a comparison between lower pole IP angle measurement by CT urogram and intraoperative pyelogram. It is one of the few variables of a study which we are conducting as an OSET collaborative study. It is a multi-center study. Lower pole nephrolithiasis is fairly common, accounting for about 1/3 of all the cases that we see. And management of lower pole stones is challenging in the sense because of difficult anatomical access, difficulty in fragmentation, mostly because of difficulty in access, and impaired clearance even after adequate dusting or fragmentation. These all are influenced by difficult lower pole pelvic calyceal anatomy, and it has been shown as a key predictor of stone clearance after flexible URS or shockwave lithotripsy. And to evaluate it, CT urography is being increasingly used. A steep IP angle has been shown as a determining factor in different studies. However, exact angle from which a cutoff where below which we can say it is difficult to access or difficult to determine stone-free rates is different in various studies. Some say less than 30 degree is significant. Some say less than 45 degree is significant. And some have said less than 70 degrees is significant to determine stone-free rates after flexible ureteroscopy. CT scan gives us a preoperative planning about the procedure, whether it might be a difficult flexible ureteroscopy or it will be relatively easy. However, operative feasibility will only be seen in the operation theater by intraoperative retrograde pyelogram. And there is a lack of validation between these imaging modalities. There are studies which show relative correlation of about 0.8 between the angles, and difference in the angle may be a cause for operative difficulty, because we might go into the OR thinking it will be a relatively easy case, and then it might be difficult because of what we see, which may lead to increased operative time and failed or difficult access to the lower pole. So in order to correlate between CT IVU and intraoperative RGP measurements of lower pole IP angle and the usefulness in predicting success to access of lower pole, we conducted this study, and we also wanted to find out whether the lower pole IP angle measurement by consultant radiologist and urologist matched, whether they correlated. We included all the patients with lower pole stones less than 2 centimeter undergoing RRS, excluded people with diverticular stones or who underwent previous open surgery or PCNL in the same kidney. We defined lower pole IP angle according to El-Banasi, which is defined lower pole IP angle as inner angle formed between intersection of the uretero-pelvic axis and the central axis of lower pole infundibulum. This is one of the cases where we measured IP angle, lower pole IP angle between CT urogram and the RGP picture, which showed about 65 degrees in the lower pole RGP picture, and similarly 64 degrees in the IVU. As I had mentioned earlier, it is a multi-center study that we are conducting with centers from Nepal, Thailand, Philippines, Singapore, and South Korea currently involved. Coming to the results, till now we have had 65 cases with a mean age of 59 years, BMI of 26, stone diameter of 12.3 mm, mean stone diameter, lower pole angle, mean lower pole angle by CT radiography is 48.8 by consultant radiologist, and lower pole IP angle by in retrograde pyelogram by consultant urologist is 50.7. There has been failure to access the lower pole with laser fiber in situ in 3 cases where relocation was possible. We did a blind Altman analysis to measure whether the measurement in lower pole angle by radiologist and urologist was in agreement, and we can see that most of the plots lie in the mean, near about the mean. That's why we can say there is agreement between the lower pole angle which was measured by radiologist and the urologist. And we compared whether CT IVU, when the urologist read the CT IVU and measured the IP angle, and when we did the RGP and measured the IP angle, whether it was in agreement. And this blind Altman plot shows that there is agreement between both the measurements. When we compared cases where there was easy access and failure to access, we could see the mean IP angle in easily accessible cases to be around 50 degrees, and failure to access was in about 40, the mean IP angle was about 40 degrees. Coming to discussion, how do we define success in flexible ureteroscopy? Only being able to fragment the stone might not account for being able to access the entire stone. Sometimes we can be able to visualize some part of the stone and start fragmenting, and we miss some part of the stones. So only being able to fragment may not be equal to being able to access the entire stones. Most studies have compared IP angle regarding stone-free status. However, we want to conduct this study and study IP angle regarding access, ease of access, and whether relocation is needed or not. Professor Inouye in 2023 showed that IP angle of less than 45.8 degree was a negative predictor for access to lower pole. In our study, we have shown that there is failure, in the failure to access group, the mean IPA was about 40 degrees. So it's similar. There's issues regarding CT urography and RGP. CT view may depend on patient, the angle may depend on patient hydration or position. And in RGP, the flexible scope or the catheter you may use may itself straighten the ureter and give a different IP angle. So even though these discrepancies occur due to patient positioning, contrast dynamics, or patient hydration, it was not seen to be significant in our study, and CT urogram and intraoperative pyelogram correlate quite well. In IP angle less than 40 degrees, we should anticipate a difficult access to the lower pole, and it may be better to relocate in view of better fragmentation or dusting, and also to limit the scope damage, especially in our part of the world. So we need to be prepared with a nitinol basket to relocate the stones. We have a relatively small sample size of 65. However, we are accrual is going on, and there is observer variability in the measuring IP angles. The studies have shown poor correlation between different observers of less than 0.4, and there might be the intercenter measurement, different measurement differences. Like I said, it is one of the parameters. Other parameters we are studying is the stone-free rates and the IP angle, operative duration and the IP angle, and Sampaio versus Albanese method on better prediction or ease of access, which would be better. I want to conclude by saying that there is no significant difference between IP angle measurement by CTI view and intraoperative pyelogram, and we should anticipate difficult access in IP angles less than 40 degrees. Thank you.
I invite Dr. Akash Chitrakar for the next talk on rethinking high-frequency RIRS. Key findings from systematic review. He is a consultant urologist at Kushu Hospital, Nepal.
Respected chairpersons, faculties, and all the delegates, a warm welcome to you all. So as the laser technology has evolved and progressed, so has the hunger and ambition of our urologists to fragment the stone more efficiently. And all of us have heard the saying that higher frequency is better. But is it really true? So I will show you the key findings of our systematic review that challenges this assumption. So this is what many of us believe and what many laser companies advocate nowadays. If you go for higher frequency, you can fragment the stone faster, you can make the dust more finer. That results in better stone clearance. And as most of the laser machines have higher frequency capabilities, they must be better. So what this has created is there's a recent shift in focus from low frequency to high frequency setting in hopes to achieve and improve the outcomes. With this, there is a significant practice variations among urologists, and also there is a rising concerns about complications, particularly ureteric stricture. Despite this, there is a limited evidence comparing high frequency and low frequency settings. And this is a gap that we tried to fill. Our objective was simple, to compare high frequency, that is more than 20 years, with low frequency, that is 20 years or less, laser lithotripsy, and patients undergoing flexible and/or rigid ureteroscopy for renal and/or ureteral stones, and to compare their operative outcomes and safety outcomes. So we conducted a study according to PISMA guidelines, and we registered our protocol prospectively in Prospero. We searched the Medline and MBES database from inception up to October 2025 to ensure that we only included highest quality of evidence. We only included randomized control trials, prospective comparative, and single-arm studies, and we excluded other type of studies. So when patients undergoing flexible and rigid URS were included, and also the lasers were holmium YAG, TFL, and pulsed thulium YAG lasers studies were included. And the key criteria was that the studies had to report the specific laser frequency setting that was used and had to report at least one predetermined outcome. The risk of bias assessment was done by using standard tools as mentioned here. So this is the PRISMA flowchart that shows that initially 971 patients were identified. After going through screening, we ended up with 22 studies. So this table shows the heterogeneous group of studies that were included in our study. So we can see low frequency studies starting from 2015 to 2025. The high frequency studies that are in the middle, we can see that most of the studies have happened in the last 2 or 3 years. And we could only find 2 studies that specifically compared low frequency and high frequency study. So interestingly, in high frequency studies, the laser frequency used are up to 200 to 300 Hz. And even high frequency setting are used even in the ureters. So what were the key findings in our study? So number one finding was that lasing time was comparable irrespective of which lasing frequency was used. So in low frequency setting, it was about 8.4 minutes to 68 minutes. In high frequency setting, it was 1.2 to 35 minutes. Interestingly, in a low frequency study, which had an operative time, lasing time of 68 minutes, they had a high volume stone, and just a short lasing time of 1.2 minutes in high frequency study had a small stone volume. And if we compare 2 laser technologies in both low frequency and high frequency, there is not much difference. If we look at the operative time, again, the operative time is comparable irrespective of using low frequency or high frequency setting. If you look at the 2 studies directly comparing low frequency and high frequency setting, the operative time is comparable. Again, when you compare 2 laser technologies in low frequency or high frequency, there is not much difference. So the determinant of lasing time and operative time was just stone burden. We also found that stone free rate was comparable irrespective of the lasing frequency used. In low frequency studies, it was between 67 to 100%, and again in high frequency, it was between 77 to 100%. In the 2 comparative studies, again, the stone free rate is comparable irrespective of the laser frequency used. Again, in the 2 different types of laser technology, the stone free rate is comparable. So what we found was that what determined stone free rate was how the stone free rate was defined in different studies, which imaging was used, and again, the most important thing was stone burden. So interestingly, in the included studies, we found that the reported incidence of ureteral injury was quite low. Even for ureteric stones, only there were 2 incidents of ureteric stricture. But we found that caution should be applied when you are using high frequency and high power settings for large renal stones, as they have been found to have high incidence of ureteral injury. The 2 studies recently published, which utilize high frequency study setting with high power for large volume stone, had high incidence of ureteric stricture. We also found varying trends of infectious complications that seem to be related to lasing frequency. In low frequency setting studies, fever was 1 to 10%, but there was no sepsis reported. In high frequency studies, the fever rate was between 2 to 6.7%. Also, they had sepsis of up to 2.9%. The RCT, which compared low frequency and high frequency setting, found that the incidence of fever in high frequency setting was almost 2 times higher than the low frequency setting. And in the FAN studies that were included, there were no sepsis reported despite of having high frequency used. Again, we found that when you are using high frequency for large renal stones, there's high incidence of infectious complications. Study in 2023 found that they had a high sepsis rate with high ICU admission rate when you are using high frequency for large renal stones. One of the interesting findings from our study was that bleeding was related to laser technology rather than the laser frequency. High incidence of intra bleeding in patients who underwent RRS using holmium YAG lasers. The 2 studies which used a low frequency setting found that when you are using holmium YAG laser, the incidence of intra bleeding was quite high. It could be related to the wavelength of TFL having higher water absorption. But there's a paradoxical finding as well. we found there's high incidence of post-op hematuria when TFL laser was used. The two studies found that when you are using TFL laser, the hematuria was quite high than when compared to Holmium laser studies. So it could be because the intra bleeding is related to bleeding from mucosa or vessel, which is better controlled with TFL, and post-op hematuria could be due to tissue sloughing and thermal injury, which was found higher when TFL lasers was used. So what does it imply is that we should start rethinking our approach. We should stop thinking that I need high frequency for better results. We should start thinking that about what combination is best for this stone in this patient. We should always try to access stone burden, stone location, and complexity of stone in each patient. Use conservative laser settings for larger stones, and try to balance between frequency, power, irrigation, and suction. The key takeaways from our systematic review is that efficacy, that is, lasing time, operative time, and stone feed rate is comparable between low frequency and high frequency settings. Caution should be applied when you are using high frequency setting for high volume renal stones. Bleeding was found to be more related to laser technology than frequency, and we should rethink about stone characteristics, frequency, power threshold, and try to apply adequate irrigation, suction, and also have knowledge about the laser technology that you are using. So I'd also like to acknowledge all the authors and collaborators who are actively involved in this study, and it was truly a team effort, and that made it possible. Thank you.
Thank you very much, Dr. Akash. I think there are some questions or comments from the floor to the speakers. Is there any questions or comments from the speaker for the speakers?
Hello. Hi. Thank you for the excellent session. I just want to ask Anil, our expert in RIRS. He's been using stone volume as a guide to flexible ureteroscopy. So my question is, what is your volume of stone that you limit to offer RIRS? Number one question in your practice. Number two, would you prefer a staged RIRS? Since you are working in a public institute, and I do the same, and operative timing and operative theater time is very important. So would you prefer patient counseling to undergo a single stage PCNL or a staged RIRS if you have a large volume stone? And as you and I always know that not only the stone volume, but stone density is very important factor in determining which volume of stone that you can dust in a single setting. So, Anil, thank you for excellent presentation.
Thank you, Dr. Bipin. Very nice question. The evidence of stone volume is actually coming up, and I showed in my slide that I think volume is a very strong determinant in deciding how long we are going to take. So in my practice, I generally do around 2,500 to 3,000 millimeter cube. So if it is less than that, then I try to finish it in 1 second. I generally don't do surgery more than 90 to 100 minutes. If I'm using access sheath, especially with suction, then I go up to 100 minutes. So if I don't use access sheath, the ureter is very tight, then the operative duration goes down to 60 minutes, sometimes maybe less than 60 minutes. So there are multiple factors to consider. Regarding how do you counsel for second stage with the patient? Of course, when the stone volume is larger than 2,500 millimeter cube, I always tell the patient that there is a high chance that we might look for second look flexible ureteroscopy when the stone burden is high. Yeah, the way we counsel the patient, I think I would agree, you would agree with me and most of us in the hall, including senior chairpersons, most of the times, few years back, we used to, offer the treatment modalities. Now patients, they ask for, they ask whether I can do 2-stage RIRS, even for bigger stones. So it's not only up to us. Definitely we offer single-stage PCNL, but there are multiple instances that patients themselves ask for. Even they have to do, even in government, even in private, when they have to pay out of their pocket, they still prefer 2-stage RS. But the answer for your question is, we generally give both the options and let them pick the suitable option for them.
No questions? So, we will thank all the speakers, excellent lectures, and the informative and educational. We'd like to thank all the speakers. We'd like to thank our co-chairs. Thank you very much. I want to end this session now.
So, thank you so much, dear chairpersons, for so well conducting this session. Before we break for lunch, I request our chairperson sirs and all our speakers who are there, and also my hall coordinators, Ishwar and Suresh, to come up for a short photo session, please.
Uttam Mehta sir, Professor Lee Jong Ming, and Dr. Suman Chapakai on the stage.
Good afternoon. I hope you had a nice lunch and you are not going to sleep now. So can we start the next session? And for the next session, that is on uro-oncology, can I request the first speaker, who is none other than the current president of the NAOS, Dr. Parasmani Shrestha. I don't think he needs any introduction, but still as a customary, I'll just read out. His topic is positive surgical margin after nephron-sparing surgery for renal cell carcinoma, clinical significance and management. He is a professor of urology, chief of unit, Department of Urology, National Academy of Medical Sciences, Veer Hospital, and senior consultant, Blue Cross Hospital, president of NAOS, which I have already told. Dr. Paras, welcome.
Thank you, Dr. Uttam. It's a post-lunch session, I can understand, but let's try to grab our attention for a while. Today, I'm going to talk about positive surgical margins in nephron-sparing surgery while doing RCC. I will come to the end why I chose this topic. As we know that this has been quite a gold standard now. Now everybody is doing it for less than 4 centimeter tumors. And incidence of these positive surgical margin in nephron-sparing surgery is about, it varies quite a lot from 0.4 in some center and I has 15% in some center. So they have a systemic review by this Marjakel in 2012. It would say about 3.7% in average. So you can see the ranges vary in different studies. And as we know, we all try to achieve this so-called trifecta while doing partial nephrectomy for renal tumors, described by Intergill group in 2013, like we need negative cancer margin, minimal renal function decrease, and no urological complications. So looking at the risk factors of positive surgical margins, the first would be tumor related. If the size is more than 4, if it is a high grade, and if it is a tumor location is quite central or hilar, and if it is an infiltrative growth or presence of necrosis and sarcomoid features. So patient-related factor can be said like if the BMI is pretty high, maybe dissection may be difficult in the renal area, prior renal surgery or radiation, and if it is related to the hereditary renal cancer syndrome like VHL. So surgical factor, it can be debated, do we do better in laparoscopy or robotic, but still not so conclusive about this compared to the open. Surgeon's experience of course matters, and intraoperative complications, if you have bleeding or if you have a longer warm ischemia time, you tend to have positive surgical margins. And of course, if you have a high renal score, then you might expect positive surgical margins. So, talking about the surgical technique, as you see, these incidents vary in open, laparoscopic, robotic, is not really significant in different studies. So, which one you choose, does it really matter, is still the question of debate. And of course, we can use the strategies like if you have very central tumor, we don't have it. So, Indo ultrasound during the intra-op period. Frozen section is still debate, does it help or not? Because we don't have much time in between the surgery because we are clamping the vessels. Enucleation or partial, which one you choose, or lab or robot, as I told that it has not shown that the robot is superior while doing this kind of surgery to achieve clear margin. So what is the clinical significance of this positive surgical margin? And we can see it in 3 aspects: oncological outcomes, local recurrences, and overall survival. So traditionally, if we think as a surgeon, as we are taught, if the margin is not clear, then you are in trouble. You should go and correct your procedures. But in positive surgical margin, it doesn't look like that. They have many ways they have shown that it appears that it has a very negligible impact, at least in survival of the patients. And there is a big meta-analysis into 2021, 42 studies, 30,000 patients, and positive surgical margin were associated with, of course, increased risk of local recurrences, but it did not significantly impact the cancer-specific survival in many cohorts. So local recurrences happen about 5 to 15% of these cases compared to 2.5 if you have a surgical margin cases, and the majority of patients with positive surgical margin, however, remain disease-free even in a long surveillance. So in this French multi-center study, they did robotic partial nephrectomy, and they've seen that there's no impact in surgical outcome, at least short term. However, it has been associated with if you have a long ischemia time, if it is chromophobe RCC, and if there's a lower renal score, they are associated somehow with the positive surgical margins, which is quite strange for us. As I told you, maybe higher, but they have so low score, maybe surgeon become too confident, I don't know. So positive surgical margin in solitary tumors, in this study, they have seen 3.2% of the patient, and in a long follow-up, like 77 months, they have found that their extended follow-ups found a substantial impact on PSM, on likelihood of recurrence. So I would really like to quote this study as one of the focus of my talk, like the patient with this PSM should have to focus mainly on this pathological features of the tumor, because prognostic is not very uniform. If you even go to the guidelines, they will not be able to guide you if you have this problem. They have said things which may not be helpful. You have to decide on your own. So basically, you have to focus on intrinsic mechanical potential of the primary lesion for surveillance schemes should be kept very rigorous if you have a high-risk patient, that means the higher grade tumors, and minimal prognostic relevance if you have low-stage, low-grade tumors. So this may not necessitate that kind of aggressive follow-up. And in the study, the positive surgical margin, they have lymphovascular and neurovascular invasion has correlation with the recurrence. However, no difference in overall survival of these two comparable groups. So how would you manage once you have a report, within a week we have report after your surgery, what would you do? You would be confused. Shall I go in? If you go to guidelines, you're confused, then you have to have a very accurate evaluation of different clinical aspects, pathological features of tumor, evidence currently available in literature. You know, you have to go back to the literature because guidelines there is no such thing called gold standard. And what are the management options? Active surveillance, salvage radical surgery, go in and again, or repeat partial nephrectomy to get a better margin. And of course, you can get some adjuvant therapies in these patients. So, as I told you before, active surveillance in low-risk patient would be a good strategy because this patient doesn't need any aggressive surgery one after another to have a clear margin. And optimal manner seem to be a very vigilant surveillance. And there are numerous studies to say that they advocate that surveillance is good enough for this kind of patient with, we have low recurrence, and there is very rare metastasis in these patients. And these are some comparable studies, some with different follow-up. They have seen no recurrences. And going to a bit aggressive approach, the salvage radical nephrectomy or redo partial to get a margin. This study has shown that delayed or immediate radical nephrectomy may not be an optimal treatment for all. You cannot use it as a blanket, but because they have done in 114 patients, 17 they did this partial, whereas they had undergone again second nephrectomy as they have positive margin in 9 patients, 5 immediate and 4 delayed. So only in 2 patients, which they did immediate, they still have the remnant tumors, whereas those who did delayed one, they couldn't even find the tumor. So, as we know, we lose nephrons while you do this kind of LRP surgery, and the patients are subjected to the chronic renal disease and even renal failure, and overall mortality may be higher in this kind of approach. So these patients only be chosen in a very aggressive kind of tumors. If you have higher grade tumors, then you might think this kind of approach. And for the pathological factors, the low potential malignancy would be type 1 papillary RCC, chromophobe, oncocytic cells, whereas high potential malignancy would be clear cell RCC, type 2 papillary, and tumors associated with sarcomoid, or if they mention about necrosis in the tumor specimen. So, adjuvant therapies have been described, radiotherapy, frequency and cryotherapy for these patients. However, there's a disadvantage. You don't have any histological examination specimen after this, and it may alter your overall follow-up in the radiological pictures later. And of course, you are losing some nephrons while doing this kind of procedure. So now, what if you have now already have a recurrence in your hand after a few months? Then, as I said before, you should really think only your decision should be based on your how high grade is your tumor. You know, this would really reduce your load of redo surgeries or radical this thing. Once it happens, then wide surgical excision, ensuring negative margin is a must, or you go for radical surgery. Then the morbidity really goes high, as 50% in these cases, and it may be complemented by some neoadjuvant radio or medical oncological therapy for such patients. So why I would go for this case, because we have this case, we did partial nephrectomy for RCC. This score was about 9, and we had a report of clear cell RCC grade 3, and we have positive margin. So at that time, we were really into surveillance only, so we kept on surveillance. This patient came after, this is from remote place, he came to us in 6 months' time, there was no recurrence. But he lost in follow-up, he came after 18 months because he has some GI symptoms. So when we did the CT, then we found there is a mass on the recurrence on the same side, the right side, and there was loss of fat plane with the duodenum. And we sent them for the endoscopy and they did a biopsy, and the biopsy came out to be RCC positive. So now we have to think of very big radical surgery because duodenum is involved. So we did this surgery with gastrosurgeons, and this is a big specimen, radical nephrectomy with Whipples. We have to do this, and which was quite, of course, invasive to this patient. This patient still have complication of pancreatic fistula. This was done like about 2 to 3 months ago, and he's still on a follow-up. So this particular case really intrigued me to go into what should we do about this positive margin. And that's what the theme of this talk is all about. So this was the histopathology report. This showed it was infiltrating tumor, RCC, clear cell carcinoma, grade 3 tumors into the duodenum. And there were even a small bowel nodule came out to be positive. So it's already T4M1 disease. So definitely prognosis has really gone from moderate good to bad now. So the take-home message is there is no uniform prognostic. Once you have positive margin, you cannot blanketly say we have to do, definitely have to do this. This has to really focus on your intrinsic malignant potential of the primary lesion with low stage rogue-led tumor. These have better prognosis, so you can keep on general surveillance. But with a high-risk patient, you may think of aggressive step like redo or do a radical surgery. And of course, the best thing is to do is not to have positive surgical margin. Try to follow the standard procedures and get a negative margin. Thank you, and I would like to once again emphasize on our next meeting, which will happen in Kathmandu, 2027 March, early March, which is a combined summit with UAA with our Urocon 2027. Thank you.
For us for the nice presentation. Because of the time constraint, most probably we are not going to allow any questions. Just only one comment. Like whenever you are, you see, he had mentioned so many factors for PSM, but I think surgeon-related factor is very important. His experience as well as technique. And the technique-wise, when you are going for a robotic partial nephrectomy, you should, point your seizures away from the tumor, not towards the tumor. That is one point, just simple. So, can I have the next speaker? Thank you.
Thank you so much. So, our next speaker is Dr. Abhishek G. Singh. So, he will be talking for partial nephrectomy in a solitary functioning kidney. He is consultant urologist from Muljibai Patel Urological Hospital, Nadiad, India. Welcome, Dr. Abhishek.
Hierarchy of nows, senior faculty members, and dear friends. I am Dr. Abhishek Singh. Today I will be speaking on partial nephrectomies in renal masses with solitary functioning kidney. I have nothing to disclose. As Paras sir rightly pointed out, trifecta is what you look for when you're doing partial nephrectomies. Achieve an R0 with maximal functional preservation with minimal complications. Unfortunately, the story is not so simple. There are certain things in doing what you do that you can modify and certain things that you can't. And solitary functioning kidney or CKD status is unfortunately something that you cannot modify. Given this situation, ischemia time, resection, suturing techniques, and how much parenchyma you preserve in this delicately balanced patients is something that you can change. Whether you do this open, laparoscopic, or robotic, it is not going to make a difference. Only thing is that doing it robotically probably arguably is more replicable, and you can record all your videos to present it. Volume preservation definitely matters, so does warm ischemia. The warm ischemia generalizably in 2-kidney model is not going to make a difference. But when you come to solitary functioning kidneys, CKDs, every minute spent beyond 25 minutes, as Dr. Gill had shown in this particular paper, increases the incidence of AKI by about 5%, which may not return to normal. When you are doing a partial nephrectomy in a solitary functioning kidney, the very important tool that you need to have is an intraoperative ultrasound so that you mark the boundaries precisely, save what is necessary to save, and take out what is absolutely essential to take out. So I would say warm ischemia, resection, suturing techniques, and parenchyma preserved are the important factors that will govern what will happen. And to prove what you are doing, you may require selective clamping, super selective clamping, off-clamp techniques, and we'll see one by one. So this is a story of a 43-year-old gentleman, right-sided nephrectomy done about a month back, and now he has 2 masses in the left-sided kidney. Creatinine after first nephrectomy is 1.1. So this is the situation, 2 masses, lower pole. Analyzing the anatomy, something favorable, there are 2 renal arteries. So lower polar artery and upper polar artery, though the tumor region is also supplied by upper polar artery. So you mark the tumor well using an intraoperative ultrasound. Surely enough, put a clamp only on the lower polar vessel to begin with. You might run into the normal parenchyma supplied by upper polar artery, which you can see in this ICG figure, but you learn to live with that vascularized portion of parenchyma and start resecting. So here we were able to complete the resection well, and the rhinography was done. So this is one situation where actually the nature favored the surgeon, and this was the revascularized parenchyma. Histology was in T1A tumor, and the baseline creatinine now at 1 year is about 1.69. Now let's talk about off-clamp resection in a complex renal mass. So this is a story of a gentleman who has left-sided poorly functioning kidney. And the right side upper polar mass, the size of the mass is about 9.5 centimeters. Good thing is that again he has a supply by 2 renal arteries, but the problem, and 2 renal veins also, but the problem is that the mass is overhanging the upper renal artery and going behind the vein. So this is the lower renal artery, this is the upper renal artery. The plan was that we'll try to take the feeders independently, which are supplying the upper polar mass. So we take the main supply. So this is the upper polar artery. There is a main supply to the tumor that we'll soon take. Before actually embarking on resection, what you do is you separate the tumor completely off the upper pole from the adrenal, from the posterior abdominal wall and lateral abdominal wall. Mark the tumor boundaries using an ultrasound. So if you've gone till this point, any point and time that you land up in problem, you can definitely go ahead and clamp first the upper polar artery, and if the need be, the lower polar artery. So this is set up. The first vascular structure that I encountered was a major venous channel supplying the mass that was taken. An ultrasound was done after taking the major supply to the upper polar artery, upper polar tumor, and then you mark the boundaries and confirm the boundaries again. Now, upper pole was lifted along with the tumor, and whatever was supplying the tumor, we decided to take till we met the parenchyma. So we were marching on the upper border of the upper renal artery, and whatever was supplying the tumor, we kept on taking that. Once the artery started entering the parenchyma, we also started to enter the parenchyma. And gradually we realized that 3/4 of the tumor was already down, and we did not have to clamp anything. The last 25% of the dissection, the upper pole did bleed, but it was manageable. And by that time we had got the margins absolutely clean. So we braved that amount of hemorrhage and decided to complete the excision. So it went on to be a clampless polar nephrectomy for about a 9 centimeter tumor. And then we sutured the parenchyma in conventional technique. using a sliding scale rhinography. Here we decided to use the inner and outer layer, incorporate both of them in the same stitch, and do it like a sliding rhinography. So case went off well, no ischemia time, patient recovered well. At 1.5 years, his creatinine was still around 1.5. Actually, he presented the last month with the rising PSA, and we did a biopsy, but fortunately, he did not have prostate cancer. So that was the second case. Now, there can be situations which present with multiple tumors. So this is a 65-year-old lady. We did a right open radical nephrectomy with caval thrombectomy. 1.5 years later, she presented with multiple tumors. On the first scan, we could count 5. And then when we did a reconstruction, we could find the 6th one. Here, she had a single renal artery and the vein. We looped the artery and vein. And the plan was to completely go intragerotally and expose the entire kidney and try to find out how many tumors are there. This was the first tumor. With the ultrasound, we marked it. Then came the second one, the third one. So every time we found a tumor, we kept on scanning it and marking the boundaries. That's the third tumor. So that is the fourth one, baby tumor. Fifth one. And behind that, we could see the 6th one. To our surprise, we found a 7th one also, which was not reported. But because we were totally intragerotal and the plan was to scan the entire kidney, we could see a few more. We went with a working plan that we'll start to enucleate whatever we can without going on clamp. And whenever we thought that it is bleeding more or we are not able to see things, we would go on clamp. And there was one tumor which was relatively endophytic. For that tumor, surely we would clamp the artery. So this is the third tumor. This was the tumor which bled for the first time. The base, the other two were pretty straightforward. So we put in one Surgicel, packed it with another one, and did the bolster rhinography as you would do in yesteryears. So we were still off clamp. The third tumor was over, and this was the biggest tumor. Out of the 7, 3 were really big. So we got one big out, and this was the baby tumor. The fourth one, we just packed this with Surgicel. Fifth one, this was slightly biggish again. Here also the base started bleeding a little, but we decided to go off clamp. But at this point, I thought that the next tumor which is endophytic, and we'll just pack this for the moment. We'll go on clamp, remove the other 2 tumor, and also suture this later on. So this is the 6th one. Went on clamp. Resected this, and there was one immediately behind this tumor. The marking was already done beforehand. So it was only execution at this point in time. So that is the 6th tumor, and then the 7th. The use of cautery usually in a single tumor is not this much, but in this particular case, we thought the more we can cauterize, the better it is. And after this, we sutured the remaining fossa together, put some Surgicel, used a hemostatic product, which in this case was Surgiflow. And then something that I did was, I had the 2 leaves of Gerotas remaining, just covered it up so that just in case tomorrow we have to do a radical, because this is surely a syndromic situation. So my guru, Dr. Mihir Desai, taught me to do this, and whenever he did this, he said, see no sin. So whenever I do this, I tell myself, see no sin. This is a similar situation in a large tumor with, again, 2 renal arteries. This appeared actually extremely exophytic. So I thought, again, by clamping the lower polar artery, I'll be able to get away with this. So that's the lower polar artery. I started resecting it, and to my surprise, there was a significant supply from the upper polar artery. So I ran into the pelvic ileal system big time. And this patient actually had a lot of leak post-operatively. Eventually, everything settled at around 1 month, and his creatinine stabilized to about 1.6, 1.7. So that is the vascularized parenchyma at the end. One more thing that can help us in this situation is crown rhinography. So what you do is, if there is a central tumor, then you will get a fossa like this. And on the medial edge of the fossa are vessels. So what you could do is go just over and over and use the adjacent parenchyma with clips. So the ultimate formation will be like a crown. You call this a crown rhinography rather than conventional rhinography. So this technique can help you save more parenchyma in critical situations. So I would conclude by saying that maximize results, minimize complications. It is perfectly okay to be defensive. If you think open is better for you with cooling, then so be it in solitary functioning kidney. Be detailed. The devil in partial nephrectomy is always in the detail, and chance will always favor a prepared mind. Competence is of utmost importance. Yes, technology is going to help you, but it is a surgical knowledge which is going to prevail. As my teacher, Dr. Mallikarjun, always says, that fool with a tool is still a fool. Thank you for a patient listening. Thank you.
Thank you very much.
Thanks.
The next speaker is Dr. Ganga Khater from India. He is the chairman of Somatic Kidney and Urology Institute. He is good at robotic surgery and oncology. His topic, let me see. His topic is beyond conventional boundaries in partial nephrectomy, define limits in the robotic area. Thank you very much.
Yes, sir. Thank you for the kind introduction, respected chairpersons, dignitaries of the Nepal Association of Urological Surgeons. I'm really grateful for the opportunity to be here. The topic that I'm slated to speak on is related to the boundaries of partial nephrectomy. And I think Dr. Shrestha and Dr. Abhishek have actually given such solid foundation to this particular topic that it has made my job relatively much easier. Every generation of surgeons tries to push the boundaries in every single surgeon, and partial nephrectomy is no exception. I think one of the biggest technological advances that has happened in our times, which has helped push these boundaries, is the advent of robotic surgery. But what are the conventional boundaries that we deal with when we talk about partial nephrectomy? Large tumors, hilar tumors, multiple bilateral tumors are all technically demanding and don't just require precise surgery, but also precise decision making. Similarly, like Dr. Abhishek showed, solitary kidney can pose its own challenges. Now, what robotics has changed is made the vision and the dexterity of the surgeon much more replicable, much more teachable, and much more precise. And that is why, while doing a robotic procedure, you can actually precisely see the plane that you need to go on. You can identify the capsule of the tumor. You can dissect slowly, meticulously, with stability of the camera and precision of the instruments. This ability to do precise surgery is something that has made doing a partial nephrectomy greatly pleasurable and also having much better outcomes for the patient as compared to the yesteryears. Now, when you look at bilateral tumors, the priority is, of course, to preserve the function of the kidney and to do a proper parenchymal mapping and do a reconstruction strategy which will allow us to preserve maximal parenchyma and at the same time make sure that we remove all the tumors that we can see. Now, in this particular situation, preoperative planning is of immense benefit. This is a young person with bilateral VHL-associated tumors. larger tumors on the left side, in which we did a bilateral partial nephrectomy sequentially in a staged manner. But before we did anything, we initially did a three-dimensional reconstruction of the kidney and the tumors to locate the tumors and the surrounding areas. What I'm trying to look at here is not the tumor, but the normal parenchyma, to be able to plan clearly what parts of the normal parenchyma I can preserve and how I can do that, what would be my dissection strategy, what would be my reconstruction strategy, and how I can minimize the warm ischemia time in this situation. So we first did the left side, and we were able to preserve about maybe 40 to 50% of the kidney, and most of these tumors were removed with zero ischemia technique, with the larger one being done with the on clamp. And similarly, the right side tumors could all be removed, enucleated, without instituting warm ischemia. Now, if you look at hilar tumors, they require a different mindset. I think the most important thing is to look at the vascularity first. A precise hilar exposure and a clear plan to control the vascular structures is the first and the most important thing that you can achieve for a hilar tumor. Now, again, three-dimensional reconstruction really helps. Now, this is a tumor which you can see in the left kidney, right in the middle of the kidney, and completely endophytic tumor in the hilar location surrounded by vasculature. If you do a three-dimensional reconstruction, you can actually find out the relation of the branches of the renal artery and the renal vein, and able to dissect out subsequently precisely what the vascularity is. This patient had a single renal vein and two renal arteries, and with the dissection that we have done, we know exactly where to achieve the control, where to clamp, which segments to clamp, and how to go about the dissection. In this situation, it's always better to clamp separately. Sometimes you just have to clamp one artery, sometimes you'll clamp the artery and the vein, like we have done in this situation. And now we have a clear picture on how to approach the tumor and do the enucleation of the tumor. Another important thing that we have seen is that doing a selective or a segmental clamping is very much a possibility in patients who've got even hilar tumors or otherwise. And here you can see that the lower branch of the renal artery is being selectively clamped. The vein, of course, is left unclamped. And by doing a firefly ICG, you can actually see a clear line of demarcation where you're going to do a partial nephrectomy in this situation. And doing a heminephrectomy in this case became very easy without actually instituting global ischemia. I think one of the most challenging aspects in this situation is to be able to remove the tumor with negative margins. Because in a hilar tumor, by definition, you will not have parenchyma on most of the sides. The lower part of the tumor or the internal part of the tumor will not have any parenchyma surrounding it. It will just be sinus fat, vascular structures in the pelvis. So again, left central hilar tumor, which we did a robotic partial nephrectomy on. 3D reconstruction, again, vital in this situation for a clear planning. Kidney is completely flipped to our side. Intraoperative ultrasound essential because you can't really see the tumor from the outside. There is no exophytic component of the tumor. So after flipping the kidney, we carefully mark out the parenchyma, and then we start cutting the tumor after instituting ischemia. And here you can see that the parenchyma ends at a particular time, at a particular point, and then everything is enucleation. Here's where robotics and precision, and to be able to do this slowly, deliberately, to be able to identify the plane perfectly is most important. And you can even see a dumbbell-shaped extension of the tumor which has been removed with clear margins in this situation. So doing this precise planning is essential to be able to to be able to meet or extend the boundaries in patients who require difficult surgery. Again, you've removed the tumor, but reconstruction plays an extremely vital role which cannot be substituted. The most important thing is to assess the defect first. How am I going to reconstruct it? Will it require a single layer, multiple layers? Does the collecting system need to be repaired as well? What is the extent of the defect in the collecting system? All these things have to be considered before you decide how you're going to reconstruct the tumor. And again, to be able to precisely place 4 zero sutures with perfect stability, to be able to close the pelvic ileal system here precisely without needing to put in a stent or a ureteric catheter is something that has helped difficult cases become easy with the help of robotic surgery. I think this kind of precise placement is may not be possible even with open surgery, with the kind of magnification and the stability that you can get with robotics. But I think the most critical factor is taking the right decision regarding the strategy of internal repair. Again, internal rhinorrhaphy can be done in a number of different ways. In most of the cases, we would use a V-lock suture, a continuous running suture through the defect. This should be done after you have closed the pelvic ileal system, because pelvic ileal system requires more precise closure. Running the rest of the defect through this is very important, but a word of caution: if you're dealing with hilar tumors, we should not be doing this kind of an inner rhinorrhaphy on sinus fat, because you don't know what lies below the sinus fat. You may be going through a major vein or a major artery, so this can only be done in the parenchymal part in more peripheral tumors. Now, once you have done the internal rhinorrhaphy, do you really actually need to do an external rhinorrhaphy in every single case? The answer we are increasingly discovering is no. In fact, if the hemostasis has been achieved perfectly, if the PCS is securely closed, then using just an oxidized cellulose patch to cover the defect, to give you the hemostasis that you need without overcompression, without compromising renal function in the periphery, in the edge of the parenchyma there, is something that is very much achievable. And about 50% of the cases that we do for partial nephrectomy, especially the easier ones, and even the hilar ones where reconstruction is more difficult, we just use the oxidized cellulose patch to be able to omit external rhinorrhaphy altogether in this situation. But I think it's very important to recognize that boundaries in partial nephrectomy still and will always exist. The most important part is knowing about the tumor biology, knowing about the size of the tumor, the extent of the invasion of the sinus, pelvic ileal system invasion, maybe a small thrombus in a segmental vein which will give you a clue about possible future clinical behavior, is something that can never be ignored. And not all patients, not all tumors definitely, are candidates for a partial nephrectomy. Again, would I do a partial nephrectomy in an 80-year-old lady with an ejection fraction of 25% when the opposite kidney is normal, even if it is a 3-centimeter tumor? The answer is no. I have to figure out, I have to balance out the potential benefit of a partial nephrectomy in terms of renal function preservation against the perioperative risk. So patient physiology is again an important factor which helps us in deciding whether to do partial nephrectomy again. We also have to look at whether our institution is ready. Is there a proper ICU setup, an interventional radiology setup, ability to handle complications within the system? Do we have the support that we need from the institution? That will help us shape. And perhaps one of the most important factors is our own learning curve. Even not only with generations, but as we grow more experienced and older, we are able to push the boundaries just because we have that experience and that team which will support us with us at the same time. So as the number of cases and as the times become, your experience becomes more, we are likely to be able to push the boundaries more. So to conclude, there are 3 important factors which will help us in deciding whether we can do a partial nephrectomy in a particular case. And they are just, I may be oversimplifying it, but just to say, can I see it clearly? Can I control it safely? By control, I mean the vascular structures, but also how we are going to kind of take the decision around the partial nephrectomy. And can I reconstruct it reliably? If the answer to any of these 3 questions is maybe or no, then maybe partial nephrectomy is not the right approach in that particular patient. Thank you very much for your time.
Urocon, I think it is. Any questions, or we are not allowing any questions because of the time constraints? Okay, thank you. So thank you, Gagan. Can I invite the next speaker? Is none other than from NOWS member, Dr. Pratik Singh. I think he is the robotic surgery fellowship holder from US. He is the senior consultant urologist and robotic surgeon, Chitwan Medical College, Bharatpur. So Dr. Pratik, time is yours. And he's going to talk about, so let us leave their kidney now, come back to prostate. So he's talking something about the prostate. Okay.
Okay, good afternoon, everyone. Namaste. Thank you for the opportunity to share the ongoing work at CMC. We started, as you know, robotics a few months back, and we've done a handful of cases. And yesterday, I think my remit was to focus on the kidney. Today, I'm just going to illustrate with a few examples of robotic application in the prostate. So what I'm going to do is just share with you a few videos of robotic simple prostatectomy and compare and contrast it to robotic radical prostatectomy. So this is a simple prostatectomy video. I'm just going to speed it up a little bit in the interest of time. 4 robotic arms, 1 assistant port, and fill up the bladder with the catheter and then approach the bladder to get entry into the bladder. You can fill up the bladder to delineate the bladder anatomy. Okay. You know, you have the extraperitoneal approach with the Millens technique, which is also can be done robotically. So this one that I'm going to be sharing with you is one which is the transvesical approach.
Gauss. He will be talking on the robotic ureteric reconstruction across pathologies. So he's a consultant urologist in Asian Institute of Nephrology and Urology, AINU. Dr. Gauss, please.
Good afternoon, respected. I would like to thank NAUS for giving me this opportunity. And I shall be speaking on robotic ureteric reconstruction across different pathologies. Yeah. So what are the factors that define reconstruction for the ureter? That depends on the level of the ureter that is involved, that is whether it's an upper ureter at the PUJ, mid ureter or the lower ureter, the length of the diseased ureter that is involved in the pathology, and what exactly is the pathology that has led to this sort of an injury or a obstruction to the ureter, and the function of that particular moiety of the kidney that is there. All these factors define how we reconstruct that particular ureter. So let us see with few examples. Here, a young male, a radiologist himself, underwent a RIRS for a lower calyceal renal stone. Mind you, it's a renal stone, and undergoes stent removal at 3 weeks, and post stent removal at 6 weeks, he presents with flank pain again. Undergoes imaging, see the hydronephrosis, undergoes PCN placement outside. And this is a nephrostogram with a total cutoff in the upper ureter. I remind you again, it's a lower calyceal stone, not a ureteric stone, so there was no laser used in the ureter, but still he developed a ureteric stricture, probably because of the access sheath itself. So this was an RGP with a total cutoff and a annular narrowing in the upper ureter. So robotic ureterostomy was contemplated, and that is the mobilization. To identify where the segment of ureter that is involved is better to have a ureteric catheter till the level of the obstruction, wherein we can tactile way of finding out where the narrowing is. So that is a ureteric catheter through which we can feel and identify the area of obstruction. The proximal extent of the obstruction can be identified with the dilated ureter itself. So that was a proximal incision, and that is a strictured segment. So once this is done, it is always good to have an approximation and see whether the edges are coming together before we totally divide the strictured segment. Because if it is a longer segment, the edges might not come together altogether. So this is a identification whether the edges are going to come together or not, and that is the excision of the strictured segment. One or two sutures are now taken interrupted so as to get the edges together. Stunt is placed and rest of the sutures circumferentially are completed. So that was a ureterostomy for a annular narrowing on a left side upper ureter. That is a completion. This was his DTPA at 3 months with a fair good drainage. A second scenario, a young male left upper ureteric calculus 11 mm, undergoes URSL. There was an avulsion during the URSL at the upper ureter. Open exploration and suturing was done by the attending urologist, but there was a post-operative leak which settled at 3 weeks, and multiple exchanges and PCNs were attempted, but still you had an obstruction with a functioning kidney. So we had to go in and repair it. And this was an RGP that was seen, though the defect appeared to be very small, but as and how we dissected and reached the area of injury, we can see that this area is virgin, was very clear to approach, but as and how we reached the area of the injury, it was densely fibrosed. It was difficult to identify where the ureter itself is. So that was a dilated pelvis, and that is the ureter being separated off its fibrotic surroundings. So once the ureter was identified, again with a ureteric catheter in situ, we could give an incision on the normal ureter or the dilated, not the non-strictured part of the ureter, and a longitudinal incision was continued from the normal ureter onto the strictured part and continued onto the area which is normal proximally. So that was a proximal extent where you can see the free flow of urine from the obstructed kidney. But here we could not get the edges together just because this is a post-urinary leak scenario where the entire ureter is stuck to the psoas muscle. The segment of the ureter that needs to be augmented was identified with the ureteric catheter measuring the defect. A buccal mucosal graft was taken with a prefixed vicryl suture. That is a proximal fixation. With the ureter only laid open, it was like a urethroplasty where we augmented with a buccal mucosal graft. So that is one layer of the buccal mucosal graft being fixed to the one edge of the opened up ureter. A stunt is placed, and then the rest of the other side of the buccal mucosal graft is sutured. So that is the completion of the buccal mucosal graft ureteroplasty for an upper ureteric, a long segment ureter with a urinary leak where we couldn't do any end-to-end anastomosis. This was a 6-month DTPA scan which showed a fair good function and drainage. This is a case of a young male who had it was a known case of chronic calcific pancreatitis, underwent a celiac plexus block by a medical gastroenterologist, and at 2 months present with pain, abdomen and vomitings with a large urinoma and a collection anterior to the kidney. So immediately a PCN was placed, the urinoma got drained, and a nephrostogram after 3 days showed a cutoff and a cicatrized pelvis. We have left the PCN for some while, and 3 weeks later a cicatrized pelvis, pelvis and ureter could not be visualized with a large defect. So we have a long segment stricture here at the POJ with a dense periureteric fibrosis because of the alcohol that was injected for a celiac plexus block, and the structures are all fixed because of the dense fibrosis. So here we contemplated doing a ureterocalicostomy rather, because the entire ureter is all cicatrized in the pathology. So that is again identification of the ureter. Ureteric catheter used to identify where the opening is. That is the attempt to identify the pelvis, and we could see only the hilar vessels, nothing else. So now a renal distensis was planned and the kidney was mobilized slightly lower down so that the ureter can be anastomose to the lower calyx. So that is the incision onto the parenchyma to excise the lower pole. Once this was done, the calyx could not be visualized because it was not a long-standing obstruction with a not a dilated lower calyx. So again, one more donut of parenchyma was excised so as to reach the lower calyx. So even then the calyx was not seen, but we could see a papilla. Once that was excised, we could see the lower calyceal infundibulum. Maturation sutures or eversion sutures of the lower calyx were taken so as to prevent it from cicatrization in the post-operative period. So that is the maturing sutures or eversion sutures of the lower calyceal infundibulum. Rhinography was commenced on both the sides and only the center part was left. So once this was done, that is a medial rhinography. The only thing that was exposed was the calyx with the surrounding parenchyma, that is a spatulated ureter and a few parachuting sutures taken from the calyx to the ureter, stent being placed into the ureter and into the PCS. That was a ureterocalycostomy for a totally cicatrized renal pelvis and upper ureter, and that is how a robotic ureterocalycostomy was performed. This was an IVP that was done for the same patient 4 months later, which showed a proper drainage through the lower calyx into the ureter. This is a transplanted male, 60 years, who had a rising creatinine and on evaluation found to have hydronephrosis and multiple attempts of stenting, ureterotomy, laser incision onto the ureter and PCN was done. But finally, again the entire ureter got stenosed because it was a BK virus ureteric stenosis that had happened. On DTPA, it showed an obstruction of the transplanted kidney. This was an attempt to do an RGP as to find out this was the 10th attempt of doing an RGP for this case. We couldn't negotiate the ureter at all. So a robotic attempt was made to anastomose the native ureter on that side to the dilated pelvis of the transplanted kidney. So that is the native ureter being dissected out, just medial to the kidney that was placed there. Once the native ureter is mobilized, a proximal end of it was looped, and then the proximal end was clipped and divided. And that is the dilated pelvis onto which the incision was given, and that is the anastomosis of the ureter, like how we do it in a pyeloplasty, to the native ureter this time. This mimics a pyeloplasty with a native ureter now. The patient's creatinine is stabilized now, is doing well even now. This being a medboard session, we have a session of medboard surgery also. So this is a 32 years female with a deep infiltrating endometriosis, underwent ovarian cystectomy and bilateral ureterolysis by a gynecologist, and presented with bilateral flank pain. Attempted stenting elsewhere but could not. This is an RGP picture of bilateral gross hydroureteronephrosis. And this is the medbot bilateral Bori flap, which we call a smiley Bori flap. That is a dilated left ureter being mobilized. The entire pelvis is frozen. None of the structures identifiable, neither dissectable. So that is the dilated ureter on the right side being mobilized. Similarly, on the left side, on the right side, the ureter being mobilized. Once both the ureters are mobilized, the bladder is dropped, and a wide-based flap is taken on either side, so as to bypass the pelvis, which was the reason for the obstruction there. So this is a wide-based left-sided flap. Similarly, on the right side, a large flap taken. And the dilated ureters were now anastomosed after taking the edges for a biopsy. This is the right-sided bladder closure with a V-lock. Similarly, on to the other side. So that is how it looked after the completion of bilateral smiley bori flap reconstruction. This is again a second last scenario of a 22 years unmarried female with a right flank pain, diagnosed to have a right obstructive megaureter with multiple secondary calculi in the ureter as well as in the kidney. So you can see a milk of lime in the lower part of the ureter. That is the ureter being mobilized. The dissection carried out as distally as possible so as to identify the area of obstruction, that is the obstructive segment of the megaureter. Once that is done, the ureter was, and the entire milk of lime was all sucked out and washed out using a ureteric catheter. And that is a transverse incision onto the bladder, which was closed longitudinally like a hanky maculix, so that we get a sufficient flap of the bladder to anastomose to this dilated ureter. But this being an unmarried girl, we had to have a non-refluxing sort of an anastomosis. So here, what we did is we took a seromuscular suture onto the ureter, then the edge bite and the bladder bite, and once tightened, there was an intussusception that was happening of the bladder mucosa into the of the ureteric mucosa into the bladder. So that is the seromuscular suture, edge suture, and then the bladder bite. Just by tightening it, there was an intussusception of the ureter that is happening. We can see that now. That is the intussuscepted ureter with a nipple valve. So once this was done circumferentially all around, a stent was placed and closure was done. Let me fast forward it. And this was the X-ray KUB, and this is MCUG before we got rid of the catheter. And this is the spontaneous expulsion of the entire stones in the kidney also. And this is an MCUG at 12 weeks which showed no reflex. So this is the last scenario if I've got time, sir. Yeah? 2 minutes, yeah. So this was a post-URSL for large upper ureteric stones bilaterally with a long segment upper ureteric narrowing on the right side. PCN was placed and the bladder capacity on a nephrostogram or a cystogram was very small. So this is the mobilized upper ureter. Attempt was made to get the edges together but could not. So we got the appendix there because the bladder flap would not be taken because of the small bladder. Identification of the distal ureter with the help of a ureteric catheter, and then whether the appendix is reaching the uppermost part. Here again an attempt was made to lay open the ureter and put the detubularized appendix over it. But even laying open of the ureter was not possible because it was a totally cicatrized ureter. There was no mucosa seen. Anyway, the incision extended into the lower normal ureter, and the defect was identified and measured. The appendix was now anastomosed without detubularizing to the proximal end, dilated end here. This is a stay suture just to get the appendix to the proximal end, and that is a lower stay suture to the lower end. This is a longitudinal incision onto the appendix given. A side to end anastomosis was done onto the upper end. That is end to side anastomosis at the upper end over a infant feeding tube. Similarly, the lower end was divided from the cecum. And this is the suturing of the appendix to the lower end of the ureter.
Dr. Gauss, I think we need,
The vascularity was assessed with an ICG, and this is a post-op CT after 1 year showing a very good drainage. So the take home is RGP always for any ureteric reconstruction, minimal mobilization, augment if required, avoid tension, have a diversion, and plan the reconstruction with all the options open. Thank you all for your patience.
Thank you, Dr. Gauss, for your nice presentation. So our next talk is by Dr. Amitabh Singh. He is talking on bilateral interfacial knob-sparing robotic radical cystoprostatectomy. So Dr. Pratik, it's ready, your presentation? So, okay. We can continue that if it is ready.
I think apologies for the technical glitch, and I think everyone kind of recognizes that I'm not Dr. Amitav. It's very recognizable. It's Dr. Amitav in disguise. So hopefully the video will play. I don't know what the technical glitch was earlier. Yep, so we're back to the entry into the bladder. So I'm just going to speed this up a little bit. Sorry. Sorry. So here we are. So we're entering the bladder. And then what I do is I just take a few stay sutures here for retraction. And this is a transperitoneal transverse cycle approach. Obviously, as I mentioned, this can equally be done extraperitoneally with a Millin's technique. In days gone by, because of the heavy bleeding, transfusions and so on with open simple prostatectomy, there were issues, but I think with robotics being available, this is, again, probably enjoying a little bit of a renaissance. So here we're finding a plane in between the prostate capsule and the nodule. Dorsally still, there's some amount of bleeding to be expected, but I think you get better control with your monopolar scissors as well as bipolar just to stop the bleeding straight away. And then you have to just patiently keep on the plane in between the capsule and the prostate nodule. Somewhat tedious procedure. And then make sure that you get all the residual nodules out too. There's always a little bit of oozing, not a problem. I think, this kind of operation lends itself very well if there's also a bladder diverticulum, which wasn't the case in this case. You could do a diverticulectomy at the same time. Also, large bladder stones or multiple bladder stones. Here, there are only a few small bladder stones. So, if you have that, large prostate, multiple bladder, large bladder stones, and diverticulum, you can do all of them at the same time by this approach. I take a hemostatic running suture in the prostate capsule you saw earlier, and once the hemostasis is settled, then you just then need to, at the end, repair the bladder defect. Because this tends to be a slightly bigger defect, I just use a V-lock running suture, saves time. Repair in 2 layers, lever Foley, lever drain. So next, I'm just going to share a video of radical prostatectomy. And again, I like to do this with a posterior approach. Just as Dr. Gagan was demonstrating very elegantly yesterday. Supine position. This is a side docking robot, just like the XI system, and not a lot of Trendelenburg required. 15-20 degrees, more than enough. Not like kind of days gone by where it was steep Trendelenburg. That's not really required these days, and get control of the seminal vesicles and the vas. You can ligate quarterly ligated or use a clip. I'm quite a user of clips, actually, as you can see in the videos yesterday as well as today. And then once that part is done, doing it as much as possible apically from behind, then kind of do the anterior bit, which is the bladder drop. Robotics gives you excellent views. There's not a lot of bleeding involved. And you can see here I'm kind of extrafacial. This is, although the PSA was, I think, only 16 in this patient, this is someone who's kind of 72. Erectile function is not a great issue, and trust biopsies were kind of indicating high-grade, high-risk disease, 4+4 bilaterally. So staying extrafacial, preserving the muscles, which ultimately leads to kind of better continence rates. So that's the right side. Now this is the left side. And then, you know, some surgeons don't use a DVC stitch. I mean, I like to get control with a V-lock here, run it a few times, 2-3 times, because I don't like seeing blood as much as possible. Ruins the field. And then the bladder neck dissection, again, you know, it's easier to go zoom across the bladder neck, but that leaves you with a big defect to have to kind of reconstruct later on. So even though will be a little bit oozy and bloody, it's best to kind of stick close to the bladder neck, preserve the detrusor muscle, and again, you know, leaves you less to reconstruct later on. Obviously, you've got to be careful of leaving positive margins in this area, particularly if the biopsies are positive towards the base of the prostate. Then complete the rest of the dissection laterally, as well as get better control of the pedicles. And this is the apical part again, being careful not to leave positive margins here, but at the same time try to preserve as much urethral length as possible and use less cautery here. And the last part of, before I go on to the anastomosis, is to just complete the lymph node dissection. In this case, I mean, you can see the external iliac artery here. I'm just dissecting a little bit more proximal and cephalad to it because the preoperative MRI was suggesting a potential lymph node there about 8-9 millimeters in size, which actually hadn't changed much over the course of a couple of years because the patient had had an MRI before, but I didn't want to take a chance. Took the lymph nodes, but you know, ultimately the final pathology was N0, but I just did a little bit more extended on that side. And then, as Dr. Gagan was demonstrating yesterday in the workshop, you know, I too like to do the posterior reconstruction. I think it makes the anastomosis at the end, the final anastomosis, very good. So just bringing the tissues together, reducing tension, reducing the dead space in that area. And you can see you can take good, nice, clear bites, you know, left side, right side. It's the beauty of robotics, makes life easier. And you can see you don't need to use sounds, you can just use ordinary Foley, just making sure that you don't kind of catch the Foley with the stitch, obviously, can happen. And then, you know, you can just use a few pieces of Vicryl if you think that there are going to be any defects left behind. Make sure that the anastomosis is watertight. Some people like using surgical. I love using surgical. Just leave it both places, leave it rain. And so this illustrates, you know, the differences in between application of robotics to simple versus cancer cases. So sorry about the technical glitch earlier. Thank you for the opportunity. I think, you know, we have another hospital coming up in Kathmandu 5-6 months' time, so we'll have robotics there too, so need your continued help and support. If you want to do robotics, please get involved. Thank you.
Thank you, Dr. Pratik and Team CMC. Congratulations on the good job. So, Amitabh, please you come for the presentation. He'll be talking on the bilateral interfacial knob-sparing robotic radical cystoprostatectomy.
Organizing team of NOWS for giving this opportunity. So again, I chose a topic which is not talked very much in the conferences, that is bilateral nerve-sparing radical cystoprostatectomy. So we always talk about the nerve-sparing radical prostatectomy, but no, we don't talk very often about the bilateral nerve-sparing intrafacial robotic radical prostatectomy. But believe me, having potency is it's as important as we are trying our best for the radical prostatectomy patients. So in the past, actually, multiple techniques has been given to prevent the potency in radical cystoprostatectomy, and they were like capsule sparing, RCP, seminal tip sparing. Now there is a technique also, bilateral VAS and SV sparing with fascia sparing also. In the past, prostate sparing radical cystoprostatectomy has been tried, apex sparing has been tried, and conventionally nerve sparing radical prostatectomy has been tried. And most of all these surgeries, they has been done with the open technique. And few actually papers, they are available with the laparoscopic and robotic bilateral nerve sparing radical cystoprostatectomy. So I was searching the papers which are published and they are indexed in PubMed journal. So in the last 2 years only, we got only 25 publications for the bilateral nerve sparing radical cystoprostatectomy. And out of those, actually, most of them were organ sparing actually, not only bilateral nerve sparing. So again, now we know the anatomy given by the walls, neuroanatomy, that all these, after forming a pelvic plexus, these are the two neurovascular bundle which runs over the bilateral posterolateral surface of the prostate. Then Dr. S. Tiwari has given that there is a hammock actually, so it's not only the bilateral posterolateral neurovascular bundle, it is a hammock. So you can have a neurovascular bundle all around the prostate, and prostate sits on the hammock of neurovascular bundle. Then Vipul Patel has given the anatomy of this capsular artery. So we can find these three capsular artery actually, anteromedial, lateral, and posteromedial. So if we can see these capsular artery during neurovascular bundle dissection, then we can be 100% sure that we are into the right plane actually. We are just on the prostate capsule. So this is a very small video for bilateral nerve sparing radical cystoprostatectomy, which I done recently. So usually I start with the mobilization of the sigmoid colon because it gives me exposure to the pelvis also, and it gives access to the left ureter also. So I always just incise the pelvic peritoneum or the bilateral ureteric this ureters, and I extend this peritoneal incision deep into the pelvis. So here just I am mobilizing the left ureter. This is the arterial supply which is coming from the internal iliac artery for the left ureter. So again, after doing the left ureter dissection, going for the right ureteric dissection, trying to prevent the adventitia over the ureter to prevent the vascularity of the ureter, so we should not be having any leak or stricture. So now just combining both peritoneal incision down into the pelvis. So now if for the posterior dissection, we always make this incision just anterior, or you can say 1 inch above from this rectovesical pouch. So you just incise the peritoneum, then the fat, and try to identify the denonvillar fascia. So we all know that the seminal vesicles and bilateral walls, they are just wrapped around by the denonvillar fascia. So this is the picture. So on the right side, if my intention is going for the intrafacial, then the picture will be like that. If my intention for the extrafacial, then the picture will be like that. So in intrafacial dissection, we preserve the denonvillar fascia, which is adhered to the prostate capsule. There are multiple layers of the denonvillar fascia, but we can separate very easily in the early diseases. This is the extrafacial dissection where we go over the perirectal fat and just leave the denonvillar over the prostate capsule. So just to have a good exposure, I always take this hemolog clip on the pedicle of the bilateral SV, and once there is enough space, then I go for the dissection of all these neurovascular bundle from the posterolateral surface. So you can very well visualize all these capsular arteries, venous covered by the neurovascular bundle fascia. So this is the capsular artery I am teasing off from the posterolateral surface, and this is the same capsular artery actually on the left posterolateral surface of the prostate. So now I am confident that I am into the right plane. I am into the complete intrafacial nerve sparing plane. So again, separating these neurovascular bundle fiber gently from the prostate. So you can very well see the prostate capsule, denonvillar fascia, dissected bilateral this thing.
So once you have divided this thing, maintain the plane posterior, I'll go for the bilateral lateral paravesical space, because cystectomy is all about the spaces. So if you have made the posterior space, paravesical space, then there are pedicle only, and you can take them and the cystectomy is done. So this is the proximal, actually you can say the level of the lymph node dissection. You can see all these vessels, internal iliac, external iliac, common iliac, all these vein. So this is the obliterated umbilical artery. So I usually take ligature after applying a clip. Once the proximal pedicle has been taken, take the ureter with the hemolog clip. So just to prevent the spill, I always take the hemolog clip on the ureter also, urethra also. Or it's my institutional this thing that we always send it for the frozen. So I took this thing, the inferior vesicle pedicle. Now I'm just trying to see the tip of seminal vesicle. This is the fat which is just covering the levator and eye fascia. So once the part of proximal pedicle is done on the left side, I just stop. Because once you proceed, you can have some bleed from the veins, open sinuses. So it just spill around your operating field, and you may not like that field. So I don't go further. I stop there. I go on the right side. Again, same dissection is being done on the right side, identifying all these vessels, actually, internal, external artery and veins, obliterated umbilical artery. You can see the superior vesical artery, which is the first branch from the obliterated umbilical artery. So trying to see all these vascular structure after having a very good precise dissection, this is the advantage of robotic surgery. Again, taking the right ureter with the hemolog clip, taking for the frozen. So now we can see very beautifully this inferior vesical pedicle also, taking with the hemolog. If it is a very broad, you can apply a hemolog clip also. So again, same thing happens. So once you are very close to the tip of the seminal vesicle, I limit myself. I usually use hemolog clip. So the dissection is athermal. So this is the space, this prerectal space, the paravesical space. So once bilateral paravesical space has already been made, prerectal space has been made. So you just see only the pedicle. So this is the lateral part of this thing. Levator and eye fascia. So you just need to incise the endopelvic fascia according to your plan of nerve sparing dissection. So if you are planning for the extrafacial dissection, you can go down deep into the endopelvic fascia, so you can see the perirectal fat also. But if you are going for the intrafacial nerve dissection, so it is kind of high release. We go on the prostatic surface and we incise the endopelvic fascia over the lateral surface of the prostate. So once you have just made your mind about the type of neurovascular bundle dissection, so in prostate, just compared to the prostatectomy, cystectomy is a bit difficult, because now here the specimen is very bulky. So you need to always retract the whole specimen with only one for this pro grasp. So you need to master yourself how to retract the whole specimen so that it doesn't fall on your camera all the time, doesn't make it dirty all the time. So now I'm just doing high anterior release, dissecting the endopelvic and prostatic fascia. So I am trying to combine both spaces and trying to just dissect this pedicle completely. So now this is, the whole prostate is left only on the pedicle, the prostatic pedicle. I am applying hemolog clip, and the neurovascular bundle automatically just fall down from the posterolateral surface of the prostate. So now you can see this glistening posterolateral surface of the prostate without any adventitial tissue or additional tissue. So same step will be repeated on the left side. Again, so just I am doing high anterior release, dissecting the neurovascular bundle away from the prostatic lateral surface. Again, the prostate is left only on the pedicle, taking the pedicle. So now I am dropping the bladder after taking this attachment with the urachus, umbilicus. So once this radius space will be opened, the careful dissection at the apex is required here right now. So again, the retraction is very important. So again, we have learned that it is very important that you should be very careful at the apex of the prostate. So it is always better to tease off them, dissect them, or separate the neurovascular bundle from the apex, and always divide the DVC on the anterior surface of the prostate. So you should be proximal, not very distal, because these neurovascular bundle, they are very close and you tend to injure them. So once you have divided this fascia, so it also helps in reducing the bleeding from the opened sinus. So again, you have got very nice anatomy. And while taking the DVC, do not go very deep into this DVC sutures, because you can take the neurovascular bundle. So go very superficial, take them, you can selectively just suture them, all these open sinus, and now you can see very beautiful apex of the prostate, bilateral veil of the neurovascular bundle, which is going to the rhabdosphincter, deep into the pelvis. So again, separating the last part of the rectum from the urethra. So my assistant was trying to apply the Hemlock clip over the urethra, but he couldn't succeed. So I just cut it, the urethra. So this is the rhabdosphincter and the part of the urethra which is marked by the yellow. So very good, sufficient length of the urethra. So just to prevent the spill, I'll take a few sutures at the prostate apex, and the cystectomy is done completely, bilateral nerve sparing. And but personally, actually, I have learned doing bilateral nerve sparing on the cystectomy, because if you'll see, even though there are almost like 20 to 30% of chances of having prostate cancer along with the bladder cancer, but in most of the cases, they are only 3+3 prostate cancer, incidental finding only. So even if you get positive margin, very rarely, they are not going to change your oncological outcomes. So I learned how to do bilateral intrafacial nerve dissection on the cystectomy, radical cystoprostectomy only. And then I switched over to the radical prostatectomy. I just replicated this technique on the radical cystoprostectomy. Although I am doing all type of the technique, like hood technique, antegrade, combination of antegrade and retrograde. But in cystectomy, because the specimen is very bulky, and you don't want to go very close to the bladder, because even if it is clinical T2 disease, there can be pathological T3 disease. So you don't want to go very close into the paravesical fat actually. So that's why it is a bit difficult from the radical prostatectomy, how we do nerve sparing into the radical prostatectomy, but it is doable, and the outcomes are very satisfying actually in the radical cystoprostectomy. I can say almost, if the patient is younger, like 60, even in 62 also, then my 80% of the patient, they are potent without sildenafil or any PD5 inhibitors. Few of them, they need PD5 inhibitor, and they still have very good erection. They can do intercourse with good tumescence of the penis. So if we can do, the disease is early, we should always venture for the bilateral nerve sparing radical cystoprostectomy. Thank you.
It's not, okay. Thank you, Amitabh. Actually, because of the time constraint, we cannot have any discussion. I am supposed to go to other hall also. You are also supposed to go. So I think this is, we are closing this session, and may I request the moderator to start the next session, please.
Thank you, Chairpersons. I would quickly like to call upon all the speakers on stage for a group photo, and the others as well. Thank you.
Good afternoon and welcome all for new session. This is a session on urolithiasis and recent advances. And for this session, I'd like to call upon chairpersons, Dr. Bishwaraj Joshi sir, Manishman Pradhan sir. I'd like to request our chairpersons, Deepak Rajouri sir, Bipendra Rai sir, and I request chairpersons to start the session.
Yeah, good afternoon, everyone. I think we're running a bit short on the session, so let's get going with the next session. It's urolithiasis and recent advances. To set the ball rolling, we'll call upon the first speaker, Dr. Ananda Dhanasekaran. He'll be speaking on the current, whirlwind or a sandstorm that's happening all around the world, AI in urology.
Thank you, chairpersons. So I prepared this talk initially like what is the role of AI in urology in general. Then afterwards, when I saw this session and the theme of the session, like mostly with urolithiasis, I changed the session a little bit to focus more on AI in urolithiasis rather than urology in general. So the AI will make a urologist augmented urologist with integration of AI, robotics, computer vision. The urolithiasis care pathway itself can be modified. The advanced imaging, collaboration of AI, robotic interventions, and prediction of outcome by using AI are the modern visions. Previously, we used to see the X-rays or CT scans with a subjective assessment. As we all know, there is always a human error and we may miss something. While in this digital era, we can go through the images completely by using the digital radionomics, deep learning, automated techniques, which will make the urolithiasis treatment a complete different type of ball game. Deep learning solves the plebolith problem. This is one of the very commonest questions in any board exams or exit exams where, for example, the right side raw CT has got lots of radiodense lesions, radio-opaque lesions, and it's difficult to differentiate which one is stone, which one is stone or pleboliths. With AI analysis, it clearly demonstrates which is plebolith, even though it's a CTK UB without any contrast, and clearly identifies the urethral stone. The computerized neural network mode sensitivity is up to 94%, and dual computerized neural network has got area under the curve up to 0.954. The raw input, as you can see on the left side, got a lot of speckled noise, and we can completely overwhelm and change the picture into a very clear AI-enhanced output where the stone, pyramids, calyces, post-acoustic shadow, everything is so clearly seen. It makes the possibility of reading and recognizing and not missing even small stones quite higher. Radiomics also predicts stone composition. Gone are the days we need to wait for the 24 hours urine assessment or the stone analysis. With the help of radiomics, we can clearly identify the composition of the stones with a confidence up to 94%. Machine learning will combine patients' body mass index, stone size, ounce-fill units with good prediction rate even before the surgery. And an individual surgeon can input his own records or results, which will give a tailor-made result for the particular surgeon. The radiomics will, as a second eye, intraoperatively, we can again identify which type of stone is it, whether it's a calcium oxalate or a struvite stone or a uric acid stone, which can help us to set the laser settings, whether you're going for a dusting or fragmentating. By using the tip of the laser fiber, whether it's a 150 micron, 200 micron, or 300 micron, it will compare the fragment size and tell whether the fragments are less than 2 millimeter, which is the relative stone-free rate which we wish to achieve. Coming to the intervention, this AI-guided path will give you a safe needle path away from bowel, away from spleen or liver, also away from infundibulum and vessels. Robotic assistance and AI augmentation results in various platforms like ANTX, Monarch, and also makes the telesurgery possible because of excellent 5G connectivity throughout the world. We can use the suction mechanism. We can measure the temperature and pressure in the tip of the suction catheters, access sheath, so that the intrarenal pressure and intrarenal temperature is not crossing the safe limits. The trifecta of stone success, stone-free status, complication-free, single-session treatment can be achieved by using AA integration. The main barriers are the data dependency. More the data, more the input, the AA will perform much better, especially if it is individualized to a particular surgeon. Image quality, if we give better image quality, the AA will give us the best performance. And cost of the AA, fortunately, it is decreasing worldwide. And generalizability, where what is happening in the West, how we can apply it in the developing countries. In future, AA integrated learning systems will help in every stage of the patient's pathway in stone treatment. Either it is pre-operative dynamics, intraoperatively robotics, or vision technology, and prognosis and outcome estimation. Slowly, AA will become the standard of care with superior reduction, democratized skills using robotics, objective real-time sizing of the stones, and improved outcomes like stone-free rate. Thank you.
Thank you, Dr. Ananda. That was a very crisp talk. And I'm sure there are many interesting points that the audience might want to discuss, but we'll take the questions at the end. And let's move on to the next talk. It's by Dr. Rajiv TP. And it's on laser innovation in urology, thulium fiber laser versus holmium YAG laser, and a novel pulsed solid state thulium YAG laser. Recent updates. Over to you, sir.
Respected chairpersons and dear friends, at the outset I would like to thank the NOWS executive for inviting me to deliver this talk. My presentation today is to explore current innovations in laser technology for urology, focusing on TFL, holmium YAG, and the novel pulse solid state thulium YAG laser, covering technical principles, performance metrics, and clinical outcomes based on recent peer-reviewed research. Lasers are the mainstay of modern endourological surgery for stone fragmentation and soft tissue applications. There have been continuous innovations into the laser technology aiming to improve ablation efficiency, precision, and safety. The newer emerging technologies focuses on wavelength optimization, pulse modulation, and fiber delivery. Holmium YAG was introduced in 1992, which revolutionized lithotripsy and soft tissue incisions. But there are certain limitations related to holmium YAG, which includes the high retropulsion, limited pulse energy control, and the fiber fragility. TFL emerged somewhere around 2015 with diode pumped architecture, enabling high repetition rates and the fine pulse control. Of late in 2023, the novel pulsed solid state thulium YAG laser came in, which represents the next generation solid state laser with hybrid pulsing. Holmium YAG has a wavelength of 2120 nanometer, TFL 1940, whereas the pulse solid state thulium YAG 2010. All are strongly absorbed in water, TFL having the highest absorption rate leading to shallow penetration. Holmium YAG has a pulse energy of 6 joules, TFL typically around 1 joule up to 2000 hertz. TFL uses silica fiber core as gain medium for energy delivery, whereas both holmium as well as the novel thulium YAG laser uses solid state crystals. Holmium YAG uses a flash lamp pump solid state crystal, produces long pulses with high peak power. It is effective for both stone fragmentations and as well as incision of hard fibrotic tissue. But the challenges include fiber degradation and the significant retropulsion rate. Thulium fiber laser, TFL, employs thulium doped silica fiber, which is a compact and diode pumped. Continuous wave or superpulsed operation with fine control for pulse energy and frequency. It has a very low retropulsion rate and higher ablation efficiency per joule than compared to the holmium YAG, generates uniform stone dust and reduces the operative time. The novel pulse solid state thulium YAG laser, it's a newly developed one, combines both the advantages of holmium YAG as well as the TFL, offers adjustable pulse width and repetition rates, It has got an improved beam quality and reduced fiber burn back. Clinically, trials show it's efficient for dusting with minimal retropulsion rate. Absorption coefficient is water. TFL scores over the novel Thulmimiag, which scores over Holmimiag. TFL and the novel Thulmimiag has a better beam quality, offering smaller spot sizes. Retropulsion energy is the lowest in TFL, followed by the novel Thulmimiag, and Holmimiag is having the highest retropulsion rate. When you compare the cooling and power efficiency, TFL is the most energy efficient. Holmimiag is long proven for its efficiency for lithotripsy and dusting of renal calculi, whereas TFL enables fine dust and faster fragmentation at low energy. So our endourologists are now favoring TFL over Holmimiag. The novel pulsed Thulmimiag laser, early results show similar or better ablation rates compared to the Holmimiag. There are ongoing RCTs which are comparing the operative time and stone-free rates among the three. Holmimiag again is reliable for BPH enucleation and stricture incisions. TFL also is showing enhanced hemostasis and smooth cutting ability with minimal carbonization. The novel Thulmimiag has a potential for bloodless resection with superior visual clarity. TFL's diode pumping provides more than 25% wall plug efficiency versus Holmimiag, which shows only less than 5%. The novel Thulmimiag introduces variable pulse shaping for energy optimization. It will have precise control of pulse width, which reduces the retropulsion and thermal spread. And there is again the improved stability, which lowers the fiber burn back and handpiece overheating. TFL demonstrate approximately 4 times lower retropulsion rate than the Holmimiag in bench testing, and the novel Thulmimiag approaches TFL performance through small smoothing. So lower retropulsion means there is a higher stone to fiber contact and better dusting efficiency. Continuous high-frequency TFL pulses can elevate irrigation temperatures, and studies have shown that the safe limit should be maintained at less than 43 degrees centigrade with adequate flow of 30 ml per minute. The novel Thulmimiag displays intermediate heating profile between Holmium and TFL, and temperature monitoring is recommended when your procedure is a prolonged one. Further, TFL fibers are thinner, which allows improved flexibility but has a disadvantage of fiber fragility. The novel Thulmimiag compatible with standard 270 micron of Holmimiag fibers, and thereby there is little cost saving. Reusability remains superior for Holmimiag, but diode lifespan favors TFL. So life cycle cost analysis favor TFL, approximately 30% lower energy costs. TFL has shown fine dusting mode, Holmimiag more effective in fragmentation, and the novel Thulmimiag adaptable to both because of its hybrid pulse range. Meta-analysis shows TFL shortens operating time by approximately 15 to 18%, stone-free rate more than 90% for renal stone less than 2 centimeters, whereas the novel mode demonstrates comparable outcomes in early trials. But Holmimiag remains reliable, but there is a disadvantage again of slower due to propulsion. TFL console is compact, air-cooled, and a simple interface, and the novel module ergonomic similar to Holmimiag with added digital control, reduced fiber changes, lower procedural interruptions. HOLEP remains the standard for larger prostates. 2-flap offers smoother cutting, better hemostasis, whereas the novel mode trials show equivalent resection volume with less bleeding. TFL allows precise incision with minimal collateral damage. The novel Thulmimiag laser promising for mucosal ablation and urethral restructure prevention, whereas Holmimiag remains versatile for fibrotic and calcified lesions. Now, hemostasis and tissue effects, TFL wavelength closer to water absorption peak, so it has got an excellent coagulation. The novel Holmimiag achieves balanced cutting and hemostasis because of its dual pulse control. Holmimiag deeper penetration can cause carbonization at higher power. TFL's high-frequency dusting reduces need for basket retrieval. The novel tolmimiaq integrates with digital ureteroscope via standard connectors. Now, TUFLEP offers shorter operating time, better hemostasis than HOLEP, whereas the novel tolmimiaq variant achieves comparable resection efficiency. Bench tests show TFL 2 to 4 times higher ablation rate per joule than the holmium-YAG, and the novel tolmium-YAG demonstrate intermediate efficiency with less debris scatter. Fiber degradation minimal with TFL below 30 watt continuous use. So clinical comparative trials, 2023 multi-center RCT has shown TFL when compared with holmium-YAG, it has got a reduced operating time, which is quite significant. And 2024 pilot study when comparing the novel tolmimiaq with holmium-YAG shows it has got similar stone-free rates but lesser fiber damage. Cost and maintenance analysis, holmium-YAG high maintenance due to the flash lump wear. TFL diode lifetime is more than 10,000 hours with minimal calibration, and the novel tolmimiaq moderate cost and low maintenance. Environmental, TFL's diode pump, low energy consumption, smaller carbon footprint, and the novel mode solid state design reduces waste compared with flash pan. Hospitals are now moving towards eco-efficient surgical technologies. Green OR initiatives promote diode-based laser adoptions. Survey by EAU in 2024 shows 80% of surgeons prefer TFL for dusting, and the novel tolmimiaq appreciated for its versatility and intuitive controls. Holmium-YAG still favored for availability and reliability, and 60% anticipate transition to fiber-based systems by 2026. Safety and complication profile, thermal injury rate less than 2% in modern TFLs as well as the novel tolmimiaq series. Ureteral stricture and perforation rates similar across platforms. Now, what is the future trend in laser design? Adaptive pulse shaping using AI-driven modulation under testing, integrated cooling sensors in new TFL models, the novel tolmimiaq transitioning towards compact air-controlled units. So regulatory approvals, all the three have got the both FDA and CA approvals. ISO 13485 compliance mandatory for manufacturing, and ongoing post-market surveillance is going for the novel tolmimiaq laser. Meta-analysis 2023 Cochrane style review shows TFL has lower operating time, approximately 20% less than the holmium-YAG, and 2024 systematic review shows no difference in stone-free rates over 3 months. So complication management, common events are hematuria and transient dysuria. TFL has a very low retroversion-related injury, and the novel tolmimiaq has shown milder post-operative irritative symptoms. So post-operative outcome, hospital stay 1.2 approximately versus holmium-YAG 1.2 plus minus 0.6. Pain scores lower for TFL as well as the novel forms, and retreatment rate less than 5% for stones less than 10 mm. So patient-reported outcomes, and so peer questionnaires show higher satisfaction for TFL, less noise, lower irrigation flow, so there is a better comfort. The novel tolmimiaq patients report lower post-operative urgency. So in case of larger stone burden applications, holmium-YAG still superior to TFL. In those cases, more than 2 centimeters due to the energy per pulse, TFL effective when dusting strategy is compliant. So there has been a comparison between holmium-YAG TFL as well as the newer novel model. Novel model will score over the others because TFL may not be that effective compared to the novel modality in case of harder and larger stones. And again, it is effective in soft tissue because of its dual mode, that is because it has got a pulsed as well as the continuous wave mode. Now, summary of key findings, TFL is efficient, compact, and cost effective. The novel tolmimiaq emerging alternative with hybrid pulse control, holmium-YAG benchmark with decades of data. In India, the novel form has come in the form of thulium, this Dio mode, that is the Dornier Duo, as well as this is marketed by the Dornier, as well as the Elangers has come in. which has comparatively considerably lower cost, which is less than 45 lakhs to the customer. Thank you for your patience.
Thank you. It was a very comprehensive.
Thank you, sir. So it's my pleasure to invite our next speaker, my senior, Dr. Dipesh Gupta. He's an associate professor at Behri Hospital, and he'll be talking about mini PCNL.
Thank you, Naus, for this opportunity. I would like to present on something on mini PCNL and staghorn stones. You can see why staghorn calculi matter. These are complex branching stones and which are associated with so many complications like infection, progressive renal damage. And the management is equally challenging and it's complex. So here we can see that it requires complete clearance for the sake of eradicating infective focus, relieving obstruction, preserving renal function, and preventing recurrence at the cost of bleeding, sepsis, organ injuries, and other complications. So we have to balance as to what we should do. So the evolution of management has changed from long back from open surgeries to PCNL nowadays, which is the standard one. So here maximal SFR, so maximal SFR is, thank you. So maximal SFR is desired with minimal complications. So there are different MIS options in the form of standard PCNL to miniaturized forms. And we always have to go for individualized approach so as to get the best outcome out of it. So the focus has changed from really can we complete the clearance to how safely and efficiently we can do it. So it is not only about the strategy, but also about the technology. So strategy matters more, however. So pre-op optimization can be done, which is like starting right from CT-based evaluation and planning to calculate stone volume and what is the branching pattern to calicial anatomy reading and skin to stone distance. And infection control cannot be underestimated. You hear this key problem, sir? Cancel your It's not moving. Any problem, sir? You cancel your room? Cancel. Yes. Okay. So it's important to go right from access planning as to segment. Like whether, so it's starting right from access planning to positioning of the patient. So if we talk mostly about the positioning of the patient, which is prone is the more preferred one nowadays, however supine is coming up. So posterior calyx access may be preferred in most of the cases, which can give to most of the stone clearance. So, and we can choose either fluoroscopy guided or ultrasound guided, depending on the situation. So we can see, so whatever be the access control or access gaining, whether through fluoroscopy or ultrasound guided, we can see we have to achieve maximal clearance with minimal complications. Similarly, other technique related factors are there. So whether we have to go for single tract or multiple tracts depends on the situation. So it depends on like what would be the complications related to it. So we always have to individualize. Minimal complications can be gained with mini PCNL. However, in standard PCNL may also be opted often if it allows. Similarly, ECIRS or combination of other forms of approach may be desired often. And similarly, choice of energy sources may be individualized. So here we can see intraoperative optimization, always like accurate calicial access, and the choice of the tract size is always important how to choose that. So it depends not only about the calyceal anatomy or calyceal size, but also the infundibular size, like what size it would allow, and use of suction is equally important. Here, there's some problem with the video. Okay, in this side, I just wanted to show about the access and the use of mini PCNL in different forms. What would be how to individualize, like what would be the correct tract size that would be desired in any case. Like if it allows, you can opt for a standard one to complete it in a shorter length of time. However, if it allows, if the infundibular size is narrow, you can always opt for miniaturized form of that, even if at the cost of increasing the number of tracts. Please change the slide. There's some problem. Okay, so sorry for the videos and sorry for the slides. In this one, I wanted to show about how the mini PCNL tract would access all the calyces, even in a standard, even in a very complex Staghorn calculus, how it would very well clear the stone, as well as clearing all the calyces, how could it access all the calyces. Sorry for the slides. So an intraoperative optimization, always choice of the calyx and judicious tract dilatation to minimize the complication, maintaining low intrarenal pressure and limiting operative time sometimes, even at the cost, even if you have to leave the stones. So for the best outcome of the patient, you may have to stage the procedure sometimes. So stone-free condition and recurrence prevention is the main aim. Early imaging in the post-operative period to have for second look PCNL whenever needed, that may be opted, and remove residual fragments proactively, so whenever needed. So that would lead to recurrence prevention, and metabolic evaluation to prevent recurrence, and stone analysis and targeted prevention is equally important. So we have got PCNL in today's era, it has got good stone-free rate, and ECIRS may even add to that, and staged minimally invasive surgery reduces morbidity versus aggressive single-stage surgery. So here what we have to see that tailored MIS approach is of most use. So in future also, AI-assisted CT planning, 3D guided access, different types of laser advancements, and different eras protocol applications would lead to better outcome in most of the cases. To conclude, MIS remains the backbone of treatment in most of the cases, and outcomes improve with careful pre-operative planning, optimal access selection, appropriate use of technology, and willingness to stage the procedure. What we have to see is strategy is more important than the speed of your surgery, and safer surgery and better renal outcomes can be achieved with all of this. Thank you.
Thank you, Dr. Pace. However, as new equipments come, PCNL is there to stay with the volume of stones that we have. Our next speaker is Dr. Harpreet Singh is here. I don't see him around. So we'll shift to next speaker, Dr. Sujit Powell, supine PCNL in children.
Good afternoon, chairpersons, esteemed faculties, and dear delegates. So I'll be presenting on supine PCNL in children. So in today's morning session, Sabni sir has nicely highlighted the principles of PCNL, and whether it's adult, children, the basic principles remain the same. Though in children, there are certain challenges which need to be addressed, and I'll be talking about those. So I don't have any conflict of interest. So we all know pediatric nephrolithiasis is in rising trend, and basic principles of stone management, the procedure we choose should give complete clearance with minimal complications, and the basic thing, basic principle, we should rule out the cause, whether there's metabolic or anatomic, as whether it's children or adults, we need to rule out the cause to prevent recurrence. And for all procedures, complete clearance is a must. So as in adults, the indications for PCNL in children remain the same. So complex, large stone, matrix stones, these are the basic indications. So there are certain challenges the PCNL poses. So small kidney, the apparent smaller size we use in adult may not be small for children. And the stone may be associated with anomalous kidneys, which should be addressed together. And there are certain technical nuances, like the track is really superficial. So just puncturing, you reach the kidney. And the guide wires, the tract may get easily dislodged. Similarly, most of the time we are using adult instruments in children. That also poses certain difficulties. And children are prone to hypothermia, they have poor body reserve, so they need good perioperative care. And these are the things we should be cognizant of. So as I already said, the tract size in infants, 24 French teeth, is equivalent to 72 French teeth in adults. So just think, we are using 72 French tract size in adults. So we all know as the tract size increases, the complications of bleeding also increases. So to prevent infundibulary tear, parenchymal trauma, it's always better to use a smaller tract. So supine PCNL, first reported by Gavin et al. In PCNL Crows study in 2013, and Gamma et al. In their series of 27 cases. He detailed the technique in 2015. And thereafter there are multiple studies and meta-analyses, and they have already backed up the efficacy and safety of supine PCNL in children. So these are the recent meta-analyses, and they have clearly compared prone versus supine. Here we get equivalent stone-free rate and complications in both. And in supine, the operative time is less than the prone. Similarly, hospital stay, hemoglobin drop, they have been found to be less in supine compared to prone. So as with adult PCNL, the supine PCNL in children starts with good perioperative planning. So we need to know the orientation of the kidney, similarly the orientation of the surrounding organs, colon, liver, spleen. This should be keep in mind for proper planning. And always better to use low-dose CT scan to prevent radiation risk, to minimize radiation risks. There's a study by Emiliani et al. So they have compared retrorenal colon in supine and prone in children. So what they have found in supine PCNL, the incidence of retrorenal colon is very less. Here you can see, we can compare in left side, it's 28% in prone versus 4% in supine. Similarly, in the right side, none in the supine position. So I think the incidence, if we do supine PCNL, the incidence of retrorenal colon is low, so the chance of injuring the colon is also less. Though these complications are quite rare, but still can occur. So whenever we are planning for surgery in children, PCNL in children, so we need to use miniaturized instruments, both in length as well as size. We are not just looking at the size, but as well as length. Here you can see, I have taken a picture from a case report. Here you can see in infants, the amplas so large, so we can see it's quite difficult because of the size of the instruments. We can see here, it's clear from the picture. So puncture needle is smaller in length, uretary catheter, resistance, both in small calibers, excessive size. We use 14 onwards in children, and length, we can trim the size of the Teflon amplas in children, so up to 10 centimeter, depending on the age of the children as well. And whenever possible, small size nephroscope and even pediatric cystoscope may become helpful. And irrigation fluid, it's always better to choose the warmer fluid to prevent hypothermia in children. And special attention should be taken during positioning. So as in adults, we use a plank-free modified supine position, 15 to 30 degrees. It depends upon the angle of depending on the window of puncture. So more the window shifts towards the posteriorly, we tend to increase the angle. So as in adults, the pros and cons of supine position, we all know, we are pretty clear. And especially in children, so anesthetic risks, it obviously decreases in supine position. So here we can see rolled cloth. We can use simply rolled cloth in smaller children. In older children, we can use Allen stirrup for positioning. So the puncture, basic principles of puncture is similar. So for most of us tend to use monoplanar technique, but it's always better to, for beginners, to mark the site with crossed table 90-degree technique to mark the site of the puncture. Here you can see, we can mark the site of the calyx, and then go for the puncture in 0 degree. Here, so before puncturing, we need to have a view of relation of colon, liver, spleen, as I said, and use of safety guide wire. So most of us don't use safety guide wire, but in children, the guide wire tends to slip out easily. And the emplas also tends to get dislodged similarly. I think most of us have, obviously, I think in our experience, we have gone for second puncture, so getting guide wire slipped out. So you need a good assistant for handling the guide wire as well in children. So, and also, obviously, if there's no guide wire inside the emplas sheath, the stone clearance time also decreases. And basic principle, do not overdilate and do not overshoot. And the use of ultrasound, it's obvious, it's very helpful, especially when we are talking about retrorenal colon, and it minimizes the risks of radiation. So as I already said, it's always better to use smaller size, and Dr. Dipesh also has highlighted the use and necessity of smaller size to prevent infundibular trauma, and it plays a great role in children. So smaller is the better, but sometimes in grossly dilated kidney, we can go for larger size. So smaller may not be always better, so we should choose the optimal size. And in supine children, and in supine position, we can clearly see from the lower calyx, we can easily clear the upper calyx. So there's obviously less torquing. So whenever we are taking care of the stones. So I think needless to emphasize about the reduction of X-ray exposure in PCNL, especially in children. So as in adults, to avoid multiple tracks in PCNL, so proper planning and equipment is essential. Use of miniaturized instruments, proper selection of calyx, use of flexible scopes, and ECIRS. In children, it's very difficult to basically, in smaller children, approaching from down below, it's very difficult. So, but in older children, we can think about ECIRS as well. So principles of stone fragmentation and retrieval is quite same as in adults. So whether you use laser or lithotripter, it depends. But still, as in management of stones, it's essential to send for small fragments for stone analysis. And as the body reserve in children is very low, so we should be wary of the potential perioperative complications, intraoperative complications whenever we are doing PCNL. So I think we don't need to emphasize the significance of CIRF, that is clinically insignificant residual fragments, because they are obviously significant. Exit strategy is similar to adults, but I think we can say that the need of second procedure after disease stenting in children poses second anesthesia. But whenever the stone fragmentation is complete and the procedure is uncomplicated, we can leave the ureteric catheter overnight and take out the second day. So in our experience, we used to do prone PCNL, and we switched over to supine PCNL in the end of 2023, and till now we have done around 34 cases, and clearance rate is around 85% with complications like sepsis, transfusion, we have all faced. And it's obvious as the gauge stone and complexity of the stone increases, the clearance rate also decreases. But in children, because of the small size of the kidney, the obvious burden, staghorn, may not be so of high burden as in adults. The staghorn may have low volume compared to adults. So clearance rate is obviously high in children. So in most of the PCNL, we add lower polar puncture compared to upper polar middle polar. It's obvious in supine PCNL. From lower track, we can approach most calyx in supine PCNL. So comparing stone clearance rate with other papers, it's comparable. And the meta-analysis, here we can see the forest plots from the recent meta-analysis, stone free rate equivalent, complications equivalent. Similarly, hemoglobin drop less in supine, operative time less in supine, and even hospitalization time less in supine. So I would like to conclude saying that whenever we are considering for supine PCNL in children, proper plan is essential, and a good experience in adult PCNL is a must before going for supine PCNL in children. And always take extra precaution perioperatively because they have poor tolerance to complications. Thank you very much.
Thank you for the extensive presentation. As my professor used small adults, they have different physiology, and there are certain nuances with pediatric PCNL, and you have to keep that in my back of mind. Thank you, Dr. Sujit. Any discussions can be taken over the tea time. So we'll call upon Dr. Harpreet Singh for his presentation on standard PCNL in the area of mini PCNL. Thank you.
Thank you, Chair, presenting in other hall. So I thank the scientific committee for giving me this opportunity. So standard PCNL in the, how many of you are still doing standard PCNL? So I'm happy to see a few hands. I thought I will be isolated. So I'm happy that still many of you, and I'm also one to raise my hand. So mini PCNL appears to be increasingly popular procedure for the treatment of renal stone. However, whether it can be superior to standard PCNL regarding efficacy and safety is still under debate worldwide. We know stone more than 2 centimeter, large stone, complex stone, lower pole stone, all are indication for PCNL. And you know this latest nomenclature of mini PCNL, and generally 14 to 20 is the mini PCNL. So what are the advantages? Less blood loss, lower blood transfusion rates, day care, reduced length of stay, and almost equivalent stone-free rate. But what are the things which we don't talk? That is intrarenal pressure, longer operative time, poor visualization, urosepsis, equipment, you need laser for the mini PCNL, costly. This we are not talking. So mini PCNL, now the new thing, why are we, you see, any RARS meeting is not complete. We have a suction, we have navigable suction, we have navigable ureteric access sheath. Why are we talking more and more of all those things? Because we are worried about intrarenal pressure. We realize that intrarenal pressure is very important. And mini PCNL, due to smaller tract, when you're using a 14 or 16 French tract and restricting the fluid out for the dynamics, the high pressure, and then you ask your assistant to press the saline bottle so that you can visualize the stone. You are further increasing, you are causing insult to the injury. And this increases your operative time. So normally IRP is about 0 to 15, but 30 millimeter is considered safe. But if it is more than 20-30, you will see pilotubular backflow. If 30 to 50, pilovenous backflow, more than 70 is pilointerstitial, and 80 to 90 fornicial rupture. And my friend Deepak, nobody can be better than him because he is the one who is involved in fracture group and teaching everybody how to do a safe RARS. So higher pressure during stone fragmentation can release bacteria trapped in the stone, and these are often pushed into the bloodstream via the open venous and lymphatic channels. So there are mitigation strategies like suction sheath, gravity irrigation. Now we are talking more and more of gravity irrigation. We are telling that fix at 60 centimeter or 100 centimeter, so that you should not have to push it. You by the gravity, you are managing the flow into the access. Tract sizing. So large enough so that your fluid can egress easily, and ureteric catheter also decreases the IRP. This is a portion study where has just shown that PCNL with 26 French sheath and 30 French sheath, you see the IRP is very low. When the mini PCNL with the sheath, no ureteric catheter, you see the IRP pressure, and when the ureteric catheter input, the pressure comes down in the last. So it's very important. This is one elephant in the room which we have to look into it. So this is a paper, does many percutaneous nephrolethotomy causes increased intrarenal pressure during percutaneous nephrolethotomy, and is this mitigated by a suctioning sheath, a randomized controlled trial? And if you see this figure, and you see how totally blocked, where the fluid will come, the whole pressure, you have make it a complete lead, and this pressure will keep on rising. So one very interesting thing which I also learned during this presentation, compared with balloon dilatation, coaxial dilatation with mini PCL sheaths generate high internal pressure. This is something new for me also. And during nephroscopic, if you are not using suction, nephroscopic sheath generate mini PCL higher IRP, and highest RP are doing when you are doing RGP. See, always our teachers used to do a gentle RGP because it ruptures the furnaces. So RGP, and when a nephroscope, when you're passing in the sheath, they say IRP rises. And the moment the vortex effect which you say, or the vacuum effect which you say, they pressure so much pressure that it throws away the stone fragment. That is the vortex, but also because of the IRP. It is not that only sheath has a role. You have to understand, earlier we were credit giving all to the sheath, that the sheath is designed. It is because of the IRP. So much pressure that it throw away the stones, fragments. So this is a risk factor for urosepsis after minimally invasive PCNL in patient with preoperative urinary tract infection. So, and it has got a very high mortality. Now almost 5 to 6 cases have been reported mortality, and the main risk factors were positive urine culture, stone size, stone complexity, surgical time, renal pelvic pressure, and residual stone. So choose appropriate channel size and avoid renal injury, and control surgical time to prevent the urosepsis after PCNL in patient with preoperative UTI. This is a meta-analysis of mini PCNL versus standard PCNL for 2 centimeter stone. So it has got all the good things about mini PCL, like less blood flow, less transfusion, all those things are very good. But it has found that 24 French standard PCNL gives the same effect as the mini PCNL. This is now in many meta-analysis and theories. See, though by definition we are 30 French, but at today's era, I don't think anybody is using 30. Maximum people using for a stagone is like 26 French. That will serve the purpose. So, on the contrary, if you use mini PCL, it takes a longer operative time. Mini PUC, no thank you. If you see this series by Gusti, you can see they're comparable and they don't find any advantage. It's full of things. So this is a 50-year-old male, diabetic, pain right loin on and off, and found to have right stagnant calculus. You can see the big user, and you can see it's look like a bit of infective stone. And see this stone. So how many people will go to by 14 and 17 French and try to remove this stone? So we have done in one sitting. It took almost more than 90 minutes, but finished in one sitting, 10.1, and we kept nephrostomy because a diabetic infected discharged third day. So it's much easier, much simpler. It is not, guidelines are there to help us, but you have to see what you have to customize the treatment. And this is another 50-year-old male and hypertensive, non-diabetic, CKD, serum creatinine 2.9. He was planned for stage PCNL somewhere with history of URS 1 month and underwent RARS plus DG stenting few days back. And he presented in urosepsis. He came to me with DG stent in situ, and you can see the stone bulk, a huge amount of stone bulk is there. And he come to, So we settled him with antibiotics, and we diverted, his creatinine settled, and we planned for surgery. And we are able to remove almost all stone, and we used one secondary tract from upper calyx, and that was a mini tract. If you can see the mini tract here, it's a mini tract, and rest. So a patient with a CKD, his creatinine is high, he's infected, you cannot go with mini patient, tuck. No, it's a mass there. You have to remove, you have to save the patient. It's not a question. You have to see what is best there. So take-home message is standard PCNL is still relevant in large birth stone, staghorn stone, shorter operative time, less intrarenal pressure, better egress dynamics, better visualization. You need vision. Without vision, you otherwise will keep on telling your technician to push the bottle, you want fluid. 24-hour French complications now it is in 24 French has standard PCNL similar to mini PCNL. Bleeding depends on many factors. It is not only your tract side, it is the torque, as Dr. Sabnis was giving the morning. How is your puncture? How much is the stone bulk? Even if a large stone, you're doing many PCNL, once you start breaking stone, when the stone leaves the mucosa, the oozing will start. That will spoil your field. You will further increase the IRP. So you have to, and very important thing, I keep on doing all the things, and I will certainly I am a big thing that for that. If you have a good dilated system, you just put a 24 French sheath, go pick up the stone, go home. You finish the PCNL in 5 minutes. Nothing is there, no blood loss, nothing. Patient, so grab and go ITO, and there's no residual fragment, because you have not broken the stone. And high intrarenal pressure will cause sepsis, will cause morbidity. So I just remember one dialogue, standard PCNL Jindabad hai, Jindabad rahega, it is going to be there. And thank you very much for your attention. There is no bleeding here.
Thank you, sir. Thank you. It's a reality check that all the procedure in endourology have their role, and we should honor and make sure that we use them appropriately. There's no procedure that is obsolete. There's absolutely no case to case. You should be a master of everything to say that this is the best or not. Thank you, sir. Thank you for getting us back to the reality.
Thank you.
And,
thank you, Deepak.
Yes, we'll move on. We have the next speaker from Jaipur, Dr. Sandeep Gupta. He'll be talking about supine PCNL in complex cases.
Good afternoon, everyone. So first of all, thank you, Nepal Uro Association, for giving me this opportunity. I'm really humbled. So my journey in supine PCNL started from 2014, when hardly anyone was doing supine, and we hardly had any talk about it in any conferences whatsoever. So I started my journey from 2014. And now if you see in every conference, every workshop, there's something on PCNL, whether it's video, live surgery, anything. So yes, I do feel, and I'm sure you all will agree, that supine has made its way in today's time, and everyone is doing supine. I'm not telling supine is for every case. No, definitely not. It has got its own disadvantages. We should have a good case selection. But yes, we should know supine. That is the message I want to give. So yes, I'll be mainly showing, it's a video presentation. First, I'll be showing the important things about supine, which as beginner, I'm sure some of you will be here who would want to start supine or have just started. So my experience of 12 years, what mistakes I have made, I'll just show all of it in a short video, and hope it helps you all. It's not on the screen. Yeah. So very important is number one, bowel preparation, I feel, because here we are all worried about colon injury. So even after 12 years of supine, regular supine, in most of my cases, I give bowel preparation, and I feel it helps. There is a controversy, people tell it doesn't help, but I've started it from beginning, and I feel bowel preparation 1 day prior to surgery helps during the surgery. So next important thing is the patient positioning, very important. So the standard position worldwide which people are using is the GMSV position. Nowadays, a true supine position has come. One of our urologists from India, Dr. Dixit, he has only popularized it, true supine. And frankly speaking, for the last 6-7 months, I've been also doing true supine. And yes, I will say that yes, true supine position, it's much better than GMSV. This is my initial experience of the last 6 months that I'm doing true supine. So I'll just show a video of the positioning. So this is the modified GMSV position. Audio, please.
The patient's ipsilateral lower limb is fully straight, in line.
So this is the GMSV position. It's like a lithotomy position.
Whereas the contralateral leg is fully abducted. So the contralateral leg is abducted, the ipsilateral leg is parallel to the patient's body as much as possible, so that we get enough space to enter and perform the procedure from below.
So we have the ipsilateral, the side on which the stone is, which we'll be operating on, that leg should be fully straight, parallel to the body, and the opposite leg should be fully abducted so that we have space. And especially in ECRIS, we need space. So this is one important point.
Whatever is required, like electric capitalization and also flexible URS if required in the case of ECR.
So the advantage, you don't have to change the position. In the same position, you put the UCAN and you start your circle.
Kept in this position. Whereas the upper limbs, both the upper limbs preferably are in the straight position, in a crucified position.
Upper limbs, some people keep it like this, as I do. Some cross over the ipsilateral upper arm to the contralateral side to get some more space.
Placed 20-degree tilt towards the operator.
Now coming to the C-arm, very important. All the points I am showing are important for beginners at least. So C-arm in all my punctures are 20-degree tilted towards the surgeon, that is towards me. So my punctures are all 20-degree C-arm facing me.
So this is a case of left-sided venous.
As you can see,
case,
the ipsilateral leg is totally
brought the
straight.
20-degree towards me. So my punctures are all in 20-degree towards me. So the C-arm is 20-degree towards me during puncture. After the puncture, I take the C-arm away from me and make it 0-degree to confirm the position of the puncture. So initial puncture is 20-degree C-arm tilted towards me, and the technique in which I puncture is the gradual ascent technique, which I will show you later.
So the technique is my gradual ascent technique. S.K. Pal sir's technique, he is popularized as gradual descent. So since I am doing supine, with sir's permission, I have named it gradual ascent technique. So the IP needle is like a flight taking off from the runway, that's the position.
It is called a gradual ascent technique. So I have explained the patient's position in this case, how the modified GMSP position is. If I show you once, I will just remove the covering so that you can see nicely. So you can see the ipsilateral leg is almost straight. We can try to make it more straight if possible, whereas the contralateral leg is fully abducted as much as possible. And the operating surgeon stands here during electric capsulation. So this is the modified GMSP position. Next I will explain the two supine position also, which I have recently started doing in supine PCNL. Since the start of my PCNL, supine PCNL journey in 2015, all my cases I have been doing in modified GMSP position, but recently for the last 10
So
years.
this is the true supine. So it just a patient lies totally flat on the table. Sir, can I continue, sir? Can I continue? Okay. So supine PCNL, totally flat on the table. This is the true supine, means no sandbag, nothing. Just like a crucified position on table.
But yes, after a few cases, I am finding it better. Technique?
So nothing, as you can see. No sandbag, no stirrups, nothing.
Just the table, the patient lying fully flat on the table. No, and the C-arm position.
So C-arm position I have already told, it's 20-degree towards me. After the puncture, we shifted to 0-degree away from me to confirm.
My markings are not done in the ward.
Next important thing is the marking. Very important is the marking in supine PCNL. 3 important landmarks of supine PCNL we should always remember.
Patient is anesthetized after positioning of the patient. So as we know, the most important line is the posterior axillary line, and in supine position, supine PCNL, our puncture should never be anterior to the posterior axillary line. So the posterior axillary line is the most important position.
So the posterior axillary line is the important landmark, and puncture should never be anterior to the PAL.
In supine PCNL marking. So this is the posterior axillary line. Then coming to the other positions.
I prefer marking the position after anesthesia of the patient, after the position. Some people do this marking in the ward and shift the patient to the OT, but I have been always comfortable with the patient anesthetized and
the PAL, which is this.
So that's the PAL, posterior axillary line. We have the 12th rib and the iliac crest. These are the 3 landmarks we should always remember.
The most important line. Second is the 12th rib, and third is the iliac crest. So these are the 3 important landmarks in supine PCNL. So, and the most important is the posterior axillary line.
So if you see, only this much narrow window we are having in supine PCNL. So the area, the field of exposure and the field which you get, especially after you dilate and you insert the nephroscope, you have a very, very narrow space to work, because you will find the iliac crest below if you shift your hand downwards. Above there will be stirrups. There's a lot of space constraint in supine PCNL. That's a difficult thing.
Like GMSP position or totally supine to supine position, the markings I always do after the patient is positioned. Only after that I do the
So now one important thing I just want to show is, after puncture, how do you confirm that your needle is in the system? So since all the it's supine PCNL. So I've just demonstrated to you guys how we'll confirm.
Forceps, the tip of the forceps, which is proposed IP needle, and the stone, they have moved in a different direction, or the IP needle has moved more lateral.
So if after 20-degree puncture, if we shift the CM from 20 to 0 degree away from the surgeon, if the tip of the IP needle moves lateral in relation to the stone, we are superficial. And since it's supine position, superficial means anterior. Hence, we have to go more deep, withdraw. Similarly, if the IP needle moves medial in relation to the stone after converting from 20 to 0 degree, that means we are deep. That means we are more posterior because patient is in supine position. So you withdraw and go more anterior. This is only the basic one-line funda which we have to remember during the puncture. Sir. Yes, sir. Yes.
Right? So if this happens when you are in 0 degree, so you are superficial. Right or wrong? Right or wrong? In this case, superficial means has gone medial in relation to the stone. So this proves we are deeper to the stone. And in supine.
So then comes the ureteric catheter placement. So in supine position, especially in true supine, it is not a difficulty. In the lithotomy GMSV position, we are always very comfortable. But I used to think that in true supine position, how we'll put the UCAT, especially in case of males. But it happens very easily, and I'm showing it in a video. It goes in very smoothly, no problem. Now I'll show some cases of complex cases of supine PCNL. Initial cases, whatever I did, 30, 40, 50 cases, all were simple lower calyceal or pelvic stones. I gained confidence over a period of months. I published 3-4 papers. Only then I started doing complex cases. So recently I've done stones in diverticular stones, supine PCNL, already published a paper. Supine in horseshoe kidney, paper is published. Supine in cross-fused ectopic kidney, and supine in staghorn. So these I'll show as videos. So this is the gradual ascent technique. As I said, the IP needle is like a flight taking off from the runway. Sometimes it may be horizontal also, because sometimes what happens, you are very posterior to the PAL, because it's always better to be safe, never go anterior to the PL. So many times I go very posterior to the PL, especially in obese patients, and in those cases it's a bit horizontal. Pardon, sir? No, sir. Patient is, sir, the right side is the inferior aspect, sir. So now I'll just show the cases. So the first case is this. It's a duplex moiety, complete duplication. So we attempted supine PCNL. The stone was in the lower moiety. I don't do gradual dilatation. I do a single step 24 French dilatation. All my punctures, all my dilatations are single step. And I don't do with a nephrostomy. It's all tubeless. Second case is supine in horseshoe kidney. So this was an interesting case. The patient had a retained, forgotten, and fragmented DJ stent with a huge bladder calculus also. So in the first sitting, we did a cystolithotomy, removed the lower part of the stent with the stone. In the second sitting, I did the supine PCNL, removed the partial stack kind of stones in the kidney with the stent. So this was the second sitting. Because of shortage of time, I've made it into 2x speed. So the final result. So this was a case of cross-fused ectopic kidney. We attempted lab-guided supine PCNL in this. I did lab-guided. because I was afraid of puncturing the great vessels. This video I presented in POKHARA 2025. I did it just before going to POKHARA. So, multiple divertigo calculi. The problem in diverticular stones is you can't, access into the ureter. So you're not able to secure the system because there's no opening many times. Horseshoe kidney supine, I've done around 8 till now. And this is the one, it's staghorn. Wherever I present this case, everyone tells me why you're on staghorn. Yes, true, staghorn supine, better to avoid. So since I have the luxury of being in a government setup, I'm the head of department, so yeah, there I do stag. But in private, if you ask me, I avoid staghorn supine, to be very frank. But luckily, we could complete the whole bulk. Thank you. So, the only message I'll give is that, yes, please do supine PCNL. Those who have not started, it is a very good thing, and please start. And just be cautious. Initial period, just take simple cases, lower calyceal, middle calyx, and pelvic stones. Don't take any difficult cases. Increase your confidence. Prepare the bowel. Take all the necessary steps I've told you, and I'm sure the journey will be smooth. Thank you. Sir, I give P enema one night before the surgery.
Thank you, Dr. San. Supine PCN. Everybody is speaking on supine PCN these days. And those doing prone tend to be people from the past. That's what the message is going on. So, but next we'll call on Dr. Sasikant Mishra for his presentation on challenging this supine PCNL, who says retrograde access is possible, that's why it's advantageous. So he's going to say, wait, I also have retrograde access.
So at the outset, I would like to thank the members of NOS for giving the opportunity to speak about this topic. So before we start, actually, I should understand from the audience, how many people are doing supine PCNL? One, and prone PCNL? Oh, still we are winners. So prone PCNL is not going to die so easily. So that is why the new complexity. So let's talk about this topic. This is something new. I think I'll be talking about prone ECIRS. I'm not a prone PCNL expert. I'm doing prone PCNL, but I'm not a supine PCNL expert. My colleague in the hospital is doing supine PCNL. And I will tell you an interesting thing why prone ECIRS started. So basically what we need to understand is the majority of us surgeons, we taught prone PCNL and we were comfortable doing prone PCNL till this supine PCNL came into picture. Almost 7, 8, or you can say 1 decade back, and people started contemplating which is better, supine PCNL or prone PCNL. So at the outset, the main thrust of managing complex stone is to reduce the number of tracts. So what we were interested in is that if we were doing 2 tracts, we would do that same case, single tract. If we were doing multiple tracts, maybe reducing to 2 tracts would suffice. Why? Because reducing the number of tracts used to reduce the number of bleeding episodes that we had. So during PCNL, the evaluation of entire collecting system with rigid nephroscopy is not possible in a significant proportion of patients. And when I was doing this staghorn morphometry when I was in Nadiad, what we found was that any stones in an inaccessible calyx, that is calyx which was at acute angle to the main tract and where the infundibulum of that difficult to access calyx was less than 9 mm, we were not able to negotiate that calyx through the flexible nephroscope. Why? Because the width of the flexible nephroscope that was available was 19 French, and it was very difficult to negotiate from a long distance from the amplas to go into an acute calyx which was just parallel to your main tract. So therefore, flexible nephroscopy did not take the flight It was not very common. It is not still not very common. In fact, companies have stopped producing flexible nephroscope just because of this reason. So it is not possible to do flexible nephroscopy in each and every case just to reduce the number of tracks, because it increases the operative time, and it also does not give you much needed help, respite. And of course, Dr. Sandeep is there, but the proponents of supine PCNL, the main advantage that they were telling, basically there was comparison between supine and prone ECRS, and what was found was that the supine PCNL is non-inferior to prone ECRS. The only advantage that the supine PCNL has over prone PCNL is that there is an availability of the option of doing flexible ureteroscopy from below, and therefore there is an option of reducing the number of tracts to complete a complex calycial stone. So, simultaneous flexible ureteroscopy adds to the versatility of supine PCNL, and this can be helpful when we are dealing with complex calycial stone. So this was the scenario where this, the debate of prone and supine PCNL started in our institute also. And here you can see there are multiple calycial stones. So supine tract was made in the lower calyx. 3 stones could be removed from the lower calyx tract. There was 1 stone in the middle anterior calyx tract which required a separate puncture, but the stone is not of great size to make an additional big tract. So there is always an advantage of passing flexible. You can see the flexible scope going from below, and it helped retrieve the stone in inaccessible calyx, and that passed into the nephroscope, and the stone was removed to the nephroscope. So this was the advantage of supine PCNL. So supine PCNL in combination with flexible ureteroscopy, it adds to the multi-channel access to the kidney. So there are 2 channels. This can also help reduce the pressures that Dr. Harpreet sir was telling. Stones located in parallel calyces in the puncture channel, or stones that cannot be found by nephroscopy for a person who is doing supine PCNL, can be removed by flexible ureteroscope, and this avoids excessive torquing of the nephroscope to remove the stones in the inaccessible calyx. 2 kinds of endoscope operate simultaneously, and this provides a mutual drainage channel to reduce the intraoperative pressure of the renal pelvis and prevent infection. This was another special finding, that when we used to do ECIRS, the amount of infective complications were less than when we are doing supine PCNL. So this was probably, I don't think, but this was probably related to some kind of egress which is provided by the 2 simultaneous nephroscopy and ureteroscopy being done in the same tract. Now, if we see a simple stone, there is no complication. There is a stone in the inferior calyx. You go through the inferior calyx, you will be able to remove majority of the stone. So there is no problem when you have a complete clearance achieved by a single tract. The issue happens when you find this kind of situation where there are stones in the multiple calyx and you require 2-3 tracts to clear. Whether you are doing it with supine PCNL, you are doing it prone PCNL. In prone PCNL, you don't have the option rather than to make multiple tracts. So this was the scenario where we started thinking, why not do a flexible ureteroscopy even in patients who are undergoing prone PCNL. So when we searched literature, prone ECIRS was routinely being practiced in China. So we decided to conduct a study, in fact, in our setup, where a person was doing a supine PCNL, they had an option of doing flexible ureteroscopy, whereas the person who was doing flexible prone PCNL did not have the option of flexible ureteroscopy. He was doing multiple tracts. So obviously results of prone PCNL were inferior than supine PCNL. So we shifted the ECRS technique in prone position also, just to reduce the number of tracts and make the arms comparable. So what we do, we put the patient in a frog split leg position. So after the general anesthesia is given, we put the patient in a frog split leg position. Before we shift the patient to prone position, we put an access sheath, fix the access sheet, keep an infant feeding tube, and then change the position. Now, this is the setup for a prone ECRS position, where the patient is lying in a prone position, in a split leg position. The 2 endoscopic systems are there. They are lying ipsilateral to the patient. There are 2 simultaneous lithotripsy systems. And then there is one endourologist who does flexible ureteroscopy from below. He starts the procedure first. If the case is simple, if there are stones in an inaccessible calyx which is not being tackled with the main tract, he retrieves the fragment, puts it into the pelvis, and then you can go and do a prone PCNL. Or if the bulk is big, both the systems are utilized. Both the endourologists will complete the procedure, one doing flexible ureteroscopy from below and the other doing prone PCNL as regularly that we do. So this is the endoscope. Now again, there is a unique system challenge that the patient is lying prone, so there is a split leg position, there is a narrow pelvis. As Dr. Sandeep was telling, in supine PCNL if you do, there is a limited space of the angulation that the supine surgeon has to encounter. In prone ECRS, there is a limited space that the person doing RERS has from below. And obviously what we are comfortable at with prone PCNL, we have the liberty of doing prone PCNL in a wide area. You can remove the number of stones, you can take help from the flexible ureteroscopy from below, and then you can complete the entire procedure what you used to do in 2 tracks or 3 tracks, maybe in single tract you can finish the procedure. So here there are 2 simultaneous people operating on 2 simultaneous endoscopic systems, and one doing from below and the other doing from above. And this is very easily reproducible, and it produces results also. Now taking through a representative case, if you see this case, the main surgeon who will do prone PCNL will approach this case to the lower calyx. He will be able to remove the stones in the lower anterior calyx, lower posterior calyx. He'll be able to remove the stone in the pelvis calyx. But one calyx which has a narrow infundibulum and which is in the anterior calyx will not be approachable from this tract. So ideally, if you are making a plan, you have to make a plan of standard PCNL. Dr. Harpreet was telling you will have to make a plan for a standard PCNL from the lower calyx and maybe a mini tract for a middle calyx. So to avoid this tract, if you do this procedure in prone ECRS position, you will be able to justify this. So here you can see the video. Now there are 2 people, one person, he is doing a flexible ureteroscopy and he's just focusing on that calyx which was not accessible through the main tract. So he's localized that stone in the middle calyx, he's lasing that stone, and the other person is doing prone PCNL from the above tract and removing the stones through the standard PCNL through the main tract. So the 2 people can do the same procedure as a normal prone PCNL and can remove the entire stone in a single session, in a single tract with minimal complications. This is what is prone ECRS. Endoscopic system is very favorable. There are 2 endoscopic units on the ipsilateral side of the patient. So there is no clutters of the instrument. The patient is lying, and between these 2 endoscopic units, you can pass your CM, and that can also be helpful while reducing the clutters that is required for 2 endoscopic units to be operating simultaneously. So this is the C-arm picture. The main tract is through the lower tract, and you can see the flexible scopy that is going through the infundibulum into the middle calyx, removing the stones in the middle calyx, and that person still has the liberty of identifying all the calyces, making sure that complete stone clearance is achieved by inspecting all the calyces visually and making sure that there is no residual fragment. So if you want to increase the stone clearance, actual stone clearance by the CT criteria, utilizing flexible ureteroscopy at the end of procedures to inspect all the system and to make sure that there are no residual fragments, this is the best technique that prone PCNL can be added with. Now there are some scenarios where the stones is small. There are stones lying in different calyx, like this stone in the pelvis, lower calyx, and one small stone in the upper calyx, upper lateral calyx. So this can be done by a single surgeon. So to start with, one can do flexible ureteroscopy, retrieve these fragments, put into the pelvis, and then complete the procedure in a prone ECRS position. But this is not actually true prone ECRS, because in true prone ECRS, 2 simultaneous surgeons have to do the procedure simultaneously. Otherwise, this will become a modification of prone ECRS where flexible is done before and PCNL is done later. So in prone ECRS, again, the 2 surgeons can complete the procedure in a single tract without any problem. So we did this as a initial feasibility studies almost 3 months back, and now we have done around 35 odd procedures, supine and prone ECRS. Now we are doing comparative study between prone ECRS and supine ECRS because we are still not in a position to identify what is the real advantage and what is the value of both these procedures in terms of the current contemporary literature. So the initial study when we select 5 partial stagons, those stagons only that would require minimum 2 tracts, and majority of these stones were completed with a single tract. 4 out of 5 we completed with single tract. In one patient, the flexible scope could not reach the upper calyx. That is another limitation in prone ECRS, and here in that case we had to make an additional tract in the upper calyx. So what are the advantages of prone ECRS? First is it is comfortable to most of the urologists who are doing prone PCNL, and we have all the liberty of doing whatever procedures that we have learned with, and that entire reproducibility of prone PCNL is still there in prone ECRS. What is the advantage for those who are doing RERS? The main advantage that I feel is that since the patient is prone, the system remains full, the PCS remains full, and the system is better seen by a person who does RERS from below, as opposed to supine PCNL where the system remains collapsed. So because the patient is supine and you make a tract, the system remains collapsed, and the person who does RERS will not find the adequate dilatation of PCS to identify the stones. So what we do in supine ECRS, we take out the nephroscope. The person who does PCNL will take out the nephroscope, will compress the tract so that the system gets dilated, and then the flexible ureteroscopy person will see and retrieve the fragments. In prone ECRS, this is not there. He can see the system well, the system remains dilated, and the vision remains also good because it is all the overflow of the water that he is looking at. And again, this is a picture of supine ECRS. So you can see the clutter of instruments. Both the endoscopic units has to be on the opposite sides. So one endoscopic on one side, one endoscope on the other side. The instruments keep on cluttering, and the surgeons who are also doing keep on interfering with each other's vision. This disadvantage is not there in prone ECRS. Because the endoscopic system lies on one side of on the patient. Now, another limitation which is in this case was that there was a stone in the upper calyx. You see there the flexible ureteroscope has just reached the tip of the upper calyx, but we could not retrieve the end of the stone because the length of the flexible ureteroscope in a prone position fell short because of the pelvis and the patient lying prone, and because of the limitation of the both legs. The person who was doing flexible ureteroscopy introduced all the flexible ureteroscope but still could not reach the upper calyx. So this is one limitation which was there. I searched the literature. It has not been reported, but we have been encountering this. But we'll need more patients to study actually what is the reason why the flexible ureteroscope does not reach the upper end of the calyx, especially when the patient is tall and the stone is lying in the upper calyx. So what modification I would suggest is that when your patient is tall and the stone major bulk is lying in the upper calyx, you approach to the upper calyx in the prone PCNL position and leave the lower calyxial stone to be addressed for the person who does flexible ureteroscopy. So this is a brief slide comparing supine and prone. Comfort to the patient. Of course, it is not supine ECRS. Patient is more comfortable because that is anesthesia-friendly position. Any patient who is obese or patient has COPD, supine ECRS is much better than prone ECRS, where the hazards of general anesthesia and prone PCNL is still there. Comfort to the surgeon. For prone people who are experts in prone PCNL, this is best. For people who are better in supine PCNL, supine ECRS is better. As far as the comfort to the person doing RERS, it is more comfortable in prone position rather than supine, because in supine it is tricky as the water seeps out and the system remains collapsed. As far as multiple tracts is required, prone ECRS is superior than supine ECRS. Instrument clutters, prone ECRS is better than supine ECRS. PCNL in special situations like pediatric patients, horseshoe kidneys, anomalous kidneys, again, supine ECRS I think is easy, but we'll need to see much, after 50, 100 cases, what is the situation in special situations. As far as limitations is considered, I'm sure I have seen this, many people are not doing supine PCNL, so therefore the main limitation of supine ECRS is generalized acceptability as of today, but prone ECRS, I think it is more acceptable and would be more reproducible by majority of the people sitting in the auditorium as well as in general public. So to conclude, prone position ECRS is feasible. So prone ECRS is feasible, safe and effective procedure. This is just an initial experience that I am mentioning. It aids in reducing the needs of tracts in prone PCNL, and this effectively utilizes flexible ureteroscopy in split leg position just by putting flexible access sheath instead of ureter catheter at the start of this procedure. Furthermore, standardization of the method is crucial to achieve good outcomes, especially as concerns are raised regarding the flexible ureteroscope to reach the upper calyx in the initial feasibility study in those patients who are tall. And there is also an issue of learning curve in doing prone position RARS, as the movements are actually opposite to what we do in supine ECRS, supine RARS. Thank you so much.
Thank you.
Yeah.
Thank you, Dr. Mishra. That was a very interesting presentation on prone ECIRS. Just another point I can add there is the orientation for the RARS surgeon in prone for the kidneys. Basically, when you're doing a supine, if you're doing a left, the calyces are oriented toward your right. Here, the left kidney, the orientation is in the opposite direction. So although it might sound a bit tricky from outside, when you're operating, you need to be mentally oriented that you're doing the reverse to what you do in a supine for RARS especially. So that orientation, as long as the surgeon is comfortable, is fine, but otherwise it doesn't matter in endo vision as per se.
There's very minimal learning curve for that.
Agreed on that.
I think 4 or 5 procedures, then you will be absolutely comfortable doing prone.
Yeah, and you also made a point on that RARS surgeon goes first and then a PCNL surgeon comes in. It's not necessarily an ECRS, but then it is one after the other. It is still considered as an ECRS. You don't necessarily operate in tandem. Most of the times, the flexible uteroscopy surgeon wants to do it first because the vision is much pristine before the puncture comes in. So it's okay. We can still do a supine and then flip onto a prone and to still call it as a prone ECRS. But very interesting, thought-provoking. Thanks a lot. Thank you.
Thank you.
And I think we have moved past almost 10 minutes from the session time, and we'll hand over the dais for the inaugural session. Any particular questions for the entire session? I can allow one question for a completion's sake. Any questions at all to any of the speakers, starting from the AI neurology to prone ECIRS? Yes, sir. We'll take one question. Dr. Mishra, you have a question.
I am excited that it is interesting. It is generating questions from the audience. Yes. Yes.
Can you use the flexible ureteroscope for the same track?
So the same.
Yes.
So the same restriction what we had for flexible nephroscopy is true for flexible ureteroscopy. The problem is that the instrument is long, and the amplas sheath which is there is short. So effectively, you have an instrument which you are operating from a distance of around 30 centimeters from the patient, and operating from there, trying to manipulate just the tip of the instrument, which is just at the acute angle at the tip of the amplas sheath. So it is very difficult to negotiate. And even if you are successful to retrieve the fragment from a stone in an accessible calyx, just the tip blending and coming and retrieving the stone into the pelvis is tricky. So that is why it is not generally acceptable, or it has not been taken up very aggressively by the urologists. Because practically it is all right that you have a flexible nephroscope, it can go through the amplas sheath and retrieve the stone. To mention it is very easy. But to do it operationally on a table is difficult. While if you pass a flexible ureteroscope from below, your ureter is entirely taking away all your length of the flexible scope that you are having, and you are just operating from the tip. So your tip of the flexible ureteroscope is stable inside the ureter, and you are comfortable doing manipulation inside the pelvic calyceal system like normally what we do in RARS. So that is the reason why it is comfortable for us to operate from below rather than to use the same long instruments and operate from an PCNL amplas sheath. And the other problem is that system remains collapsed.
Thank you. Thank you, sir. Thank you, Dr. Mishra, for that. And we'll conclude the session with that. Thank you. Thanks for that.
Now I would like to request our respected Professor Dr. Jagdish Lal Vaidya sir for keynote speech.
Thank you. Good evening, friends, the NOW's dignitaries, all the delegates and friends. Well, I'm trying to tell you my own story and how was my beginning and where I am now. Well, I came back to Nepal from UK in 1982 with skills in hand, big dreams in my heart, and many unanswered questions about the future. In UK, in 10 years, I had very good training in general surgery and urology. But to my disappointment, there was no urology department in any hospitals in Nepal. So I ended up in a mission hospital as consultant general surgeon with interest in urology. At 1,500 rupees monthly salary, that equals to about $13 per month. There was no lateral entry in any government hospitals. The only post I could get was house officer, in spite of doing my fellowship in 76, 77. That's where I met my partner, Dr. A.K. Banskota, facing the similar problem. He had come back after his fellowship and is staying in America for 12 years. Private practice was not allowed in a mission hospital, but they made exception to the rule and eventually allowed us to do the private practice after hours. Choice was whether to go back to UK, where of course I was working in a teaching hospital, or struggle in Nepal by doing some private practice. Building an institution was never taught to us in medical school or in UK. We opened an 8-bedded first private hospital in Nepal. There was no private hospitals in Nepal up to that time. That was called Kathmandu Nursing Home in 1984. And we soon realized that there was plenty of demand for it and gradually increased the bed to 60. Well, I have got enough time, I think. I will just tell you the small story that to open 8-bedded hospital, we didn't have money. So I had to put my house mortgage in the bank and borrow 50,000 rupees. So all the 4 partners did that. And in that rented place where there was no proper drain, erratic electric supply, and no water source, very small house, basically small residential building. Even the royalties had their operation done there. So we realized there is plenty of demand of private institute in Nepal. I'm talking about the time when there was no glycine available. There was nothing like bipolar TURP, no monitors, no ICU. Disasters were bound to happen. In spite of extreme care, the bleeding, TUR syndrome, as I told you, there was no glycine available. So I started my TUR by using the boiled water. I don't want to go in detail how I managed to keep it sterile. But that's how I did my first TUR in Nepal. I will tell you a small short story. There was a VIP, 66 years old man, had TURP done in one of the referral center in Kathmandu, tertiary care hospital. And on second day was brought to my nursing home at 11:30 p.m. as he was bleeding massively. surprisingly, incidentally, I had discharged all my patients and shut my clinic that day due to some celebration at home. That was called Bartaman, the threading ceremony of my two boys who are in the audience at the moment. One is laparoscopic surgeon, another one is robotic urological surgeon. He was bleeding massively and there was no blood bank in Kathmandu nursing home. So I called the ambulance, transferred the patient to Patan Hospital, that's the mission hospital where I used to work, and followed him in my car. I was whole night trying to resuscitate the patient, and eventually I did the several bladder wash, nothing worked, so I had to open him up. I opened his bladder, packed the prostatic urethra, then his blood pressure came up to 80/60. I realized the importance of help from intensivists, availability of blood, and ICU care. I did not start my journey by dreaming of huge building and beds, but realized we need multidisciplinary institution and the thought of starting our own B&B hospital. We started the private hospital with simple wish to heal and the patients and of course be financially better off so that we could put our children in a better school. Me and Dr. Baskota did bring some operative equipments including endourological instruments, light source and a diathermy with us. I wish to share my experience of building an 8-bedded first private hospital in Kathmandu, Nepal, and converting it into 300-bedded super specialty hospital with teaching and training facility. I feel partnership with like-minded people is the key to success. We bought the land, borrowed some money from the bank, and started first phase of B&B, which was 50-bedded. Resources was limited, but commitment was not. We focused on 3 simple principles: quality before quantity, team before individual, service before profit. Departments expanded, young doctors joined, technology improved, trust from the community deepened. We poured the hospital income into the expansion of the building and the facility. Of course, we had enough income from our own practice. We had a very busy clinic. Years of disciplined growth, careful investment, and a strong partnership finally transformed that fragile beginning into what stands today, a 300-bedded tertiary upper super specialty hospital. I would like to show some slides. Well, fundamentals of running a general hospital, I don't want to go into this. Now, when you talk about opening a hospital, I'm sure it is true in the neighboring country as well, that you got to register with the Ministry of Industry, you got to register with the VAT, you got to have the building, and it is inspected time and again by the Health Institute, Health Division, and you got to have the approval from the environment. And once you build the building, it got to be earthquake resistant, and the building society will come and inspect it. And the government will come and find out that how many nurses are there. 1:1 in ICU and 1:4 in general wards. And of course, you got to have the tax clearance. Now, this is the Kathmandu nursing home. Now, B&B, it looks a big building, but we didn't have money. So we bought the land where it was cheapest in the valley, near the ring road, so that we could open 50-bedded hospital first. I will tell you one thing, that when we inaugurated and we laid the foundation stone, B&B, we didn't invite anybody, we laid the stone. There was no electricity in that area. And there was no public transportation in that area. So we drove our Maruti Gypsy, and with the headlight on, we did the celebration, whatever the Panditji said, we inaugurate that place. And that is the B&B plus, that is the present. Now we realized, after working in the crampy position in Kathmandu nursing home, we need to have a lot of space in the OPD, because it looks better and the patients feel better. And what are the different departments? We have got maybe more than 26 departments in B&B. I'm sure you will know those who are working in the hospitals. The wards got to be neat and clean. It should be better than the another hospital, or at least in par, so that in the waiting area is spacious. Though in Asian country, I'm sure it is same everywhere. 1 patient and 10 visitors. So we don't allow many visitors in the patient's bed side, so that they have got a good waiting area where they can gossip, of course. The room got to be state of the art and presentable. And you got to have accident and emergency. That is where you get your patients from. So that, and in the accident emergency, there is regular teaching, training going on. They have this ALTS training, certification, etc. And we have got one super specialist, 4 MD-GP, 5 registrars, medical officers, total 19 staffs. We have got 20 beds in the emergency. And the team they are quite well trained to evacuate the patients from anywhere in Nepal. Heli evacuation. We have got helipad on the top of the roof, but it is not functional at the moment. So our team goes to the airport and picks the patient up. Of course, you see the patient, as soon as he enters the operation theater, if it looks like a storeroom, psychologically they are upset. So this is my operation theater where this is theater number 2, where I put my robotics as well, and it got to be clean and spacious. We have got 9 modular operation theater and 9 ordinary theater. We do in one day, because I provide the food for them. I know how many of them are there. So there are 90 staff working any day in the operation theater. And average, we do about 40 operations every day, maybe 56 sometimes, 36 sometimes. We do more than 12,000 operations in 1 year. I'm not trying to boast that B&B is this and that. This is what you need if you want to open a hospital. This is the basic minimum requirement now. You got to have good ICU. We have got general ICU beds as well as the cubicles. One thing is for isolation. Another thing, these days the patient demand that they want privacy even in ICU. So there are cubicles and the pathology department. This is our pathology department. You can see so bright, and you can see the whole range of mountain from there. It is 6th floor, and ours is category B. We thought the category A is not financially viable. If it is a private hospital, you got to have good equipment. I don't have to tell that. And pharmacy is one unit which makes a lot of money for any institute. So we try to prevent the patient going out to buy the medicine. So we have got total of 5 pharmacies, 1 general pharmacy in the ground floor. Operation theatre has got 2 pharmacies, 1 in the IVF and 1 in OPD. And of course the trained pharmacists will have to maintain the temperature. There can't be any date expired medicines, and of course narcotic medicine management is done by the pharmacist. In Kathmandu nursing home, in a small room, we used to boil, autoclave and do the operation. Now the CSSD department is big, where we can see 2 dummy lifts. One brings the dirty equipments and another takes the clean equipment in different floors, so that it is scientifically built, big machines and manpowered. This housekeeping is the largest department in the hospital. We employ 130 people. Half of them clean the hospital. Every 15 minutes, they are there, cleaning the hospital. And of course, you got to segregate the linen, which is blood stained, which may be infective, and of course the clean, and so that they segregate and clean in the big machine. They iron and send it to the store. And another important thing which the government is very keen in the hospital is the waste disposal. We have got solid waste disposal, the autoclave, the liquid waste disposal. It has got 4 chambers. From 4th chamber, when it comes out, they say you can drink the water. Who drinks? But it goes to the public drainage system. And of course, this organic waste, recyclable, that everybody knows. And in a hospital like ours, we need 200,000 liters of water every day. So, you know about the water shortage in Kathmandu. Melamchi is just a little bit of narrow neck, so that we have got 2 boring, deep boring. You got to get the permission from the government. Just in case one boring stops working, we have got another one. And we have got dedicated Melamchi water, and we have got reverse osmosis for dialysis as well as for the public drinking. Electricity, how erratic the electricity is in Kathmandu, you can't imagine. 15 minutes light is off, so that our patient of course can't have no electricity even for 5 minutes or 1 minute. So that you can see there are multiple generators, and we have got our own transformer, and of course you need to have the central oxygen. We have got central suction, central oxygen pressure. I mean the air pressure. This is logistic management. In a hospital of 300 bed capacity, it occupies such a big space. The papers, the cleaning things, there is a manager. Of course, you got to buy it in the economic, cheapest way you can, and you need a lot of space for logistic inventory. And you got to have the open space around your hospital. That we learned from 1972 earthquake. Nobody wanted to go inside the hospital. We had to do minor operations, major operation out in the parking area. So it is very important that you have got enough. Disaster can happen anytime. And of course the parking is another. More busier you are, you need more parking. So we have got 150 parking places in different zones, 3 zones, staff, hospital doctors, and of course the visitors. And in Kathmandu, the 2-wheeler is more popular, so that we have got provision for 400 2-wheeler parking. You can see, almost all of them are filled up. A very important department, if you want to open the hospital, you got to have good maintenance. I have got a maintenance lady here, the biomed engineer, and it is manned by 2 full-time biomed engineers and multiple other diploma holders. It is, since you use so many electronic and electrical devices, it is mandatory that you have got good maintenance department. And when you get a hospital like this, disasters tend to come there. We are near the airport, so that time and again we have got disasters, so that everybody in the hospital is aware of this green zone, yellow zone, red zone and black zone. Hopefully nobody goes to black zone. And of course we have got a disaster evacuation plan, and we have there is a booklet, and all the staff, they are aware of it. Ambulance, I don't have to tell you, it is important to transfer the patient. Another thing is canteen. This is run by the 2 dietitians, manned by 2 dietitians, and there is a separate for the visitors and separate for the staff, and patients, they get free hygienic food 4 times a day. If I say free, I might be lying, but that money comes from where along the course, but for the patient, it is breakfast, lunch, evening snacks, and dinner free. And of course, when I built the building, I said my public toilet should be cleaner than at the airport, so that we have got a separate bathroom and toilets for visitors, disabled friendly toilets, male and female. In the female toilet, there is a breastfeeding facility also. I, being the managing director, I visit every public bathroom at least once a month and check it myself. Of course, you got to have security staff, surveillance camera, alarm and paging system, fire extinguisher, smoke detectors, etc. And the government is very strict. Only 2 days back we had inspection again, and they make sure that there is 10% of the beds are free, and elderly people get the discount, whatever the government rate is. And the vaccines, the government provides, of course, but we got to give it free. And there are plenty of patients also. If you want to run a hospital like this, you cannot forget the poor people of Nepal. Now, since it is a tertiary care hospital, you need to have some of these gadgets like thulium laser, the operative microscopes, and of course this is endourological laser suites with quantum thulium laser. This is a holmium laser, which is almost obsolete now. Nobody wants to use it. We have a 2 plasma, 100 and 120. You got to invest on these things, because infection is the dreaded complication, whatever operation you do. Of course, you got to have good MRI, good CT scanning, spacious, and you need multiple SIAM, because our hospital is famous for trauma, accident emergency, so that we have got maybe more than almost a dozen of SIAMs, multiple portable X-rays. And of course, we have 18 ventilators and the DEXA scan digital X-ray, which is must these days. And recently we have opened the blood bank, which is of course category C. I don't want to get in detail what is category C. And I have got a suite. This is surgery urology suite called the JLB Center. We do transplant and dialysis in this floor. Well, I'm the first one to import a robotic in Nepal. Did I do the wise thing? Maybe not. The instrument is one thing. Manpower is the most important thing. And I have sent my son to Rajiv Gandhi Cancer Hospital training, but still you can see the Sudhir Rawal there trying to inaugurate that thing there. But we need mentorship even now. Amitabh Ji is here. He has been very kind to come and guide the boys. And if you want to use the laser just by urologist, you are bound to lose money. It got to be used by the gynecologist, by the general surgeon, of course by the urologist. We have got very good, active, very popular IVF center. The cherry on the top. The cath lab runs 24 hours. And NICU have a 10-bedded and acute stroke unit. We are one of the first to open the acute stroke unit. We have got 24-hour, the interventional radiologist available. Of course, sometimes when you do PCNL and you bleed, and they will quickly embolize the bleeder site. We have got good skin and aesthetic clinic, speech therapy, and recently we have just opened the AKB limb center because there are so many amputees and you don't get good limbs here. So we have tried to copy the institute in India, in Rajasthan. So I hope we improve on that. When you run a hospital like that, you got to have good academic activities. We used to run the MBBS program and MS program for 5 years for Kathmandu University. And now we have got BMI where we teach the nursing, BSc nursing, BN and PCL. And I am one of the oldest one to run the FCPS program for Pakistan. And now the National Board of Medical Specialists in different departments, the government has trusted us, and there is multiple fellowship program, particularly in orthopedics. Now publication, you must have. There are, I am not boasting it, but we have 40 publications per year, 50% in international journals. And our surgeons, orthopedic surgeons have written in the chapters in the textbooks. And we do regular free health camp in the surrounding Nagar Palika. Because we have got blood bank, mandatory government rule is that every week there should be blood donation program, which we hold either in BNB itself or in the surrounding wards. A genuine friendship that brings a smile to millions of patients and uplifts the spirit of thousands of employees. The employees are like our, not servants, they are colleagues, whether it is a sweeper or your consultant surgeon. This is the Santa Bhavan Hospital, the mission hospital, where Baskota and Vaidya used to work in 1982. I told you, no money, so that we built the first phase, 1997, 50 bedded, then gradually increased. This is the phase 4. And I'm already 83. So before I retire, I want to make sure that the phase 5, fifth phase is complete, and then I will take my retirement. And behind all this success, there are 2 ladies. Without their help, it's not possible. I can't carry on for lifelong. You know, the second generation, our children. This is a, with the whole, the 10 is that you, in this audience, I'm sure of it, 50% of your kids are in America, UK, Australia. I'm very proud to say that my children, though they were British, now are Nepali, they are serving in Nepal, and Dr. Banskota's all children, they were brought up citizens somewhere else. Now they are all employed in BNB, so that there is already transformation of the management in the younger generation. If your hospital is good enough for your patient, it should be good enough for you also. This is Dr. Banskota having major operation. I had my major operation, And my wife, when she was COVID, she was in ventilator support for 2 months in BNB. She almost fully recovered now. So last month, we were awarded the Institution Builders Award 2025. And now I would just like to, it sounded, I'm sure that BNB did this and that, but all these things, they are important if you want to open a hospital. Well, friends, building a hospital is not about concrete and machine. It is about the people. It is about trust. It is about staying awake at night, worrying about the patients, staff salaries, and the quality of care, and still waking up every morning with hope and a smile. Ego in partnership, far to step aside. We move forward in partnership. If Vaidya and Banskota can dream and succeed to create an institution, a super specialty hospital, then any dedicated doctors in the audience can dream of something bigger than themselves. When medicine meets purpose, miracles quietly happens. You just need the blessing of the God. Thank you.
Thank you, Vaidya sir, for your speech. Please be patient. The inauguration session will start in a short while. Thank you.
Ceremony, may I kindly request all our distinguished guests and delegates to please take their respective seat and settle comfortably because we shall be commencing shortly the inaugural session. Respected dignitaries and esteemed national and international delegates. I'm Diksha Khati and it is my deep honor to serve you as your Master of Ceremony in this inaugural session. On the behalf of Nepal Association of Urological Surgeons, it is my privilege and a great sense of honor to extend a heartfelt welcome to each one of you to this prestigious occasion, which is the inaugural ceremony of Urocon 2026. This conference stands as a remarkable platform that brings together esteemed urologists, distinguished medical professionals, respected academicians, and valued partners from Nepal and across the globe, united by a shared commitment to advancing excellence in urological science, practice, and collaboration. Your gracious presence here this evening not only elevates the significance of this gathering, but also reflects your dedication towards strengthening professional exchange, fostering innovation, and contributing to the continued growth of urological care, both nationally and internationally. So to formally commence this inaugural ceremony, it is now my distinct honor to invite our distinguished dignitaries to kindly grace the dais. First of all, let me invite the chairman of the inaugural program. Ladies and gentlemen, please join me in welcoming President of the Nepal Association of Urological Surgeons, Professor Dr. Paras Mani Shrestha, with a warm round of applause, ladies and gentlemen. Ladies and gentlemen, now we are truly honored to be graced by the presence of a distinguished academic leader, an accomplished medical professional, and a visionary whose contributions to medical education and healthcare have been profoundly impactful. So, ladies and gentlemen, please join me in extending a warm and respectful welcome to our chief guest, the Vice Chancellor of POKHARA Academy of Health Science, Professor Dr. Bharat Khatri. So, ladies and gentlemen, let's welcome our chief guest with a warm round of applause. Ladies and gentlemen, now I'd like to invite the local organizing chairman of the inaugural program, Dr. Dhurva Adhikari, to kindly join us on the dais. So, ladies and gentlemen, please welcome Dr. Dhurva Adhikari. Now, I would also like to invite the organizing secretary of Urocon 2026 and general secretary of NAOS, Dr. Suman Chapagai, to kindly take his place on the dais. I now would like to invite the Vice President and Chairman of the Scientific Committee, Professor Dr. Anil Shrestha, to kindly grace the dais. And finally, let me welcome the local organizing secretary, Dr. Prakash Chhetri, to kindly join the distinguished panel on the dais. Ladies and gentlemen, the dais is now graced by our distinguished dignitaries, and let us once again acknowledge them with a heartfelt round of applause. And now, to honor our esteemed chief guest, I request the President of NAOS, Professor Dr. Parasmani Shrestha, to kindly present a bouquet as a token of love and appreciation. I also request Dr. Manishman Pradhan to kindly assist him. Thank you so much. Ladies and gentlemen, as we honor this prestigious gathering and the spirit of unity, excellence, and national pride that brings us together, we shall now proceed with the national anthem of Nepal. May I now respectfully request everyone present in the hall to kindly rise and join in paying tribute to our nation with the national anthem of Nepal.
ढुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली सयौं ढुङ्गा फुलका हामी एउटै माला नेपाली फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचल वीरहरूका रगतले ज्ञान भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल.
Thank you, everyone. Please be seated. Ladies and gentlemen, now it's time for another auspicious moment. The lighting of the traditional panas is a time-honored ritual that signifies enlightenment, hope, and continuous pursuit of knowledge. It marks the auspicious beginning of this conference and reflects our shared vision for progress and excellence. I now respectfully invite our chief guest, Professor Dr. Bharat Khatri, along with all dignitaries on the dais to kindly light the panas and officially inaugurate Urocon 2026. Thank you to all the dignitaries. To extend a formal welcome and set the tone of this prestigious gathering, I would like to invite the chairman of this inaugural session and president of NAOS, Professor Dr. Paras Shrestha, to deliver the welcome address. So ladies and gentlemen, let's welcome him with a huge round of applause.
Respected Chief Guest, Professor Bharadwaj Khatriju, my senior colleagues, esteemed international delegates and faculties, my fellow urologists, enthusiastic residents and dedicated nurses, ladies and gentlemen. It is my utmost honor and privilege to stand here today before you in this beautiful city of Pokhara, the city of lakes and mountains, to inaugurate our annual conference of NAOS Urocon Nepal 2026. As we gather here, the majestic Annapurna range watching over us and the pristine beauty of Fewa Lake besides us, we are reminded of nature's perfection in this city. It is a fitting metaphor for our field, the need of calm precision of still waters, combined with strength and to navigate the challenging, rapid, and complex clinical scenarios. Few years ago, at our last conference here, we set forth a vision for future of urology of Nepal. Today, we meet here again in 2026. It is time to take stock of our voyage. The landscape of urology is changing in a very rapid pace, and from robotic-assisted surgery becoming more accessible to the revolution of artificial intelligence in diagnostic, the world is moving really fast. The question before us is not just whether we are keeping up, but whether we are setting the pace of the world. Since its establishment in 2005, NAOS has worked tirelessly to promote the growth of urology in this country at the time when the specialist services were limited and need was great. Today, we take pride to this remarkable process made in this clinical practice, training, research, and technological adoption in our country. We must remember that a patient in a rural clinic deserves the same standard and privilege of clinical care as a patient as in a tertiary hospital like in Kathmandu and Pokhara. Our mission as an association is to standardize the education, promote ethical practice, and ensure the technology services to every Nepali citizen as possible. Urocon has become the flagship of academic platform of our association, bringing together experienced surgeons, young trainees, and researchers, nurses, and industrial partners together in one roof. This year's conference once again provides the vibrant forum of sharing knowledge, debating controversies, and exploring innovations that are rapidly transforming our urology worldwide. The scientific committee has curated an excellent program featuring keynote speakers, panel discussions, live and semi-live demonstration, abstract presentations, and workshops. I am confident that academic deliberations over the coming days, including tomorrow, will enrich our clinical practice and inspire our research collaborations. To the resident and the young urologist in this room, you are the future, and the surgical knife and the endoscope in your hand are the tools of healing, but they are also instruments of innovations. Do not be afraid for questions. Like in our old days, we were very scared to even ask questions. Do not be afraid to publish your research, even if it is a case report in a rural hospital. Your observations are the bedrock of tomorrow's textbooks. So let us leave Pokhara not just with updated knowledge, but with renewed friendships and also reinforced commitment to the oath we took when we were just a young doctor. I extend my deepest gratitude to the organizing committee. We have really worked day and night to keep up with this event and made this a reality. I thank my sponsors for believing in us and our vision, and I thank the delegates to be here with us today. So my special gratitude to my ISC classmate, my MBBS classmate, as well as my roommate, Professor Bharat Bahadur Adhikari, to be with us today as our chief guest. So may the tranquility of Himalayas guide our hands and clarity in our mind as Favor Lake. I wish you all highly productive and memorable Urocon 2026 POKHARA. Thank you.
Thank you, sir, for your warm and inspiring words. Now, ladies and gentlemen, in order to deliver the welcome address, I would like to invite on stage the local organizing chairman, Dr. Dhurba Adhikari, to present the speech for us. So, ladies and gentlemen, let's welcome him with a huge round of applause.
Namaste and good evening to all of you. Respected Chief Guest, Professor Bharat Bahadur Khatri, distinguished national and international delegates, and respected seniors, colleagues, ladies and gentlemen. Good evening and a very warm welcome to all of you to the 11th National Conference of the National Association of Urological Surgeons here in the beautiful city of POKHARA, which is occurring third time in the history of NAUS. It is a great honor for us to host this prestigious gathering. On behalf of the local organizing committee, I would like to sincerely thank the Central Committee of NAUS for entrusting POKHARA with the responsibility of organizing this important academic event. Ladies and gentlemen, we are especially privileged to have our respected chief guest, Professor Bharat Bahadur Khatri, whose presence greatly inspires us. We are equally grateful to our international faculty and delegates who have traveled from afar to share their experience and enrich our scientific sessions. This conference is not only a platform for academic exchanges, but I believe it's also an opportunity to strengthen professional bonds, foster collaborations, and advance urological care in Nepal and beyond. I would also like to extend my heartfelt thanks to my dedicated team in the local organizing committee, whose tireless efforts have made this conference possible. We hope your time in POKHARA will be academically rewarding and personally memorable. Thank you, and wishing all of us a successful conference ahead. Good evening.
Thank you so much, sir, for your warm words. And ladies and gentlemen, now it's time for a very special moment of this evening, the release of the official conference souvenir of Urocon 2026, which captures the vision, achievement, and collective efforts of the urological community, both nationally and internationally. So, I request our esteemed chief guest, Professor Dr. Bharat Khatri, to kindly release the souvenir marking this significant milestone of the conference. I would also like to invite Dr. Sujit Podel to kindly assist him in this ceremonial release. All right, ladies and gentlemen, with this, the official conference souvenir of Urocon 2026 is released. Thank you, sir. And now, we move on to one of the most special and prestigious moments of this evening, the felicitation session. The Nepal Association of Urological Surgeons takes immense pride in conferring honorary membership upon a distinguished international urologist in recognition of his outstanding contribution, unwavering support, and outstanding contribution, unwavering support, and continued commitment towards strengthening professional collaboration, advancing the mission and vision of NOWS. This honorary recognition reflects our deep appreciation for excellence, leadership, and dedication to the global urological community. May I now invite the Organizing Secretary of Urocon 2026 and General Secretary of NOWS, Dr. Suman Chapagai, to kindly introduce our honorary member.
So this year, to continue with the tradition, we are awarding our honorary membership to Dr. Michael Y.C. Wong from Singapore. So I'm going to introduce him. He's a dual USA fellowship trained urologist in both endourology and female urology with an exceptional international standing. So he has an educational background. He is Government Public Service Commission medical scholar and graduated from the National University of Singapore in 1985. So he entered the General Surgery Residency Program where he obtained his FRCS Edinburgh and Master of Medicine General Surgery in August 1990. So after a bout of uriatric colic, he switched from surgical oncology to the 4-year National Urology Residency Program from 1991 to 1994, where he was largely based at Singapore General Hospital. So he completed 3 USA-based postgraduate programs: fellowship in endourology and urolithiasis, fellowship in female urology, and mini residency program in robotic urology. So he's 64 years old, and he is currently the president of the Endourological Society. He is also currently the associate consulting editor of the BJUI Knowledge at the British Journal of Urology, and currently medical director at International Urology, Fertility and Gynecological Center at Mount Elizabeth Medical Center. So he has several international contributions. The president of USA-based Endourological Society and World Congress of Endourological Society, and he also is a board of director of the Endourological Society and World Congress, and member of Scientific Committee of the World Congress of Endourology, and the Award Committee of Endourology Society, and he was the editorial survey reviewer of Journal of Endourology and Percutaneous Surgery. So in the Urological Association of Asia Arena, he is currently elected as the Honorary Executive Director of the Urological Association area for the tenure of 2026 to 2034. He started and organized the joint UA-AUA residency program since 2016 in this platform, and also associated with the BJUI Knowledge. So he has been involved in the several of the UAA Congress, and in the Singapore Urological Association, he acted as a president. He was president of Singapore Urological Association from 2009 to 2012. He was honorary secretary of the Singapore Urological Association also before this. And he had different global awards. The president of USA-based Endourological Society in 2026, the American Urological Association Award for Global Leadership in Urology 2018, UAA Honorary Member Award, Thailand Annual National Urology Lecture, Indian Annual National Urology Lecture, Singapore Urological Association Lecture are very, to name a few. So he has also been involved in the hospital management beside the the urological aspect. He has been pioneering the corporate director, and then he initiated several completely new initiative and business units in the Singapore General Hospital, Corporate Health Screening Center, and also he is the specialist. He also a specialist practice center in the Gleneagles Hospital, the Hyperbaric Medical Center, and so many are to name a few. So, since he is not available, we are going to play his virtual message, and we are awarding the honorary membership to Professor Michael Wong. So, let us have the video, please.
It is my great privilege and honor. Good evening, dear friends and colleagues. It is my great privilege and honor to receive Nepal Association of Urological Surgeons honorary membership for 2026. This recognition is especially meaningful as it coincides with the 21st anniversary of your distinguished society. I'd like to express my sincere gratitude to President Paresh and the entire Council for giving me this great honor. This year, 2026, is especially meaningful to me in many, many ways. Firstly, I'll be turning 65 years old soon. I am now the 4th Asian president in the 43-year history of Endo-Urology Society and World Congress of Endo-Urology. At the end of this year, I also become the Executive Director of UAA. Indeed, to make this year even more special, I'm deeply honored to receive this very special recognition from Nepal. I wish you all a very successful meeting, and I look forward to thanking you all personally at next year's conference at Nepal. Dayabat, or thank you in Nepali. Good night.
So thank you so much, Professor Wang. So to honor him, we are awarding the certificate. So I ask, Dr. Vaikuntha, our president, to read out the certificate for honoring Professor Michael Wang.
Let me read out our certificate we awarded Professor Michael Wang. Certificate of Honorary Membership, Dr. Michael Wang is hereby recognized as an honorary member of Nepal Association of Urological Surgeons (NAUS) in appreciation of his outstanding contribution to the development of urology in Nepal. Awarded on 27th February 2026 during the 11th Annual Conference of Nepal Association of Urological Surgeons, Urocon 2026. Signed by Organizing Chairman, Secretary, and Scientific Chair. Thank you. So I
Thank you, Dr. Chapagai, for that gracious introduction. And ladies and gentlemen, now it's time to invite the chairman of the scientific committee, Professor Dr. Anil Shrestha, and I request him to present the scientific committee report.
Thank you. Very good evening, respected chief guest, president of NAUS, distinguished dignitaries on dais, esteemed national and international faculty, honored guests, dear colleagues, residents, nursing professionals, ladies and gentlemen. It is a distinct honor and privilege as a chair of the scientific committee to welcome you in this 11th Annual Conference of Nepal Association of Urological Surgeons, Urocon 2026. Over the past months, my team of the scientific committee has worked with singular vision to design a program that reflects the aspiration of urology in Nepal. The journey began with our pre-conference workshop themed Dawn of Nepal's Robotic Era, learning from the masters and building the future, a theme that captures the transformative phase our specialty is currently experiencing. Urocon 2026 brings together an outstanding assembly of national leaders and distinguished international faculty through collaborative sessions and association lectures. Their presence underscores our growing academic integration with regional and global urological community. We are proud to host dedicated sessions in partnership with regional scientists, building academic diplomacy and shared learning across the borders. The structured debates, expert panels, and evidence-driven discussion reflect our commitment to academic integrity and critical appraisal, qualities that define progressive surgical practice. A significant addition this year is the introduction of focused instructional courses that we designed carefully, skill-oriented, aimed translating evidence into practice competence. These courses reaffirm our shift towards structured outcome-oriented education. Equally important is the comprehensive urology nursing segment. By providing an academic platform for our nursing colleagues, we acknowledge their important role in ensuring safety, efficacy, and quality outcomes. Our residents and young urology award session represents the intellectual vitality of our future consultants. Their research contributions and clinical insights reassure us that the next generation is not only capable, but visionary. A particular meaningful highlight is the word of wisdom from the master this afternoon, an opportunity to reflect the mentorship, professionalism, and the values that shape a competent urologist from residency to consultants. In an era driven by technology, it is these principles that sustain excellence. Respected delegates, Urocon 2026 is not only a scientific gathering, it is reflection of our collective progress, our collaborative spirit, and our shared commitment to elevate urological care in Nepal to highest standards. I encourage each of you to participate actively, engage thoroughly, and use the platform to exchange ideas that will influence practice long after this conference concludes. With great pride and warm regards, I welcome you all to NOW's Urocon 2026 and wish you a stimulating and rewarding conference. Thank you.
Thank you, sir. Now, ladies and gentlemen, Urocon 2026 is deeply honored by the presence, support, and continued collaboration of our esteemed international associations. Their contribution have played a vital role in advancing the standard of urological care, not only in the region, but across the global medical community. The enduring relationship between NOWS and these respected international bodies reflects a shared vision of excellence, innovation, and collective progress in the field of urology. So now it is my great honor to invite our distinguished international representatives to share their best wishes. So firstly, I would like to invite the representative of the Urological Association of Asia, Dr. Anthony Ng, on the stage. So ladies and gentlemen, let's welcome him with a huge round of applause.
Distinguished now the Chairman, Professor Palas, and also leaders. Dear colleagues and friends, on behalf of the UAA and also the OSTEC group, I would like to extend our greatest congratulations to the Nepal Association of Urological Surgeons, NOWS, for organizing such an exceptional Urocon 2026. The continuity of the scientific exchange and the warmth of your hospitality have been so exceptional. And despite relatively small, Nepal continues to be a vital part of Asia, seeing the innovation and also the commitment on display here, reaffirming why our partnership with the NOWS are so valuable. And thank you for bringing us all together to push the boundary of our field. I look forward to have more collaboration in both UAA and OSTEC platform and bring the best care to our patients. And once again, congratulations to the entire NOWS team. Thank you.
Thank you, sir. And now, ladies and gentlemen, let me invite the president of the SARC, Association of Urological Surgeons, Professor Dr. Hamad Athar, on the stage. So, ladies and gentlemen, let's welcome him with a warm round of applause.
Thank you very much for a very kind invitation. All gentlemen on the stage, all respected chairmen, the president of the NAUS, the cabinet, the scientific committee. I'm really amazed at the hospitality, the scientific contents of this meeting, and I'm sure tomorrow will be another exciting day in this regard. NAUS is a very active member of South Asian Association of Urological Surgeons. We had the pleasure of having the first General Secretary of NAUS, of SAUS from NAUS, Dr. Pawan Chalise, who did a wonderful job as the General Secretary and currently is also the scientific chair of the SAUS Association. We had very positive contribution coming from all NAUS members, and I'm really happy that we had a wonderful session, a joint session with NAUS and SAUS in the afternoon, which was very well attended. As always, this is my fourth or fifth visit to Nepal. The hospitality is just out of words. I mean, I can't put it into words, the kind of hospitality and love that I have received in this country. And I wish them best, and I hope that we'll have greater collaboration between NAUS and SAUS to take urology to the next millennium. Thank you very much.
Thank you so much, sir. And now, ladies and gentlemen, let's welcome the Honorary General Secretary of the Urological Society of India, Dr. Uttam Mete, on the stage. So, ladies and gentlemen, let's welcome him with a huge round of applause. और सर, नेपाल में आपका स्वागत है.
आप नेपाल में बोला, मैं हिंदी में बोलता हूँ. नमस्कार. Good evening. The respected chief guest and guest of honor, the president of the NAUS, Dr. Paras, Secretary Shumon, and other dignitaries on the dais, Dr. Anil, of course. My friends, Nepali urologist friend, the other international faculty members, ladies and gentlemen. It is really a proud moment for me to be here as secretary of a bigger, or you can say in the Asian region, the bigger society, that is the Urological Society of India. And on behalf of each and every member of the Urological Society of India, I bring warm greetings to all my Nepali friends, all my Nepali colleagues. And I must congratulate you for giving this beautiful, beautiful, prestigious event. As you all know, that India shares the boundary, geographical boundary with Nepal. But it doesn't end here. We share so many things. We share our history, we share our culture, we share food. So whenever I come here, I see I don't find any uncomfortable here because the food is same. We talk the same language. I don't know, more or less. So that is what we share. Well, in the field of urology also, we share so many things, both professional as well as academic things. As you already know that we have academic exchange programs, and that is for the benefit of everybody. So we share a relationship. That relationship or friendship is mutual, collaborative, and I think it is going to continue. I take this opportunity, few minutes. You know, my first visit to Nepal was more than a decade ago. On that time, I was the secretary of North Zone chapter of the Urological Society of India, and the conference or the workshop was, it was held in Dhulikhel. Dr. Mahesh Adhikari was the secretary, I remember, and I had performed the live surgery, the laparoscopic surgery. I think that was the beginning of laparoscopy in Nepal, if I am correct. But today I saw how it has progressed. I saw from the lecture of Professor B.L. Vaidya sir that now they have acquired robot. So congratulations, many, many congratulations for this huge and tremendous progress. And as a urologist or as a profession, you need two things. One is your knowledge, and second thing is your skill. Definitely from the contents of this conference, which has been nicely curated by the scientific chair and other scientific secretary and the president also, the content shows this tremendous progress in the knowledge. What they need is the skill. I think on that front, we can help for a skill exchange program with India. And another few areas where we can help is the research. Collaborative research wing is there in the USI. We can have a multi-centric, multi-country research program. That way it might help. And third thing what we can do is the exchange program for the skill also, not only for the residents, for the young faculty also. I think these are the few areas where we can progress, we can have a little bit of further progress there. And on behalf of Urological Society of India, I reaffirm or confirm our bonding, whatever is there, this friendship or relationship is going to be stronger and stronger as the days come. And I wish you all a good success for this conference and for the future also. Thank you very much.
Thank you so much, sir. And now, ladies and gentlemen, let's welcome the President of the Malaysian Urological Association, Professor Noor Ashani, on the stage. So, ladies and gentlemen, let's welcome him with a huge round of applause. And sir, Salamat Datang ke Nepal.
And thank you, Master of Ceremony. First of all, on behalf of Malaysian Urological Association, I would like to congratulate and announce for successful meeting in POKHARA, NAUS 2026. I also would like to thank for invitation of Malaysian delegates, including myself and my trainees, to come here to learn from all of you in Nepal. I think our bonding getting stronger with time. This year will be my last year as a president of Malaysian Urological Association, but I believe our collaboration will continue in the future with whoever that's going to become the president. And I wish you best of luck. Thank you.
Thank you, sir. And now, finally, let's welcome the President of the Sri Lanka Association of Urological Surgeons, Dr. Srinath Chandrasekhara, on the stage with a huge round of applause, ladies and gentlemen. And this is something I'm going to try for the first time. Nepala Tirikavarika, sir. I don't know if I pronounce it right or not, but all right, ladies and gentlemen, once again, let's welcome him with a huge round of applause.
Good evening, ladies and gentlemen. President of the Nepalese Association of Urological Surgeons, Professor Paras Shestra, chief guest, members on stage, respected members on stage, friends, colleagues, ladies and gentlemen. It is indeed a wonderful moment for the Sri Lanka Association of Urological Surgeons to be here, and my association brings the warmest greetings to Nepal. As you know, Nepal and Sri Lanka, the cultural similarities and our bonds run as far back as the documented history of Sri Lanka, and you know the basis of that. Our friendships, our culture, as well as our mutual respect is as old as the documented history. So it is a very special occasion for us from Sri Lanka, and we've got a delegation not only of consultant urologists but of trainees attending this conference. I'm also even more delighted that similar delegations have now begun and continue to visit Sri Lanka for our conferences, so this is a growing bond. It is very relevant for us to be here because in South Asia we share many challenges as well as opportunities, and it is a very appropriate forum for us to meet, to listen to each other, to discuss with each other, and to move forward with common solutions to the population of people in this area with so many common issues. I'm also very glad that despite these traditions, for the first time, SLAUS, which is Sri Lanka Association, as well as NAUS, has today signed a memorandum of understanding formalizing these friendships and activities. So thank you, sir, for this opportunity, and I'm sure our bonds will grow from strength to strength. Finally, I would like to announce that the next Sri Lanka Association of Urological Surgeons meeting, which is a forum like this, with attendance from the region and internationally, will be held in November, the last weekend of November, and I do look forward to even a bigger contingent from Nepal attending. So once again, thank you very much for inviting us, for your wonderful hospitality. We've been made to feel so much at home, and for putting together this fantastic academic event, and I'm sure tomorrow will be even better than what we witnessed today. Thank you very much.
Thank you, esteemed representatives, for your inspiring words, continued partnership, and invaluable support. Your presence truly enriches Urocon 2026 and strengthens the spirit of international collaboration and friendship. Ladies and gentlemen, NAUS takes great pride in recognizing residents who have received various awards and honors over the past year. Their dedication, hard work, and achievement represents the promising future of urology in Nepal. So we will now have a special photo presentation in recognition of their accomplishments. And to proceed with this, I would like to invite Dr. Suman Chapagai to present the photo display. Thank you.
Thank you. So the residents are the foundation of the future urologists and the urological health here. So our society gives a best resident paper award. So for the 2025, the first award went to Dr. Nishchal Shrestha. The second awardee was Dr. Amit Jha. And third awardee is Dr. Rishabh Sharma. Congratulations to our residents for getting this award. Thank you so much.
Thank you, sir. And ladies and gentlemen, let us again appreciate and congratulate our residents with a warm round of applause, ladies and gentlemen. All right, it is now a great honor and privilege for us to hear from our esteemed chief guest, whose distinguished leadership and remarkable contribution to medical education and healthcare have been truly inspiring. So I would like to invite our esteemed chief guest, Professor Dr. Bharat Khatri, to kindly deliver his message. So ladies and gentlemen, please join me in welcoming him with a huge round of applause.
सबैजनालाई नमस्कार। यस युरोकनको अर्गनाइजिङ कमिटीको चेयरम्यान, मेरो साथी पारस र लोकल चेयरम्यान र सेक्रेटरीहरू, विभिन्न देशहरूबाट पाल्नुभएको पाहुनाहरू, हाम्रो नेपालमै रहनुभएको विभिन्न ठाउँबाट पाल्नुभएको युरोलोजिस्टहरू र स्वास्थ्यसँग सम्बन्धित सबै विद्वत वर्गहरू, यहाँहरू सबैलाई पोखरामा स्वागत गर्न चाहन्छु। सर्वप्रथम त नेपालको युरोलोजिस्टहरूलाई धेरै धेरै बधाई तथा धन्यवाद ज्ञापन गर्न चाहन्छु, किनकि यहाँले पोखरा, विच इज द बेस्ट प्लेस इन द वर्ल्ड, आई से सबैभन्दा राम्रो सहरलाई छानेर जुन युरोकन गर्नुभएको छ, यहाँहरूलाई बधाई पनि दिन चाहन्छु र धन्यवाद पनि दिन चाहन्छु। आशा छ पक्कै पनि यहाँहरूको हस्पिटालिटीले, हाम्रो इन्टरनेसनल गेस्टहरूले राम्रो इन्जोय गरिराख्नु भएको छ भन्ने आशा लिएको छु। खास गरी हामी तीनवटा कुरालाई फोकस गर्छौँ। 3, एउटा ट्रिटमेन्ट पार्ट हो, अर्को एजुकेसनको पार्ट हो, हेल्थ एजुकेसनको पार्ट हो, र अर्को रिसर्चको पार्ट हो। अहिले यहाँहरूले प्रेजेन्ट गरेको पेपरहरू हेर्दा, यहाँहरूको स्पिचहरू सुन्दा हेल्थ केयर पार्टलाई निकै राम्रो गरिराख्नु भएको सुनिन्छ। तर म के भन्न चाहन्छु भनेदेखि इट सुड बी पेसेन्ट सेन्टर। हामीले जति राम्रो गरे पनि, जे गरे पनि, जसो गरे पनि, इफ द पेसेन्ट डजन्ट फिल बेटर, इट्स युजलेस। सो बी पेसेन्ट सेन्टर। अर्को कुरा म के भन्न चाहन्छु भन्दाखेरि यदि म पेसेन्ट भएँ भने कि मैले के चाहन्छु, वाट आई वान्ट फ्रम द डक्टर भने तपाईँले पहिला आफूले आफूलाई सोध्नुहोस्। त्यसपछि मात्रै तपाईँले आफूलाई जे आफूले चाहनुहुन्छ त्यही पेसेन्टलाई दिन सक्नुहुन्छ। वी आर डक्टर्स एज वेल एज पेसेन्ट्स। त्यही भएर फर्स्ट अफ अल थिङ्क एबाउट द पेसेन्ट, बी द पेसेन्ट सेन्टर। त्यसो भन्नुभयो भने, त्यसो गर्न सक्नुभयो भनेदेखि यु विल बी अ रिनाउन्ड युरोलोजिस्ट। किनकि सबै पेसेन्टले प्रेज गर्ने हो नि त, युरोलोजिस्टले त आफ्नो कलिगलाई कसले प्रेज गर्छ, त्यति धेरै प्रेज गर्दैन नि। प्रेज गर्ने कसले? त्यही जसले ट्रिटमेन्ट गर्न आयो उनीहरूले नै प्रेज गर्ने हो। सो बी फ्रेन्डली विथ देम, आस्क देम वाट दे वान्ट। त्यसपछि होलिस्टिक एप्रोचबाट उहाँलाई सोध्नुहोस्, नट युरोलोजिकल। अहिले त त्यस्तै छ नि, होलिस्टिक एप्रोचबाट सोधेन भनेदेखि युरोलोजीको मात्रै उपचार गऱ्यो भनेदेखि सायद अब साइकोलोजिकल्ली धेरै सोसियल्ली हि मे नट फिल बेटर। त्यही भएर होलिस्टिक एप्रोचबाट युरोलोजीको पार्ट पनि ट्रिटमेन्ट गरिदिन सक्नु भएको छ। अहिले अब सरले प्रेजेन्ट गर्नुभयो, रोबोटिक ट्रिटमेन्ट उपचार पनि सुरु गरिसक्नु भएको छ। अब इन्डोस्कोपी त धेरै पुरानो भइसक्यो होइन, यहाँले राम्रो गर्दै गर्नुभएको छ, त्यसको लागि धेरै धेरै धन्यवाद दिन चाहन्छु। अर्को कुरा एजुकेसनको कुरा, हामीले खालि ब्ल्याङ्केट पोलिसी लिन्छौँ, मास एजुकेसन युज गरिरहेको छौँ। इज द्याट युजफुल? सबैले थिङ्क गर्नुपर्ने। त्यही भएर एजुकेसन अब स्टुडेन्ट सेन्टर हुनुपर्छ। स्टुडेन्टलाई यही मास एजुकेसन लेक्चरको सिस्टमले पढाएर बुझ्नुहुन्छ कि हुँदैन? हुन त सबैभन्दा राम्रो टिचरले पढाउनु भयो, तर स्टुडेन्ट कसैले पनि बुझेन। इज द्याट वर्किङ? इट्स युजलेस। जब तपाईँको टार्गेटले बुझ्दैन भनेदेखि जति राम्रो पढायो भने, जति राम्रो टिचर भयो भने इट डजन्ट वर्क, डजन्ट म्याटर। त्यही भएर हामीले सायद एजुकेसन पोलिसी पनि चेन्ज गर्नुपर्ने हो कि फर्स्ट अफ अल वी हेभ टु इभ्यालुएट द स्टुडेन्ट्स, वाट सर्ट अफ टिचिङ दे लाइक, वाट सर्ट अफ ट्रेनिङ दे लाइक, देन वी हेभ टु फिगर आउट आवर करिकुलम एन्ड द टिचिङ आइडियाज। त्यसो गऱ्यौँ भने मात्रै हामी बल्ल स्टुडेन्टलाई राम्रोसँग चाहिँ ट्रेनिङ गर्न सक्छौँ कि भनेर भन्न चाहन्छु। त्यसपछि अर्को रिसर्चको पार्ट हो। साँच्चै नेपालमा हामी त सरले अघि 20वटा पेपर निकाल्छु भन्नुभयो, एउटा बिएनबीबाट मात्रै हुन्छ, नेपालबाट केही भयो भने 20,200 पेपर त निस्केलान् युरोलोजीको होइन, अथवा त्योभन्दा बढी निस्केलान्। त्यो पेपर सोसाइटीको लागि कतिको युजफुल छ त? इज इट ओन्ली रिसर्च फर रिसर्च कि स्टुडेन्टलाई पिजी पास गर्नको लागि, एमसिएस पास गर्नको लागि रिसर्च हो कि स्टडी हो कि इज इट रियली फ्रुटफुल टु द सोसाइटी? जबसम्म हामीले सोसाइटीले के चाहन्छ, लोकालिटीले के चाहन्छ, देशले के चाहन्छ त्यसलाई फोकस गरेर रिसर्च गर्दैन भनेदेखि इट्स जस्ट वेस्ट अफ म्यान पावर, वेस्ट अफ मनी एन्ड वेस्ट अफ टाइम। सो थिङ्क अन द्याट। त्यसरी गयो भनेदेखि हामी अलि अगाडि बढ्न सक्छौँ कि जस्तो लाग्छ। र अहिले पेपरहरू थुप्रै तपाईँहरूले प्रेजेन्ट गर्नुभयो होला होइन, कहिले अमेरिकाको इक्जाम्पल दिन्छु, कहिले युरोपको इक्जाम्पल दिन्छौँ, कहिले अस्ट्रेलियाको इक्जाम्पल दिन्छौँ। अब हाम्रो इक्जाम्पल दिने अब तपाईँहरूले प्रयास गर्नुपर्छ। नेपालमा यो स्टडी भएको थियो, यसले यो भनेको थियो, यो फोरममा जबसम्म त्यहाँ हामी त्यो प्रेजेन्ट गर्न सक्दैनौँ, अमेरिका र अस्ट्रेलियाको युरोपको चाहिँ अथवा अहिलेलाई भनौँ सबभन्दा नजिक इन्डिया छ, अरूको चाहिँ डाटा लिएर आएर हामीले प्रेजेन्ट गर्छौँ भनेदेखि हुन त देयर आर लट्स अफ सिमिलरिटिज, तर इज द्याट सिचुएसन फिट्स टु आवर सोसाइटी, फिट्स टु आवर पिपुल, फिट्स टु अस? सो वी हेभ टु वर्क अन द्याट। यदि तिनवटा कुरामा हामीले गऱ्यौँ भनेदेखि साँच्चै हामीले भने जस्तो बल्ल स्वास्थ्य प्रक्रिया हुन्छ कि? अहिले हामीले भने जस्तो भएन भनेर बाहिर आवाज उठिरहेछ नि, भोलि सबै मेडिकल फ्राटर्निटीले पनि हामीले भने जस्तो भएन भनेर यस्तै गरेर फेरि समस्या आउन सक्छ। त्यही भएर अहिले नै हामीले सोच्यौँ भनेदेखि पक्कै पनि हामी राइट डिरेक्सनमा जान्छौँ। र यहाँहरू जहाँ पोखरा आउनुभएको छ यहाँको बसाइ चाहिँ एकदम राम्रो होस् र सबैजनाले जुन नलेज सेयर गर्नुभएको छ त्यो नलेज चाहिँ राइट ठाउँमा युज होस्, तपाईँहरूको चाहिँ उत्तरको प्रगति होस्। र यो जुन युरोकन यहाँ सञ्चालन गर्नुभएको छ, थर्ड टाइम भन्दै हुन्थ्यो डाक्टर ध्रुवले, उहाँ पनि मेरो साथी, डाक्टर परास त मेरो क्लासमेट है, ब्याचमेट, रुममेट सबै हो, हामी सँगै थियौँ है। हाम्रो उसको बानी मलाई थाहा छ, मेरो बानी उसलाई थाहा छ। अहिले ऊ अध्यक्ष भएको बेला म यता बिसी भएर यहाँ तपाईँहरूको अगाडि एउटा गेस्टको रूपमा आउनु पाउँदा एकदम खुसी लागेको छ र यहाँलाई त्यसको लागि पनि धेरै धेरै धन्यवाद दिन चाहन्छु। र यो जुन तपाईँहरूको युरोकन छ यसको एकदम भव्य सफलताको कामना गर्न चाहन्छु। ओके, जय युरोकन, नमस्कार।
Thank you, sir, for your warm and inspiring words. And now, ladies and gentlemen, we are almost to the end of our formal segment. So to conclude the formal segment, I would now like to invite the General Secretary of NAUS, Dr. Suman Chapagai, to deliver the vote of thanks. And ladies and gentlemen, let's once again welcome him with a huge round of applause.
Honorable Chief Guest, Professor Bharat Khatri, Vice Chancellor of POKHARA Academy of Health Sciences, respected President of the Nepal Association of Urological Surgeons, my esteemed past presidents, distinguished dignitaries on the dais, representatives from international societies, respected international and national faculties, dear delegates, colleagues and friends, ladies and gentlemen, good evening. This is my privilege and honor as the organizing secretary of the Urocon 2026 POKHARA, Conference of Nepal Association of Urological Association, to stand before you to propose the vote of thanks. First and foremost, on behalf of the entire executive committee and all the members of NAUS, I extend our deepest gratitude to our honorable chief guest, Professor Bharat Khatri. Sir, your presence here today as the Vice Chancellor of POKHARA Academy of Health Sciences has made us give us the inspiration and a guiding light for us as we navigate the future of urological care and education in Nepal. We are deeply grateful that you took time from your busy schedule to be with us. We owe a great deal of gratitude to our past presidents as advisors. Your foresight and the strong foundation you built for this association are what allow us to stand here today. Thank you for your constant mentorship and support. To our international faculties who have traveled across borders to be here, thank you. And you have raised the academic bar of this conference. The exchange of knowledge, the discussions, and your willingness to share your expertise will have a lasting impact. We hope you carry back fond memories of POKHARA, Nepal, and Nepalese hospitality. Our national faculties, thank you for sharing your experiences and for the immense effort you put to the scientific sessions. Your participation is important for the success of the conference. A conference is nothing without its participants. So all the distinguished delegates, both national and international, nurses, paramedics, technicians, and all other associated people, thank you for your active participation in the conference. I would like to thank our scientific committee, led by Dr. Anil Shrestha, and the whole organizing team, the local organizing team, led by Dr. Our Dhruva sir. And so I thank you. I thank everybody for running every session smoothly, and every working microphones, every timely tea break, and the hours of unseen labor, and all to the volunteers and supportive staffs. Thank you so much. Lastly, the vote of thanks would not be complete without thanking our sponsors. Without their support, we cannot run together. So your support not only makes these academics gatherings financially feasible, but also allows us to witness the technological advancements. Thank you very much. So ladies and gentlemen, as we conclude, let us remember that the true success of this conference will be measured not in these few days, but in the improved quality of life we provide to our patients in the times ahead, using the knowledge we have gained here. So if I have missed someone or missed anyone who contributed to this success, please forgive my oversight and accept my gratitude. Thank you all for your presence, your participation, and your contributions. We wish you a safe journey home. Thank you very much.
Thank you, sir, for your warm words. Ladies and gentlemen, we will now proceed with the felicitation of trade delegates, followed by the official photo session. So may I respectfully request all present executive members on the dais for photo session. All right, it's time for the felicitation of our major sponsors. So I'd like to invite on stage Labline Traders Private Limited. Any representative from Labline Traders Private Limited, I would like to request to please come on the stage and receive this token of appreciation. And now I'd like to invite on stage Cipla Limited. So I'd like to request the representative from Cipla Limited to please come on the stage and receive the certificate of appreciation. Now, I would like to invite the representative of Asian Pharmaceuticals Private Limited to please receive the certificate of appreciation. And now, let me invite on stage all right, ladies and gentlemen, now let me invite on stage Alliance Healthcare Technologies and Services Private Limited to receive the certificate of appreciation. So ladies and gentlemen, they are our major sponsors and a huge contributor to this Urocon 2026 inaugural ceremony. So let's applaud them for their effort. All right, now it's time for the felicitation is already done and it's time for the photo session. So may I now respectfully request the present executive members on the dais for photo session. As these moments are worth to be captured. Now let me invite on stage all the local organizing committee members on the dais for photo session. Now, I'd like to invite on stage all past presidents and past executive members on the dais for photo session. And lastly, I'd like to call on the stage all NOW's international guests on the dais, on the stage for the photo session. when we'll not just present performances, but we will present our heritage, our diversity, and the vibrant spirit of our community. So we will shortly begin the cultural program.
शक्ति हस्ता भयानकी त्रिनेत्रा यौवनाङ्गी च नमामि शिखि वाहिनी त्रिनेत्रा यौवनाङ्गी च नमामि शिखि वाहिनी
Wow.
सीमे भूमे वराह देवता तिम्रै शरण पूर्वै दिशाको सीमे भूमे वराह देवता तिम्रै शरण पश्चिमै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा पश्चिमै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा उत्तरै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा उत्तरै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा दक्षिणै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा दक्षिणै दिशाको सीमे भूमे वराह देवता तिम्रै शरणा कालो र बादला हो पूर्वै र दिशा कालो र बादला चम चम चमकिला बिजुली चम चम चमकिला बिजुली जतामा होला मरिदको भेष उतै गरजेला मेरा जतामा होला मरिदको भेष उतै गरजेला मेरा कालो र बादला हो पश्चिमै दिशा कालो र बादला चम चम चमकिला बिजुली चम चम चमकिला बिजुली जतामा होला मरिदको भेष उतै गरजेला मेघ जतामा होला मरिदको भेष उतै गरजेला मेघ जान्छु स्वामीको साथ बसेमैतिर जय म त 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 जान्छु स्वामीको साथ।
But before that, I just want to ask you, isn't it beautiful how our folk dances tell stories without even through words, through single words? Isn't it interesting? Because this dance forms tells stories, tells heritage through expressions, rhythm, and movement. And we can share our entire history come live on this stage again. So dear audience, Nepal is truly a garden of cultures, and now we are about to travel towards the vibrant Tamang heritage. Keeping that spirit alive, we move to a community known for its rich music, rhythmic beats, and powerful cultural identity. So ladies and gentlemen, are you all ready for the next performance or not? All right, so our next performance is a lively Tamang dance called Tungi dance, representing the rich culture and musical tradition of the Tamang community. And our performers are, it's mentioned Nitu A and Nitu B, so I'm going to pronounce in the same way because there are two Nitus, and Komal, Kavita, Sanjay, and Ayush. So ladies and gentlemen, let's encourage them by giving a warm round of applause, ladies and gentlemen, for our performers.
Somindo kar kar ahina ngama ngama khao yala somindo kar kar ahina ngama ngama khao. Tungna bazaunday domphuma selo git gaunday turlunge tungna bazaunday domphuma selo git gaunday sirkini marday raton sirkini marday raton yo mana pridlaunday yo mana pridlaunday shao shao Khao प्रितलाउँदै त्यो मन यो मन प्रितलाउँदै
छेउ आउने जिउ गर्ने भन्नेको थरी न्यु पर्ने जङ्गको के नहोला अर्काको छोरीको मन चढ्ने अर्काको छोरीको मन चढ्ने
खाउ खाउ जङ्ग खाउ खाउ जङ्ग बल नम नम खाउ खाउ
खाउ खाउ जङ्ग खाउ खाउ मै जङ्ग नम नम खाउ खाउ
खाउ खाउ मै जङ्ग खाउ खाउ जङ्ग बल नम नम खाउ खाउ
Personal favorite, and even I was enjoying there as you all were. So this is not just the end. We have some exciting performances. So are you ready for those performances or not, audience? Can I hear some cheers right now? All right. With this, up next, we have a special presentation titled 16 Years Old. Actually, that's called Sora Barsiya Chori. But it's performed in the traditional Kora dance style. So, taking the stage, we have wonderful performers once again. So, let's welcome them warmly on the stage as they are going to grace the stage with their beautiful and gracious performance, ladies and gentlemen.
भयो तन्नेरी किन नानी नबोलेको जोबान दिँदाखेरि मैलुरे नि भयो तन्नेरी मैलुरे नि भयो तन्नेरी
All right, that was definitely a graceful performance by our performers, and with this, we officially conclude our cultural program. And before we conclude it, I believe we should sincerely appreciate Himali cultural family, the performers, their dance coordinator, Mr. Yuvraj Gurung, the assistant dance coordinator, Ms. Sangeeta Ali, because your dedication and hard work made today's cultural program possible and so beautiful. So ladies and gentlemen, let's conclude this cultural event by applauding the wonderful performance of our performers.